I would like to start the first session and invite the chairperson, Dr. Sachin Handa and Dr. Kunal Nigam, to chair the first session.
Good morning, everyone. So we have the first speaker is Dr. A.V. Ramesh, who's a very eminent and decorated ENT specialist and well-known, and head of the implant program at the Army Hospital R&R for 5 years. And he's been a PG teacher and examiner for Delhi University, KGMU Lucknow, and DOE for the last 10 years. And he's been awarded the prestigious Vishisht Seva Medal to Ramesh in 2020. He's right now working as a senior consultant at BLK Max Super Specialty Hospital. So we would like to invite him to deliver his talk on diagnostic endoscopy. So let's look forward to his talk. Thank you.
World Cup for the Indian team. So starting off conferences and lectures is also sometimes there are a lot of hiccups. So we will be talking about diagnostic endoscopy as a start to how do we go about dealing with various problems of voice and swallowing. Whenever a patient a change in voice or a swallowing problem, it could be a simple sore throat, maybe a foreign body sensation in the throat, a change in voice, uh, all those things. Examination of the larynx and the hypopharynx. There are many methods of examining the larynx and the hypopharynx, from indirect laryngoscopy and direct laryngoscopy by way of rigid endoscopes or a flexible endoscopes. Then some kind of a functional examination to see how the vocal cords are functioning by way of stroboscopy, NBI, or a research tool which is a high-speed video laryngoscopy. This is say a lot. You can start understanding what is the normal anatomy of the larynx, but the illumination is often limited to the kind of a light that you are using, and it's a reflected light, so often not very good, and certainly not do any recording out of this. And with the onset of COVID, we are not sure whether today or not. What do we require to do a laryngeal endoscopy? For a laryngeal endoscopy, we require a stack, which is quite common. Lab, speech lab, you would require a stroboscope and a NBI generator. So the commonest examination that is done is a direct rigid laryngoscopy. This is done by using a rigid laryngoscope. This particular scope is usually 8 millimeters in diameter. Angulation of 70 degrees or 90 degrees based on what you are comfortable with. It allows you to examine the larynx very well, and it gives you a very good image. And generally the patient is made to sit in a sniffing position, a slightly forward neck, as is held out with a gauze, and a laryngoscope is passed on the tongue. We cross the soft palate and the base of tongue, and we start looking into the larynx. Some of the patients might how does it? This is what it would look like. You're going along the base. You see the base of tongue. And then you see the larynx. And a little pathology, contact ulcer on the arytenoid. Next is a flexible laryngoscope. These flexible laryngoscopes are generally introduced through the nose. They are varying in sizes from 2 millimeters to 4 millimeters. They are much smaller than the rigid laryngoscopes. The advantage of these flexible laryngoscopes is the patient is sitting in an anatomical position and the larynx functions in a physiological manner, unlike the rigid where you hold the tongue and pull it forward. So that is not really a very physiological way, and patient can cough, speak. Introducing the laryngoscope through the nose, you check which nostril is convenient and roomy enough. A little lubrication with a lignocaine jelly is all that is required. You go through the nose, you see the cross the uvula, base of tongue, epiglottis, and the larynx is there in front of you. Most patients accept this particular scopy very easily, much better than a rigid endoscopy. And when you have when you do this endoscopy, what all things that you might see, mostly they might be normal, or you might find a little laryngopharyngeal reflux, a little congested arytenoids, but more likely that you will find sometimes a hemorrhagic polyp on the vocal cord, or there could be a plaque. There could be growths. There could be multiple growths like a laryngeal papilloma that you see here, or there could be a ulceroproliferative growth on the vocal cords. You might see a sulcus, or you could see a vocal cord paralysis. What you can also do with this laryngoscopy is that you can do follow-up, post-op follow-up. You can see it, the same laryngeal papilloma operated. This is the first post-op day, and you can see the same thing on the 30th day, 1 month after the surgery. It's not moving. Go to the next slide. Once you have seen the larynx, you can do more. You can cross the vocal cords. All you need to do, most of these laryngoscopes have instrument channels through which you can put a biopsy forceps. You can put lignocaine, 4% topical lignocaine. So you can anesthetize the supraglottis and the vocal cords. You can go cross the vocal cords, and you can go into the subglottis and the trachea bronchial tree with the same endoscope. Go to my presentation, please. Just go down. The only thing that you need to be careful when you're instilling some 4% lignocaine into the instrument channel is most often you need to shut off the suctions. So if you don't shut off the suction, the 4% doesn't go across into the larynx. And once the vocal cords are nice and the supraglottis is nicely anesthetized with the 4% lignocaine, then you can take a biopsy. This is the biopsy forceps going in, and under direct vision you can take biopsies avoiding a general anesthesia. You can go beyond the larynx also. Once the larynx is nicely anesthetized, you can go into the subglottis and the trachea, and you can observe the abnormalities that are there. Here you can do injection laryngoplasty also. These are procedures that you can do after under endoscopic control. Often the question comes, which is preferable? It's a question of personal choices very often, and sometimes the patient variable comes into play. A rigid endoscope is rigid and a flexible one is flexible. Rigid one goes through the oral cavity, whereas the flexible goes through the nasal cavity. This is of use in unconscious patients or who are uncooperative for an oral examination. Gag reflex is a major problem with rigid, whereas there is no such issue with flexible. The advantage of rigid is you can connect high definition cameras, etc. to it and get much better pictures. Now the flexible scopes have come up with chip on tip cameras, which improve the quality of the pictures that you can record. The image size is much larger and the resolution is far better with a rigid scope, because the fiber optics are 8 millimeters in size, whereas the flexible scopes are 2 to 4 millimeters only in size. So it gives you a much better picture. What you can make the person say is just vowels in a rigid, whereas with a flexible you can make the person speak, cough, swallow, anything during the endoscopy. Then we come to the functional assessment of the larynx. The commonest thing that most people do is a stroboscopic examination. We've all been to discos where there is a light generator which flashes light. The same kind of a principle is used in stroboscopy. What it does is, since the vocal cords move at a very great speed and you cannot observe it with naked eye, it gives you flashes of light at a particular interval, and what you are seeing is the oscillations of the vocal cord at slightly different time zones. So with the result, what happens is that you kind of slow down the speed of the vocal vibrations, and if the frequency of this strobe matches that of the vocal frequency of the individual, it almost kind of freezes. You can freeze it, you can see it in a slower motion, and you can observe the abnormalities far better. So what you are actually seeing is the vocal folds in different oscillations. It's not the same oscillation, they are different oscillations, but at different times of the cycle. So you see it as if they are progressively, the vocal fold is vibrating progressively, but it is at a much slower pace. What it allows you to do is study the vocal fold vibratory dynamics and how does the vocal cords close the glottis, the glottal closure. This is how a normal stroboscopy picture of a larynx would look like. So this has been slowed down. It is far slower than the natural vibrations of the vocal cord. The same thing, if you have an abnormality, like on nodules are, small nodules are present, you can see how the glottis closes or does not close at various places and what are the abnormalities of the vocal fold function. Then we come to another way of assessing the vocal folds and the glottis. This is known as narrowband imaging. It's a kind of a biological endoscopy, because the other question that comes into our mind is what part of the mucosa is normal and what part is abnormal. So to identify what is normal and what is abnormal, we use what is known as a narrowband imaging. Here the light spectrum is concentrated onto just the blue light, and this is better absorbed by the hemoglobin and gives you a different characteristic to the mucosa, the submucosa and the vasculature that is present in the submucosa. So this helps in highlighting the vascularity, and that helps generally all neoplastic lesions would have a higher vascularity. So this is what it highlights. So the subtle changes in the microvasculature can be identified easily, and this can help us identify as to what area would you like to take a biopsy from. So if you have a growth here, this is what it would look like in a natural normal white light. But when you switch on the NBI, you can see a totally different picture. You can see it highlighted, and that helps you in identifying it and taking a good biopsy. Next, we come to another way of assessing the vocal fold functions. In the stroboscope, what we saw was we were slowing down the pace and we were taking pictures, or we were observing the different phases of different oscillations. Here, what we are trying to do is, by using high-speed cameras, we are trying to take many pictures of the same single cycle. The cycles are not different. So this helps us study the pattern of vocal fold movements far better than stroboscopy of a single cycle. So a high-speed camera is what is required. Generally, whatever is the vocal fold vibration rate, the F0, you need to go almost about 16 times that particular rate to be able to get all the pictures of a single cycle. This is what a video kymograph would look like. Currently, this is a 2D picture that we are taking. At a single plane, the pictures are taken, so it does not give you a depth perception. But at that particular plane, it gives you a complete picture of each one of these 8,000 images are stacked one over the other like this and put into a frame. Then you can easily identify the various abnormalities that would be there on the vocal cords. Currently, it is still a research tool which very few people have this kind of an equipment. From 1996, it has undergone many changes. A lot of new features have been added to this, but it is essentially what they consider it is as a complementary to strobe. The advantage of video chymography is if you have irregular vibratory patterns, then the strobe doesn't work very well because it takes different cycles. The advantage of chymograph is it's a single cycle. So even if the vibratory pattern is irregular, it will pick up one cycle each. So that is the basic advantage of a video chymograph. There is a lot of effort on to get the depth perception and get it into a 3D mode. Once that comes, I suppose the utility of video chymograph will go up tremendously. And the speeds of cameras and the resolution from 1996 to date has undergone a great change, and we are getting much better resolution in video chymographies. I think that is a starter to the whole workshop and the conference. I think the successive speakers are going to tell you a lot more about each one of these and how to utilize them in specific conditions. This is just a primer. Thank you.
Thank you, Dr. Ramesh, for a very exhaustive and wonderful talk on endoscopy of the larynx. And I would like to ask any audience if they have any queries or questions regarding endoscopies, the diagnostic endoscopies of the larynx. They can go ahead and ask Dr. Ramesh.
Most people in the audience are, frankly speaking, better laryngologists than me.
I think it's so exhaustive that they have no questions.
Thank you.
Thank you, sir.
I would like to call the chairpersons on the stage to please felicitate sir for this.
The next speaker here is Dr. Has been a wonderful friend for the last decade or so, and he's a very eminent does and he does what he talks, and he's been a consultant ENT head and neck surgeon in Artemis Hospital for a long time, and he does pediatric airways reconstructions, and his clinical interests include airway reconstruction, treating swallowing disorders, sleep apnea surgeries, and general ENT to go along with it. I would like to invite him to give a talk on his favorite topic of narrowband imaging.
Thank you so much, Dr. Sachin. I would like to take opportunity to thank Dr. Sachin Gandhi and Dr. Ramalingam for giving this wonderful opportunity to speak on LVA platform. And LVA has made leaps and bounds of progress in last few years, and the community is just increasing day by day. It's so heartening to see that we have such a wide participation. And I want to make my little contribution to this because we bought a little tool called narrowband imaging few years back before the COVID, and we didn't really understand. And it was told to us it's a good cancer screening tool. But over the years, it has gone so many adaptations into new areas that now we feel that we can't even work in OPD without narrowband imaging. It's so exciting that it would almost appear like I'm trying to sell this, but no. is the technology which is useful, and what is it doing is just helping you to see the blood vessels clear. Okay, let me just see if things work. Yeah, so everything is dependent on what you take, you give it back. So the principle is simple. When you see with a white light, you see everything, but instead of seeing with a white light, just use two spectrums, blue and green. Blue is for capillaries, the green is for veins. So hemoglobin loves blue and green, so it absorbs it, and once it absorbs it, it also reflects it back, and that's what the NBI technology really sells off. That if you want to see blood vessels, either mucosal or submucosal, it's a great tool. Uh, so coming to the outset, so this was a 3D rendering of the blood vessels, which was done on PET scan. Uh, the first picture here, okay. Let me just go back. The first picture here is a normal vasculature where you have straight blood vessels going in, very mild deviations in everything. So this is a dysplastic picture where the blood vessels inside the tongue, they start going little haphazard, but more haphazard near the surface. That's where they really go bonkers. And this is frank malignancy where they kind of concentrate into big three loops, and then they go up, and then they have a dysplastic pattern. So the vasculature, what we can study here is all marked in green. So below green, whatever you see, you can't pick it on NBI. So it can only be done really by endoscopes which are very close to the mucosa, almost as close as 3 mm. So in oral cavity, you'll have to use a rigid scope unless you want your expensive scope to be bitten by the patient. There shouldn't be no misting. Saliva and blood are the biggest enemies of NBI. There's no way you can do it if there's a lot of drooling and blood inside the field. And usually it gives a anteroposterior view. So if you really have to uh, do an NBI in a funnel sort of a cavity, which is like a tubular structure funnel, your scope has to go straight and tilt 90-degree towards the mucosa. If you're seeing like this, you won't get the NBI picture. But if you're tilting the scope, which is right perpendicular to the vessel, then only you get the good loops. So this is the fundamental of NBI. Now, really, the patterns have been very well taken from the gastro people, and they made this classification. And there are 5 types of lesions, starting from benign to type 2, type 3, type 4. But what you can see is in the benign lesions, these blood vessels, they are starting thin, then they get thicker, then they start getting breaks because of leukoplakia. So leukoplakia decreases the permeability of the light. It's like an umbrella effect. So you'll see this leukoplakic area will be delineated, but you won't see blood vessels under it, and some blood vessels coming over this. And then these thick dots are the ones where the dysplasia has really started. And once the dysplasia increases, they find the word which is used is intraepithelial papillary capillary loops, or ICPLs. And if you see ICPLs, you're fairly confident, more than studies quote 90 to 99% that this is a malignancy. And the whole trick is about finding the ICPLs inside your images. Just to give you some examples, this is how you see a normal in white light, but once you put an NBI, you can actually see the blood vessels. Okay. So for benign lesions, if you want to diagnose a vocal cord cyst, a leukoplakia, or a hypertrophic lesions, this is excellent. So examples of a type 2 pattern. So this is a thick vessel. This is the umbrella effect which I'm trying to tell, because blood vessels come here, then there are breaks here and go away. And this is a type 4 pattern where you can see thick dots here. On the routine light, it just appears little more hyperemic. And this is where dysplasia and ICPLs, they just start appearing. And this helps you to actually take a biopsy from the most representative site when you're doing a imaging. And this is a 5B pattern, which is almost diagnostic of a malignancy. Now, certain benign lesions like papilloma uh, of larynx, you can actually see the loops which are there. They're very similar to ICPLs, but when you see the root of the growth, you don't get increased vasculature here. But in a malignancy, you'll have these loops, but at the root of the lesion, the blood vessel, it goes crazy here. So this is one way to actually see a papilloma, and you want to differentiate it from malignancy. You can pretty much do it confidently on an NBI. Then Rinkin's edema, actually, you see a big lesion like this, which can look like, sarcoidosis or some malignancy going on underneath. But when you see an NBI, it doesn't have much of vascularity at all. It is all water inside. So yeah, so that's a very helpful tool. And vocal cord cyst actually delineate very nicely on NBI. So that confusion, if it's a nodule or a polyp or a cyst, works very well when you have an NBI. Now, there are few things which can actually, they are benign, but they'll mimic malignancy, and tuberculosis was one of those things. And we were developing AI algorithm to actually diagnose NBI on the pictures. Dr. Rakesh Srivastava was pioneering this project, and a lot of the AI algorithms were picking up tuberculosis as malignancy. Uh, so post-radiation larynx and tuberculosis larynx, their vascular pattern can actually mimic a malignancy, so you need to be careful. So that's one of the things NBI can mislead you. Now, the other places it is very difficult to interpret as areas near the gums and teeth. So tar is also one of the things like hemoglobin, which will take a lot of absorption of green and blue light, and then they request. So there's a lot of people, it is just a simple tar, but it may come as malignancy or post-surgery, because there's a lot of neovascularization. That also mimics malignancy, or there's a candida infection that can cause difficult interpretation. And severe reflux, even that is one of the problems with NBI. But once you have done enough endoscopies, you would actually differentiate them. And if the lesion is very keratotic, like a varicose carcinoma, you can actually miss. So that can happen in squamous cell carcinoma or even in sarcomas, where the blood vessels are not ulceroproliferative typically. You can make mistakes with narrowband imaging. So what are the new uses we have started NBI? And this is very useful for epistaxis. So this patient had epistaxis for 4 years, had the autoimmune workup, but he would have gone 13 times cauterization, and every time it would come in the same place or somewhere very close to that lesion. So when we did NBI, we actually saw that the vascularization is actually coming right from the roof of the septum, and that's what we had to block it. So what we did is we raised the flap, cauterized this plate, and put a temporalis fascia graft, and then it never bled again. So these are the few things you can use it in routine use with NBI. Now we did a thesis for our DNB candidate on adenoids and NBI. So the really vascular adenoids which you see in the proliferative phase between 3 to 4 years in a child, which responds to topical intranasal steroids, you can pick up those adenoids on the NBI. Whereas in mature adenoids, which you see in adults about 10 to 12 years or 14 years or 15 years, their vascular pattern is different. They have less of vasculature. So you can actually predict he may actually respond to a medical treatment. The other ones would actually, you can advise surgery upfront. So we are yet to publish the results, but I can quite confidently say, it's got a really good role in deciding the medical treatment for adenoids in kids. And in one go, when you do an NBI scopy in a child, instead of an X-ray, you can see so many coexisting pathologies like sinusitis, allergies, reflux, and polyps. All those things can be picked up, and they're not coming to you as a surprise during the operating room, or you have a bad posterior deviation, and your adenoids have been removed, but you may still have some breathing problems. So that problem is sorted out, and the images are so beautiful that even for insurance purposes and other things, they're very well accepted. So we kind of do X-ray only once, but the progress of the adenoids, the kid is improving or not, we just see with the NBI, because we can pick up so many co-founding factors which are contributing to the problem. So this is just an example of one of the kids where, it's a routine case of adenoid hypertrophy, but you can see so many changes here, lingual hypertrophy, cobblestone appearance of the pharynx, PND, everything. So when you try to treat these kids, the usual 2 or 3 medication will change to 6 or 7, because now you're trying to treat the coexisting sinusitis, reflux, all those. So, and even give a short course of oral steroids, but the response is much better than the standard treatment. So this thesis was about, when you use the NBI, the average cost of medicines which you give for a routine adenoid patient was 600, and after NBI it became 1700. It was a much more expensive, because you're seeing a lot of things, but at the same time, the response to the treatment was 3 times better when we using NBI to treat our kids with adenoids. That's one of the take-home lessons here. Now, during the surgery, you can also use it to, see the tumor margins much better. You can just say if it's going to the anterior commissure or going to the contralateral vocal cord, which sometimes can be missed during a routine laryngoscopy. So, there are so many studies that, margins change when you use NBI during the surgery. We also use this, but we use a different technology by stores called Chroma A and Chroma B, which is very similar to NBI for intraoperative excisions of the tumor margins. And most of the times the tumor can upstage when you put an MBI. Like here, the other cord almost look normal, but it's a bilateral vocal cord lesion. So it has some advantages of PET-CT, because the minimum tumor volume to pick up in PET-CT would be 5 millimeters, and if the lesions are smaller than that, PET-CT can miss it. So endoscopy actually shows you much better. In our routine practice, all the patients who undergo radiation therapy at our institute, they would be followed up with NBI rather than actually PET-CT, and PET-CT is usually done at 6 months or later, rather than the previous protocol where the PET-CT was usually being done at 3 months. And the biggest confusion is whenever there is something left after the treatment, is it a recurrence, or is it a fibrosis, or is it post-op change? And NBI is extremely useful to pick on those things for your post-surgery patients in routine follow-up. Laser granulomas, which come very frequently, but when the patient sees a lesion there, they are very apprehensive. So NBI can actually, reassure them that, it's not a tumor recurrence, but a laser granuloma, which is occurring after 2 to 3 weeks or 4 weeks after the surgery. So this is another study which kind of shows narrowband imaging in high def in laryngeal cancer, and what it generally said, for surveillance of head and neck cancer, it's far supersedes any other modality. This came from Peretti. And now even in the recommendations, standard European recommendations, they have incorporated NBI as one of the modalities. And if you look at the treatment algorithm, so actually at this stage, it's basically flexible nasal endoscopy with NBI, and primary found, you have to treat it. So even after PET-CT, you have to, if it's a negative, then you have to repeat your NBI scopy. So it has now found huge uh, utility in this. So this is just one of the examples where we multiple biopsy taken, every time it would come negative. But when we were doing PET NBI scopy, okay. So what it showed was the center of the lesion here, somewhere over here, the crater, were the vessels. So the conventional wisdom is always go and take the biopsy from the margins, and that was coming out negative. But when you kind of switch over to the NBI, this is the place where the loops were, and when we did biopsy from this came positive. So it's fundamentally one of the best investigations when you have a carcinoma of unknown primary. And we never pass it on to our radiology colleagues for evaluation without, doing an NBI, because this is such a seemingly normal arytenoids and larynx. But when you do a close NBI, you can actually clearly see these dots and loops coming out here, and you have to take a biopsy here, and it turns out positive. So if you have to go underneath the tonsils or even at the gingigo tonsillar folds, it's very easy with the scope to go and see it. Rather than giving multiple biopsy, it's always better that you can do NBI in general anesthesia. Similar examples. So in COVID, we used NBI a lot, and one of the reasons for that is in middle turbinate, it can differentiate avascular tissue of mucor with a polyp or some other lesion. So it can differentiate an inverted papilloma from a benign polyp. It does very well, and it can actually. Uh, so that's a polyp-looking lesion, but turns out to be inverted papilloma on NBI. So your counseling and what sort of CT scan you're doing for a regular polyp dramatically changes when you're using NBI in the OPD setup. And now one of the things for Globus evaluation is reflux. And reflux, you don't end up doing a manometry or upper GI endoscopy for every case, but you can give a definitive evidence of reflux almost with a more than 90% sensitivity and specificity when you're using NBI for diagnosis of the reflux. So they give like a tiny town brown dots when you get to the lesions, and that's a very useful test. So we are using it for reflux, or to validate that the patient has a globus in our routine scopies in the OPD. So these are the lesions which you can see with NBI on in reflux patients. And the place to really go around is actually interarytenoid space, uh, slightly in the below the anterior commissure of the trachea and in the posterior surface of the arytenoids. That's where you kind of pick up these brownish dots. And once in a while, you actually see it in the nose, these brownish dots, and then you know that this kid or this person has a reflux, a severe reflux at night. So there's a learning curve, there's a cost. You can't see underneath hyperkeratotic lesions. If the tumor is not at the surface, the NBI will almost always miss it. And there are false positive and false negatives, which we have gone through it. So really, is the NBI the only tool? No. So SPICE, which is by Stores, and iScan, which is by Pentex, they rely on a slightly different technology where the light source does not change, but the images, they have a filter, an RGB filter in the images. So basically, like when you're fiddling with an image, you're playing with the saturation, red and green. So with that, they can give an image which is very similar to NBI. And when they compared all three the modalities, they're almost the same. So I'm not saying the Olympus is the only one which makes the NBI, but there are very similar parallel technologies. And a lot of people have made apps where you can put a normal image and it will change it to an NBI image instantly, which is just nothing but changing the color saturations of the image. So every truth has two sides. It is well to look at both before we commit ourselves to either. So what's the SWOT analysis? What are the strengths, weaknesses, and opportunities and threats? So we have gone mostly the strengths and weaknesses. Uh, so we had this huge camp where we called in all the smokers. Olympus had done it at our institute and said, hey, do you want to know that you have a high risk of cancer or not? And that was just in the middle of the COVID. And a lot of people were just interested. And they would almost never reveal that they are smokers, but they would just say, and okay, I'm not a smoker, but I do want to do a scan. So, and that's one of the really good screening opportunities. Then cancer surveillance. So deep learning and cancer prediction. So if we all pool the data and upload into the server for AI, right now the sensitivity we are coming about for 4,000 images is about 85%. But if you have like a million images or more than that, we can reach 95 to above sensitivity to say diagnosis just based on NBI. And the threats are basically there are very parallel technologies which are running with NBI, and they're also quite good. But NBI has the ease to do it in the outpatient department. So in the end, as we move on to 4K system, NBI is going to be much more powerful. We can have lenses attached to your scopes, which can give a much more meaningful image in NBI. It can be attached to a Da Vinci robot while doing a robotic surgery. Now you can have an advanced automated tumor marking on an iPad, and the robotic machine actually takes out the lesion for you. So that you can do with NBI images incorporated. And then we are working very hard on the artificial intelligence and kind of improving our diagnostic probability with narrowband imaging. Thank you so much for your time.
Thank you, Dr. Shashi, for wonderful insight on NBI. And from here, we'll go on to inauguration before we go for the third talk. Good morning, ladies and gentlemen. At the outset, I welcome all the delegates, both national and international delegates, particularly from Bangladesh. We have about 10 of them attending our conference. We welcome you all, and we welcome our chief guest, Dr. Sanjay Mehta, who is the Vice President and Unit Head of BLK Max Super Specialty Hospital. I welcome Ma'am, Dr. Mrs. Sunita Abrol. She is also our guest of honor. And I really, this particular this particular conference is actually we have limited our seats to 100 because we have a smaller auditorium. But at the same time, I would say that there is a overwhelming response. All seats are full, so that's why we decided to do hybrid at the last moment. A lot of people are watching. Yesterday in Gangaram Hospital, we had a nice surgical demonstration, and today we are having our didactic lecture series. Tomorrow we'll be doing the hands-on experience again. Hands-on experience for that we had limited our seats to 30, but due to popular demand we had to increase by 10 more to accommodate more people. So 40 people. So every year we have been doing since last 2015. Every year we have been doing this workshop, hands-on workshop, and it has been always appreciated. And this time, rather after 2 years of pandemic, people are more interested, I think. So that's why it has taken a very good response. Thank you very much. Can we share this? इधर कोई शेयर करो ये स्क्रीन शेयर करो 1 2 3 करो ना नहीं शेयर हाँ तो ज्वाइन हाँ नहीं you can join
आज नहीं सॉरी आज शाम को
Yeah, last year we lost
सर आपको म्यूट करना पड़ेगा
last year we lost two of our beloved members of LVA. So before we proceed with inaugural function, we would like to pay our homages to the stalwarts. Late Professor B.M. Abral, a few words about him. He graduated from Amritsar and did his MS from AIMS. He was in teaching faculty as associate professor also. He did He worked at AIMS, Gangaram Hospital, Mulchand, Batra, Apollo, PSRI. He did various fellowships in all over the world, most of the places. He was honorary ENT surgeon to President of India, patron in chief, patron in chief of laryngectomy. He was main founder of laryngectomy club of India. Because since the time I become an oncosurgeon, I started getting newsletters from laryngectomy club. That's how I came to know about Professor Abral. He was also founder president of Voice Foundation of India International, published more than 80 papers in various national and international journals. He was a great teacher. Believe me, in last from 2005 onwards, I've been watching every conference, let it be a clinical meeting, let it be a national conference or local conference, he would be there. Dot at 8 o'clock means 8 o'clock. And he would be there throughout. I used to ask, sir, don't you get tired? He said, no, I'm unlearning to learn new things. The famous phrase of his that unlearn to learn new things. Great person. Even in last year we had a webinar because of pandemic. So that time also he attended the webinar. And Dr. Sunita Abral, ma'am, we are really our deepest condolences to you. We'll be always missing him. He was a wonderful teacher and always a great inspiration for all young laryngologists. Next is Professor Arun Goel. Professor Arun Goel was associated with LVA very closely and always smiling. He did his MBBS from Allahabad, MS in Delhi, joined GTB in 91, 30 years of teaching experience. He became HOD also in 2020. Last year when we did our webinar, which was seen by almost 4,000 people from 105 countries, that time he was also one of the speakers, but he never gave an inkling that he was not well. He battled with cancer and finally he succumbed and left for heavenly abode in 2021. So I request all of you to stand for 2 minutes to pay homage. Thank you. Please sit down. Thank you. Now I have another pleasant task now. शेयर करना है, एक मिनट, इसको खोलना है ना। It's my pleasant duty to announce that LVA is awarding Lifetime Achievement Award to Mr. Vasant Oswal, FRCS from UK, who is the chief patron of our LVA, and his blessings are always there with LVA. That is how LVA has been progressing so well, and time and again we are holding a lot of um, a lot of conferences and workshops to promote laryngology. May I request our chief guest, Dr. Sanjay Mehta, to present the memento, the Lifetime Achievement Award. The virtual, he is watching. He is watching. Now, may I request Dr. Sanjay Mehta to say a few words?
Thank you so much, sir. And I think very happy to see such a lovely crowd and all distinguished physicians and surgeons here in the morning. And my heartfelt thanks to all of you to be here early in the morning. It just shows your dedication towards learning. I would also like to congratulate the LVA and the organizers and Dr. Ramalingam and his team to organize such a wonderful workshop for 3 days, and also express my gratitude to invite me to this place. And it's a privilege to be among such distinguished people. And I'm sure you've learned, you've enjoyed yesterday, you will enjoy today and tomorrow as well. Like sir mentioned, like Dr. Ramalingam mentioned, this conference has become an annual affair, and it's the 7th year in row, and it keeps becoming better and bigger. So I wish you all and Dr. Ramalingam in particular all the success, and I'm sure under his leadership we'll take this conference forward, and it's going to become, like I said, better and bigger in the years to come. Like he's been instrumental in taking the Department of ENT and cochlear implant wherever it is in BLK today. He's been very instrumental in setting up the voice lab, the cochlear implants, and now very happy to share, and I'm sure you all are aware that he is now ventured into robotic surgeries as well. So heartiest congratulations, sir. So again, thanks to all of you, and thanking Dr. Ramalingam to organize all this, and wish you all the best. Thank you so much.
Thank you, Dr. Sanjay. Really, in spite of your busy schedule, you have taken out time to come here and grace the occasion. Now, may I request my organizing secretary, Dr. Niyasud, to present bouquets to Dr. Mrs. Abral and Dr. Sanjay Mehta. इसको ये काम करना है। Now I request Ma'am Abral and Dr. Sanjay and chairpersons Dr. Sachin and Dr. Kunal to do the lamp lighting. इसका ना एक प्रेजेंटेशन है ये वाला प्ले करना है इसको no, no, no. Oh.
We should take this out before the censors get activated. Yeah, I think so.
Now I'll play. Dr. Oswal has sent a recorded video, which I'm going to play for you all to hear what he has to say. Sound.
Dr. Neha, the members of the organizing committee, and
Hmm? केबल दे दो मेरे वाले लैपटॉप का साउंड कहाँ गया Sorry, just 1 minute. Hmm?
to inaugurate this conference. It's 4 o'clock in the morning in the Dr. Neha, the members of the organizing committee, and the members of the executive body of the LVA. Thank you for inviting me to inaugurate this conference. It's 4 o'clock in the morning in the UK, so maybe I feel a bit sleepy. Just as the pandemic was over, we had Russia-Ukraine conflict. Many of you would not know I was a chairman in the 90s of the Young Otolaryngologists Association of USSR, the old USSR, and I went to Russia every 2 years to teach in St. Petersburg. Some young surgeons from Ukraine also were there. So it makes me feel fairly sad to having had a good relationship with both Russians and Ukrainians in the past. These are uncertain times, and the organizing committee did well, not only to be able to hold this conference and also find extra revenue that is necessary to make it a hybrid conference. I'm now 88-year-old. I went into medicine in 1955 and qualified in 1960 in Pune University. Then I went to Bombay and had my first ENT job in Bombay Hospital under Dr. Hiranandani, Dr. R.F. Cooper, and Dr. N.K. Apte. It's incredible to know that in those days, mastoid surgery was undertaken with chisel and hammer. The 60s saw, after the war, a tremendous progress in technology. There was a baby boom after the war, and those baby boomers of the post-war era were now young, and London was nicknamed as swinging 60s of London. So in the 60s, we had a lot of technological progress. The ENT got operating microscope, and we were able to do finer surgery on the mastoid, preserving the hearing at the same time. We were also able to treat otosclerosis with stapedectomies. I did not stepidotomies, but I did stapedectomies in the 60s, 3 cases per week. I did my own prosthesis with fat and wire. The development of laryngology goes back to the 19th century. In 1854, Manuel Garcia, a music teacher from Spain, invented a laryngoscope. It was a preliminary, primitive laryngoscope. He used a small dental mirror put in his throat and used sunlight from another mirror to shine on the mirror in the throat. So that was the beginning of laryngoscopy. He came to London to present his work to Royal Society of Medicine a year later. So the microscope and fine instruments also made some difference for laryngology in the 60s and 70s. But I think the real progress in laryngology was in 80s when the laser came into use. Laser can be regarded as a quantum leap in instrumentation of laryngeal surgery. The emphasis has shifted from removal of disease to preservation of voice. there was one surgical procedure that only bilateral vocal cord palsy, laser arytenoid surgery for this condition. Only laser can do it. Such patients in the past had permanent tracheostomy, lifelong tracheostomy. So, with the progress of laryngology in the 80s, it's small wonder that we started thinking of laryngology as a important subspecialty of ENT. Some people would go a stage further and call it a super specialty. The laryngology associations were established in Europe and UK, and one, of course, in India. Americans actually had laryngology association way back in 1875. So where we are today is a much more progress that we did in laryngeal surgery. The Mangeshkar Hospital in Pune, my hometown, was instrumental in giving me an opportunity to bring laser to India. I also brought many of my international colleagues and held conferences and courses in many cities of India. Asia Pacific laryngology was established because the region is so vast and socially diverse. And Asia Pacific Laryngology Association held its first meeting in Singapore, which was quite a successful meeting thanks to the leadership of David Lau and Vyas Prasad. The second conference is now in Manila in December. So where do we go from here? India, of course, is now a very advanced country. It's got a tremendous place in the world, top countries in the world. And I think we should take a lead in the Asia Pacific region, having a platform of Asia Pacific Laryngology Association and become an important laryngology country as well. There is much work to do. LVA and APLA are doing clinical work for laryngology. But I think people should think about establishing Institute of Laryngology in India, Indian Institute of Laryngology. There is much work to do for such an institute. For example, you need to have a minimum criteria for voice clinic. You need to establish them. You need to accredit courses, laryngology courses. An institution can do that. You need to spread the word about courses, conferences through a newsletter. So this is something that I'll leave it with you to think about. I think it's pretty worthwhile undertaking for the future. Another thing I would like to say is more of our Indian ENT laryngology colleagues presenting their work in international conferences. We're doing good work in India. We need to spread it around. Also, those young people who are going to make their career in laryngology or who are practicing, who want to have a little bit of academic angle to their practice, they should learn basic skills of presenting in conferences, such as PowerPoint animation or public speaking in English. There are many such programs on YouTube. And go abroad, go in countries around the world to present your work. I think we should do that now. We are ready to do it. India is going to be one of the top countries in the world. It is already there. Laryngology can do the same, take the lead, at least in Asia Pacific region, and take it further. That's my advice. I hope that will happen. So thank you very much for invitation again, and enjoy your 2 days, educationally rich. And again, thank you, Brigadier and Dr. Neha, for all the hard work you're doing for the association. All the best. Thank you and bye.
Uh, okay. Now, may I request Dr. Sanjay Mehta to accept a small memento from our side, from LVA side? May I request our President of LVA, Brigadier Rakesh Datta, to come and address the audience.
Good morning, everyone. Respected teachers in the audience, I can see a fair amount of them, and really honored to be here. Members of the LVA, invited dignitaries, as well as all delegates. Uh, I took over this presidentship around 2 years back, and that's when COVID happened. And through that, I must appreciate the efforts of all our members, especially our stalwarts, to carry forward the activities of this association. As has been rightly brought out by Dr. Oswal, we have really come a long way, and this association has, and the various conferences all over the country have only grown in leaps and bounds, as Dr. Mehta rightly pointed out. I really appreciate everyone for this collective efforts, and especially Dr. Ramalingam, who has held the fort in Delhi and really, along with Dr. Neha, managed to pull off this show, which is grander and larger than before. Thank you, everyone. And I'm sure with the support of everyone, we will carry forward this association and grow in leaps and bounds with new technologies and all the stalwarts here. Thank you.
I would like to call Dr. Manjunath MK, sir.
Good morning, all. I'd be presenting the annual report of LVA for the last academic year. First of all, at the outset, I would like to thank Dr. Ramlingam sir and Dr. Neha for inviting all of us. And since the last conference was a virtual conference held in Lucknow by Dr. Rakesh Srivastava and Dr. Rakesh Datta. And following that, we had a 6th BLK webinar in April last year. And also Sachin Gandhi sir has been doing annual hands-on workshop in swallowing, airway and voice at DMH Pune. This was held at during September this year. And then he has also started a virtual virtual webinars, uh, back to basics, on every third Saturday, and it's been divided into 3 modules: voice, airway, and swallowing. Voice, air, and airway modules have been completed, and the swallowing module has been going on as of now. And we have had a very good response with that, and probably sir would be continuing that in the next year as well. And we also had the transnasal esophagoscopy and office-based laryngology workshop at Bangalore at Meenakshi ENT Hospital in August this year, also under the aegis of LVA. So these have been some of the workshops and conferences held in the last 1 year, and fortunately we have been transitioning now from the virtual conferences to the physical conferences, and that's a good thing. And it's good to be back meeting all colleagues and friends in physical form now after a gap of 2 years, and hope to continue more and more works in the next few years as well. Thank you.
I would like to call Dr. Neha Sood to give the vote of thanks. Good morning, everybody. I first of all would like to welcome everybody who is there with us to make this 3-day event a pleasure to be. We have knowledge which is going to be shared by stalwarts, and exchange of ideas between colleagues, and it will be a pleasure to impart knowledge to the younger surgeons. And before I start my vote of thanks, I think I should take out this piece of paper, because I might forget somebody, and that would not be great. So first of all, Dr. Sanjay Mehta, who's our unit head and senior vice president, thank you, sir, for being here. I know you have a very, very busy schedule, but I would also like to thank you for always supporting our department under the leadership of Dr. Ramalingam. And that has helped us grow over these years, all of us grow over these years. So thank you so much, sir. And we welcome you here. I would also like to welcome all the delegates who have not only made it from Delhi, from India, but also international delegates who've come all the way from other places with us for the next 2 days. I would like to thank the faculty who have taken out time to come here and impart knowledge to all of us. It is a pleasure to be associated with LVA. I would like to thank Mr. Vasant Oswal, sir. First of all, congratulations, sir, if he's listening to us, for receiving the award. And thank you so much for always imparting your experiences and your knowledge with us. Dr. Sachin Gandhi, Dr. Ashok Purohit, Dr. Rakesh Datta, I thank all of you for being here, and the entire faculty who are there with us. The chairpersons, who again have been on a working day, have taken out time to come and help us out. I would like to thank our sponsors, Olympus and Boston Scientific, who have throughout these 7 years been associated with us, and multiple drug companies who have sponsored this event. I cannot forget the marketing team led by Mr. Shehzad Mirza and his team members who have been working morning till evening to make this event a success and helping all of us out. Lastly, but most importantly, our department. First of all, I would like to welcome and thank you, Dr. Ramesh. I think he's not here. So he has recently joined us, but he has been such a great pleasure to work with, and he has supported us during this event from the beginning till date and till this event finishes. I would also like to thank all our team members, the doctors, the technicians, our Neeraj brother who's there with us, everybody in our department who are still running somewhere in the backdrop, but they are the most important people. Lastly, and but most importantly, Dr. Ramalingam, who has been the backbone of this department and under whose guidance we have all grown and we are still learning. And he never leaves an opportunity to share his knowledge or push all of us in the right direction, push us up and motivate us to work harder. Thank you. Thank you so much. Welcome, all of you.
ये क्या है टाइप सी का है क्या एक बार अपनी वो चेक कर लें प्रेजेंटेशन फिर अपना कंप्यूटर ले आएंगे अगर इसमें नहीं चलेगा हेलो गुड टू सी यू गुड दैट आई गॉट दिस पेन आपकी तरफ क्या हालत है ठंड तो यहाँ भी होनी शुरू हो गई है गर्मी लग रही है हमें नहीं लग रही मैं अपनी वो कंट्रोल कर रहा है चलो आज टाइम दिया मैं आता हूँ हाँ सही बात चलो दोबारा ये टेकिंग नेक्स्ट एक बार चेक कर दो ये चल रही है इसमें डजंट फिट इन व्हाट फिट्स टाइप सी होगा आई हैव got that how do we do it मैं have to ask it's not their computer oh no, this is the one no this is theirs अच्छा हुआ है videos इसमें भी 4-5 है ठीक है हेलो हियर will get one to the I can very I can feel the all the और मेहनत किया रिस्पॉन्स सुनने मेरे यहाँ नहीं बट रिस्पॉन्स सुनने लगा आप सारे दिखा दो एक बार फिर देख लेते हैं डैमेजिंग इतना ही नहीं चल रहा होगा तो फिर ठीक कर देंगे आप लोग आए थे डॉक्टर रामलिंगम कह रहे हैं कि मैं नेक्स्ट कर लेता हूँ क्योंकि मेरा वैसे 11 बजे शेड्यूल था।
यहाँ से मीटिंग में हुई ये तो नहीं,
ये नहीं करना। इफ यू वांट तो ये भी चल जाएगी, मैं आपको मुझे कंप्यूटर दे दो, मैं 5 मिनट में इसमें चला सकता हूँ, पर ये बेटर है अगर उसमें नहीं चल रहा इतना कंप्यूटर, क्योंकि उसमें 8-9 वीडियो हैं, पहले में ही अटक रहा है, उसमें फिर सब कनेक्ट करने पड़ेंगे एक एक करके। यहाँ से कर देते हैं, आप मुझे लॉग इन करा दो। ये बाकी है पीछे से फुल्ली चार्ज है, बट फिर भी सेफ है। क्या हो गया, फिर चला गया? नहीं, ये तो इसमें तो है ही। आप बस मुझे वो दे दीजिए, क्या कहते हैं, हाँ HDMI लगा दीजिए। HDMI लगा दीजिए, इंटरनेट चाहिए।
बस आपको पहले इंटरनेट एसेंशियल जो मीटिंग से कर लीजिए, मेरे को लगेगा बोलेगा तो मैं आपको ये
Whatever you do, I'm happy. एक मिनट,
जैसा आप मुझे कहोगे मैं वैसा ही करूँगा, कोई दिक्कत नहीं है।
ठीक है जी। So you want me to?
ये बस आप यहाँ पे चेक कर लीजिए अपनी वीडियो, आपके
ये बैक नहीं नहीं चलेगा, ये क्या तो चलता है, रोज तो चलाता हूँ ना। ये आप डाल दो पासवर्ड जरूर डालना।
मीटिंग लिंक खोल लीजिए।
अच्छा, आपने ईमेल किया है?
मेल पे आएगा, सब मीटिंग का लिंक होती है,
क्योंकि आया तो था कुछ, पर मैं तो यहीं आना था, तो मैंने क्या करना था उसका।
हाँ यही हुआ है, कई सारे
तो डॉक्टर सूद ने भेजा, किसने भेजा है? कब भेजा ये भी आपको पता नहीं?
ये मैसेज से आया कल मॉर्निंग आया, कल इवनिंग को शायद एक मीटिंग थी।
डिलीट यहाँ कर दिया होगा, जरूरी था ना। सुबह आया डॉक्टर नया इन्विटेशन आया, इसमें होगा शायद। लॉन्च श्योर।
स्क्रीन शेयर
यहाँ शेयर तो लेना है। Lovely, this is the most best बताने वाले कुछ नहीं।
आप देख लीजिए वीडियो से कुछ ज़्यादा बेटर होगा।
कंप्यूटर पे तो सब चलता ही है।
सब चलता है, लेकिन कई बार क्या होता है कुछ दिक्कत आ जाए तो फिर काम
राइट। सिर्फ ये देखिए कि यहाँ पे म्यूट राइट, आपने तो बिल्कुल ठीक बात है। तो ये सामने भी जाएगा क्या? इतना जिससे जा रहा है इतना काफी है। कोई ऐसे कोई ठीक है।
सही है। वैसे तो 4 या 10 सिस्टम के आसपास कनेक्ट हो गए होंगे, 4 तो उसी टाइम देख रहे हैं। चार्जर मेरे से तो है नहीं, सिर्फ ये कनेक्टेड था यहाँ पे। नहीं सिर्फ करेक्ट है एचडीएमआई उन्होंने पता नहीं एचडीएमआई क्यों लगा लिया उन्होंने लगा लिया होगा वैसे
हाँ जी
वो सिर्फ वो वीडियो है तो वो भी एक बार चेक कर लीजिए
नहीं नहीं हो गए
किसी के
इसको
अंदर कोई भी वीडियो में अंदर इंक्लूड ही नहीं है ना
इसको बाहर कर सकते हैं इसको हटा सकता हूँ यहाँ से
हाँ जी हटा सकते हैं
वो तो वैसे भी शेयर करेंगे तो कट ही जाएगा शायद
सर ये साउंड सिर्फ म्यूट कर दीजिए
हाँ ठीक है कर देता हूँ
नीचे
ये आउटपुट बंद कर दीजिए बस
ठीक है लवली
तो ये रहेगा कि जो आपकी वीडियो वहीं पे ऑडियो सुनाई देगी सिर्फ यहाँ पे नहीं आएगी अलग से
नहीं यहाँ पे तो ना है।
आपका सर माइक भी म्यूट होना चाहिए देख सकते हैं
इसका माइक
हाँ इसका
वो तो मैं कभी किया ही नहीं आज तक इतनी जूम मीटिंग करता हूँ मुझे पता भी नहीं कैसे करते
नहीं क्योंकि सर उस कैमरे का माइक
वर्क करेगा
ट्रांसमिट
ठीक
होगा
आप इससे साउंड मत दीजिए कंप्यूटर से साउंड मत दीजिए
their information from one financial
or we'll give you the NEFT details and then you can pay later. And also, whoever wants to participate in the quiz, you can give your names to the, yeah, all PGs. So please give your names at the registration again. There is a list.
We are going to form 3 teams for quiz, mostly from PGs only. So institution wise, you can register yourself at the reception counter. Thank you.
Good morning, everyone. I'm Dr. Kunal. It's a wonderful startup, and I know Sir always is very punctual about time, and has been bang on target. It's a very good start. I would also like to thank Ramalingam Sir for giving me this opportunity to chairing the first session of this wonderful association of LVA, which I'm also associated with it. And I would like to welcome Dr. Nilanjan Bhomik. He is a post-graduation from Government Medical College Aurangabad and presently is a consultant at Dinanath Mangeshwar Hospital and Research Center, Pune. He has been invited many times as a faculty in national and international conferences on laryngology and dysphagia. He is also a faculty for biennial hands-on workshop on swallowing conducted at Dinanath Mangeshwar Hospital. He is also teaching faculty for a fellowship course in laryngology, which is accredited by the prestigious Royal College of Surgeons. He's a postgraduate teacher for DNB examination, and like me, he is extremely fond of traveling, reading, and has a zest for his passion sharing with laryngology. So I would like to welcome Dr. Nilanjan Bhomik to present his talk.
Thank you very much, sir. I'll be speaking on transnasal esophagoscopy, or TNE as it's fondly abbreviated. Now, the history of TNE is rather interesting. So it was Dr. Adolf Kuzmol who first did the esophagoscopy inspired by sword swallows, but then it's Dr. Chevalier Jackson, who an eminent laryngologist who actually popularized the procedure, did hundreds if not thousands of them. Now, what changed in the 1950s is Dr. Basil Hirschowitz, a gastroenterologist himself, first invented the flexible fiber optic gastroscope. And since then, esophagoscopy slowly slipped into the domain of gastroenterologists. Then again, something changed in 92. Dr. Reza Shakir, a gastroenterologist himself, did the first transnasal esophagoscopy. And Dr. Jonathan Aviv in the late 90s demonstrated the TNE to a large audience. And from then on, laryngologists were back into the game. So what happened is, since the early 2000s, laryngologists have been increasingly performing TNE. Now, TNE is performed with a scope which is 60 centimeters in length, and the width, the bore is anywhere between 3.5 to 5.9 millimeters. It has got a insufflation channel. It has got a suction channel. Of course, it's got an instrument channel which is somewhat small. It's around 2 millimeters. That's important because the instruments that pass through the 2 millimeter channel are quite small, which is important, which I'll just talk about in a little while. So these are some of the instruments that pass through the instrument channel, nowhere more than 1.5, 1.6 millimeters. That's the maximum diameter of the instruments that can be passed. Now, most studies would agree that dysphagia is the most common indication for performing a TNE. Now, when I say dysphagia, I essentially mean esophageal dysphagia, which I'll come to in a minute. The other indications being gastroesophageal reflux, laryngopharyngeal reflux 2, head and neck cancer screening in patients who have a high predilection for head and neck cancers, or also patients who stay in areas which have a high predilection, preponderance for the diseases in the head and neck region. Studies have shown that a combination of TNE and FEES is an excellent investigative modality for globus.
And then some of the other interventional uses that the TNE can be put to are biopsies, secondary tracheoesophageal punctures, and of course dilatations of the esophagus. Now, as I was mentioning, esophageal dysphagia. So what needs to be understood is that symptoms of esophageal dysphagia vary a little from oropharyngeal dysphagia. Usually patients of esophageal dysphagia would complain of some suprasternal or retrosternal discomfort associated with food intake that can also be associated with regurgitation or heartburn. Again, studies have shown that roughly 60 to 80% of patients can localize their symptoms. This is important because based on this would be the tool of choice for performing the further examination. It could be a FEES or a TNE based on the patient symptomatology. Now, obviously, TNEs enjoy some advantages over the conventional OGD scopy. The primary one being that you do not require any sort of general anesthesia or sedation for the TNE. So which, as a consequence of that, post-procedural surveillance, the cost, everything comes down. Again, there's a study which compared unsedated TNEs to unsedated OGD scopies and have found that patients have tolerated the TNE substantially better. And finally, as a pan-endoscopic tool, so patients who might require, say, a pan-endoscopy for locating an occult primary, we can do a combination of nasal endoscopy, a laryngoscopy, as well as an esophagoscopy, all in the same sitting. So it serves as a one-stop diagnostic tool, the TNE. Now, coming to the procedure, most centers agree that it's best done in the sitting position. The patient is asked to be nil by mouth for around 4 hours prior to the procedure. Local anesthesia is sprayed in the throat. Now, this is something which I need to tell about. You see, local anesthesia, when it's sprayed, numbs the throat substantially. If you spray too much, what happens is this pooling, the patient loses a sensation of swallowing and the patient starts having pooling of saliva in the throat. That he can start aspirating, making the patient extremely uncomfortable. So suggestion is spray the throat, not too much though. Now coming to insertion of the scope, it stands to reason that we use the more patent nostril for inserting the scope. However, how to diagnose this beforehand is either by doing something called a sniff test, wherein we see which of the nostril has a better airflow, or what I prefer to do is something called a meatoscopy, wherein I insert the scope through each of the nostrils, look for the more patent cavity, and then eventually go in. You'll notice out here that there's a deviated spur on the left side. Now, in spite of the fact that I can negotiate past that spur and go into the esophagus, it's not very advisable to do so. You see, this is quite a long scopy. So what happens is you keep moving the scope, eventually the scope will touch the spur at times and the patient is going to get extremely uncomfortable. A sort of thumb rule for nasal scopies are that you need to stay in contact with the inferior turbinate rather than the septum, because that elicits more sensitivity. So go in through the more patent cavity. Now the next point, after you have visualized the larynx, the oropharynx, the next point of possible problem, or you might encounter some difficulty in, is visualizing the cricopharynx in the upper esophageal sphincter. So one way to go about this is maintain the scope just a little above the larynx in the cricopharynx. Ask the patient to repeatedly swallow, and what you'll notice is not playing. Hmm? No, this needs to play. ये हो जाएगा ना, ठीक है, चलिए. Take care. Okay, fine. Fine. Anyway, so one way of going about this is maintaining the scope just above the cricopharynx, above the larynx, and ask the patient to repeatedly swallow. So at some point, the cricopharynx opens up, the upper esophageal sphincter opens up, and you can get a glimpse of it. This is before you start negotiating into the esophagus, because once you start negotiating, you'll not be able to visualize the cricopharynx or the EUS very well. Another alternative method is to do something called a trumpet maneuver, where you ask the patient to blow out the cheeks, the neck, and the hypopharynx inflates up, and you can get a glimpse of the upper esophageal sphincter. Then we advance the scope into the esophagus. Now this is where the insufflation starts coming into play. You need to insufflate, however, again in small degrees. What happens is you insufflate too much, a lot of air goes into the patient's stomach. So insufflation has to be done intermittently. You continuously insufflate, the patient will start belching, will get extremely uncomfortable. So as you advance the scope through the esophagus, inflate or insufflate intermittently, see the esophageal mucosa, see for any ulcerations, mucosal breaks, obviously tumors. Another good idea out here is to do something called an eye scanning, which was previously talked about, either an eye scanning or a narrowband imaging. This gives a better glimpse, a better visualization of the esophageal mucosa. You all might be able to make out mucosal breaks, ulcerations, even smaller nodules and growths in the esophagus far better when you do an eye scanning or a NBI. Then, as we proceed on further, this is probably one of the most important places, the Z line. The Z line is the the squamocolumnar junction of the esophagus. Now, the squamocolumnar junction of the esophagus is at the lower end of the esophagus. It ideally should be, as it appears out here, round, without any breaks, without any tongues of mucosa or tongues of metaplasia going into the esophagus. There's a good grading system for this called the ZAP, the Z-line appearance grading system, which is graded from ZAP 0, which is a normal roundish looking, the way it appears here, roundish looking Z-line, to ZAP grade 3, wherein tongues of metaplasia come into the esophagus. Now, again, there are two studies, which has very distinctly shown the high association of tongues of metaplasia coming into the esophagus with Barrett's. The other study showing a high association of GERD with this sort of changes. So the Z-line appearance is extremely useful, and it is something which needs to be noted. We just cannot negotiate past it without looking at it. Now is the lower esophageal sphincter. Now, the lower esophageal sphincter is ideally in a closed, it's one of the high pressure zones of the esophagus. It's ideally in a closed position. What we need to observe before we approach the lower esophageal sphincter is whether it's patulous, whether there's a gaping lower esophageal sphincter. And then as we negotiate past it, we ask the patient to swallow so that it opens up, and then we gently pass into the stomach. No forcing through the lower esophageal sphincter. Once inside the stomach mucosa, the rugae of the stomach, these need to be observed. We can go down right till the gastroduodenal junction and have a look. Again, there's an endoscopic grading system which is called the Kyoto classification or the Kyoto grading system for gastritis, which is based on the overall redness, the nodularity of the stomach, the thickened gastric mucosa. So that's something which can be used for grading gastritis and also noting whether there's a possibility of these gastritis changes having a greater predilection towards gastric cancers. Now the journey back is quite informative because the TNE itself cannulates the esophagus. So what can be observed is the esophagus. You don't need to insufflate a lot when you come back. One, you can of course observe the esophagus the way it is without insufflating too much. And secondly, we can also see for the peristaltic movements. These are the secondary peristaltic movements that we see in the esophagus. This is something that needs to be observed well when we return back. And finally, again, while coming back, the upper esophageal sphincter can be visualized well. Now, esophageal dysphagia is going to occur because of one of two possibilities. One, there's a structural abnormality in the esophagus. Second, if there's a motility disorder in the esophagus. Now, most of these conditions cause some sort of a structural deformity or structural defect in the esophagus, mucosal rings, strictures. This is not in any particular order of incidence, but these are some of the most common conditions that you'll encounter on a TNE scopy. The occasional infection and tumors, reflux changes, and then of course motility disorders, which we'll talk about in a minute. Now, when I say infections, probably candidal esophagitis is the most common infection that you'll encounter in the esophagus. And the endoscopic picture is usually self-evident. If at all you need a more conclusive diagnosis, something like a brush biopsy can be done, which I'll demonstrate in a little while in a further slide. A brush biopsy of the whitish looking patches, and then they can be sent for KOH or calcofluor culture. Reflux esophagitis is probably the most common diagnosis that you're going to encounter on a TNE scopy. Reflux esophagitis is usually diagnosed by noting mucosal breaks in the esophagus. Again, there's a classification system for this, which is called the Los Angeles classification system, A to D, wherein the amount or the number of mucosal breaks as well as the area of mucosal breaks are taken into account, and it's classified from A to D, A being the least and D being the highest. So this is how early mucosal changes will appear in the esophagus, and you'll see towards the end of the scopy. Yeah, here. Post-radiation patients, you'll encounter the occasional stricture. Again, this needs you to, this is not playing, I'm not sure why. This needs you to again observe the upper esophageal sphincter while staying above the larynx and asking the patient to repeatedly swallow. This is not playing. Not sure why are all these videos not playing. Can I play from there? Just a sec. It must be playing here, right? Can we attach this? क्या करना पड़ेगा? मीटिंग अटेंड करने को डिफरेंट फॉर्मेट दैट इज नॉट सपोर्टेड क्या करना है कर सकते हैं see if it works, otherwise just continue working. जो लैपटॉप में ये एप्पल सपोर्ट नहीं कर रहा था ये ऑपरेट लैपटॉप कनेक्ट किया उसमें नहीं कर रहा एक फॉर्मेट को एप्पल सपोर्ट नहीं ठीक है, देखिए इसमें देखिए ये हो रहा है। मीटिंग आईडी कहाँ है? मीटिंग आईडी मैंने लिखा था कौन से लोग हैं वो लैपटॉप में कर दिया ठीक है अब फाइल ये पेनड्राइव में है करवाता हूँ सब I know. We're losing time. See if it works here. ये किसका है सर का? ये
I would request all the speakers for the next session to, during the break, to check your, I think, videos. It'll be easier for everybody. Then I think these people will check your videos if they're working or not beforehand.
So anyway, yeah, sorry. Uh, so cricopharyngeal stricture, as I talked about, esophageal divertically, you can spot the occasional esophageal divertically. You need to be very careful about not probing because they have got very thin walls. You might cause a perforation. Of course, there are occasional foreign bodies that you'll see. Again, point to remember is the TNE forceps are quite small. So any larger foreign bodies are not, you'll not be able to grasp larger foreign bodies. So foreign bodies with a sharper edge like this or very small foreign bodies are the only stuff that you can actually catch with the TNE forceps. I hope this plays. And finally, as I was saying, motility disorders. So what can be done is this is called a goose examination, an endoscopic evaluation of esophageal swallowing, a guided observation. So herein we feed the patient, boluses are then, as they transfer into the esophagus, you follow them with your TNE right down to the lower end or the lower esophageal sphincter as it moves into the stomach. This gives you a good idea about the time as well as the motility of the esophagus and the passage of food inside the esophagus. So any motility disorders, this is a good diagnostic tool out here. So brush biopsies, as I was saying earlier, for Candida, one thing, biopsies can be taken excellently with this tool. Only thing is something blue looking inside the esophagus, you don't biopsy it, it might be varices, will bleed torrentially. It can be used as an tool for awake dilatation for the esophageal strictures, wherein you can, under TNE guidance, again this is not playing, but under TNE guidance you can pass either a balloon or a bougie into the cricopharynx, into the esophagus and dilate it under observation. Barrett's esophagus screening is done by biopsying any suspicious looking mucosa in the esophagus. A 4-quadrant biopsy is taken for every 2 centimeters of suspicious mucosa that you note. 4 quadrants. So all 4 quadrants you need to take biopsy and then come proximally. And finally, a secondary tracheoesophageal puncture can be done in the OPD, wherein the trocar can be introduced under TNE guidance. When you insufflate the esophagus, through the trocar you pass a guide wire which can be brought out through the mouth, and then the prosthesis can be loaded on it and then brought back to the puncture site. So this is quite an easy procedure, and So secondary tracheoesophageal punctures are now being done by quite a lot of centers in the OPD, just with a TNE. Some other uses that the TNE can be put to are tracheoscopies, wherein you can actually visualize the trachea, look for any abnormalities within the trachea too with the TNE. Here, this is a patient with a tracheoesophageal fistula actually. Yeah. And some procedures in the trachea too. I'll just skip that. Now, again, studies have shown that conventional EGD-scopies and TNEs can be comparable for detection of gastric neoplasms, for endoscopic findings of gastritis, Barrett's, as well as reflux esophagitis, and for biopsy of lesions too. So the advantages quite outnumber the limitations, which are in around roughly 10% of patients, you may not be able to negotiate in the nose because of a tight nasal vault. A hypersensitive gag reflex you may have to abandon the procedure. Larger foreign bodies, as I was just mentioning, cannot be grasped with the present armamentarium of forceps and tools that you have. And for obvious reasons, pediatric population, you may not be able to do a TNE. Complications are thankfully quite rare. The occasional epistaxis, some pain and discomfort for the patient. Only one case of esophageal perforation has been reported in literature. So we can see that the TNE can be quite an effective panendoscopic tool. The procedure itself requires a very short time, depending on any interventions. If you require from anywhere from 5 to 15, 20 minutes, it's safe, comfortable. You can see from the patient's look that I'm well inside the stomach. He's quite comfortably sitting there. And I urge you to use it as the first investigative modality in patients suspected of having esophageal dysphagia. Thank you very much for hearing me out.
Thank you, Dr. Nalind. It was very informative. Thank you so much.
Dr. Kunal Nigam. Yes. We would like to start the next session. I would like to call Dr. Ishwar Singh and Colonel Manoj sir for the chairing the next session.
Manoj.
Anyway, good morning, everybody. I must thank the organizers, Brigadier Ramalingam and Neha, for inviting me to be here among you. So we have this oration, LAVA oration, and it will be delivered by Professor Alok Thakkar. Alok needs no introduction. He is a well-known figure nationally and internationally. He has done FRCS. He is heading the department at Colony Institute. He is honored with various awards and list is long. So I request Alok to start the oration. Dr. Alok.
Thank you, Dr. Ishwar. Can I have my computer? Oops. Waiting for the electronics to come up. So before the meeting, I was asked what is chaos, and of course, many of you know, because this is a very august gathering. Sachin's been involved with this very soon after we got involved, and you could say chaos is what you see in a medical meeting. Not this meeting, of course, not once run by Brigadiers Ramalingam and Brigadier Datta and Dr. Sood, but oftentimes. So this chaos is a little bit different. This chaos led us to so Dr. Roy will tell you what can go wrong, will go wrong. We are waiting. Oh, अच्छा Zoom खोलना है अभी, बोलो connect हो गया. This will take a few minutes.
So the title of your talk is
Yes.
You can tell about it.
अरे भाई ईमेल खुले तो सही पहले लोड करो. You will have to come.
Is it booting up or what's there?
Taking its own time because it's been
It's
closed.
not in
on the
hurry.
list, no?
We are waiting. We want it to start early, but it will take its own time. Huh? Yes.
That is cool. So we are almost good to go.
पता है वो आलोक क्या हुआ था ये
We have
ट्रायल
to open
बॉल
everything.
और
We have to open the Zoom again. We have to open the PowerPoint again. We have to. The whole computer is been shut
नहीं
down.
मैं तेरे को कहानी बता रहा हूँ WG ग्रेस था ही वाज ए क्रिकेटर एंड ही वाज ओपनर तो उनका क्या हुआ पहली बॉल पे ही आउट हो गए तो उन्होंने कहा वेल ट्रायल लेट्स स्टार्ट सो लेट्स स्टार्ट नाउ यू हैड ए ट्रायल
Zoom आया नहीं अब तक. क्या ओपन करें? Join. ठीक है. Should I say join or not yet?
सर पीपीटी के लिए मैं वहां से प्ले कर रहा हूँ
Yeah, exactly. So यहाँ से कनेक्ट कर दीजिए इसको. हाँ. पहले पीपीटी दी तो थी आपको तो लीड नहीं. हाँ, exactly. So क्या कहते हैं? It was all connected once. Why is it not connecting on Zoom? Finally.
Yeah, finally.
करीब ही हो गया नहीं
So these are technical glitches. Chaos. वो अभी पुतिन के साथ पाकिस्तान के प्राइम मिनिस्टर की मीटिंग हुई थी. वाज फिडलिंग विद दैट ईयरफोन उनका फिट नहीं हो रहा था, बार बार इट वाज फॉलिंग आउट. पुतिन और पाकिस्तान के प्रेसिडेंट प्राइम मिनिस्टर की मीटिंग हो रही थी. ही विजिटेड कौन सी उसमें तो इंटरनेशनल लेवल पे वो कान में लगा रहा था और इट वाज फॉलिंग आउट अगेन. ये टेक्नोलॉजी काम करे तो करे, नहीं प्रॉब्लम हो जाती.
Stop share कर दो. Where is it? And then share again. Share again. Share screen. Select screen. I'll share. ये नहीं select करना. आप share कीजिए. चलिए ये लेना पड़ेगा. Sure. Why? Why? Presentation. Yeah, sometimes I feel I can do this better. ये क्या हो गया देखो? So thank you. So this was about exiting from chaos, and this is something that I got involved with quite a while ago, 13, 14 years ago. And certainly when I got involved, I didn't quite know what chaos was. It's not quite something that I did for myself. I'm just one of the many players who got involved with this, wherein we had Dr. Ramesh Agarwal from pediatrics, from anesthesiology, we had Dr. Mrs. Deka, Dr. Vatsala from obstetrics, we had Dr. Sandeep Agarwal from pediatrics, myself, and now Dr. Arvind Cairo from otolaryngology. And we had residents and residents and residents and residents. Because ultimately, when we did it the first time, it was all about young people. It wasn't about the faculty. I was among the oldest, and I was yet in my early 40s. So what is chaos? Chaos is congenital high airway obstruction syndrome. Some of you would know, some of you may not. I didn't know when I was first confronted with this. It was a Friday. I was doing my rounds. I came out of rounds. It was the 30th of January. So we get a siren at 11 o'clock. And around that time, the pediatrician walked up to me and says, "Sir, we have a patient with chaos." I said, "What's that?" So chaos is this. Chaos is someone who has congenital high airway obstruction. You can diagnose it on the ultrasound, so you know. And the child grows in the womb quite well because he's on the placental circulation. But everybody knows that the moment this pregnancy comes to term, this child will not make it because he is not going to be able to breathe once he comes out. And what is exit? Exit is ex utero intrapartum treatment. I also was totally unaware as to what is exit then. But I was told by my pediatric surgeon and pediatric colleagues that this basically means that you actually take the baby out, but you continue the baby's gas exchange and nutrition through the umbilical cord. So it's outside the uterus, but it is connected to the placenta. And that gives you a window wherein the child, though outside the womb of the mother, is still nourished and gas exchanges to the mother. And so you have a child who can be outside the womb and can live as long as the umbilical cord is attached. And as long as the placenta does not separate, because when the placenta separates spontaneously, the delivery happens, the placenta separates. And the moment the placenta separates, that's going to be the end of the nourishment that this child is going to get. If you have a vaginal delivery, there's really no more than a few minutes that this is going to continue for. But if you do a cesarean section with very good relaxation, you could extend that. This is something that the world was getting involved with by then. It had been 20 odd years since this was happening, just that I was not up to date. So in the late 80s, someone had done a tracheostomy for a child who was born with this syndrome. A little bit later, people had realized that you could work with the eustachian, with the umbilical cord still patent, and then do it. And there was a name which was put through, which was OOPS, Operation on Placental Support. And 96, there was a term that came through, which was EXIT, that came from San Francisco. And EXIT, as I said, is ex utero but intrapartum treatment, and this has stayed then. So this story is about the EXIT procedure in patients who have chaos. Kids who will certainly not live, where everybody is aware that the child would not live, and you can get prepared for it. And as teams, you can do something about it. This first patient, we really had not much time because this was a patient who had presented to the casualty rather early, preterm, 30 weeks of gestation, and already had premature rupture of membranes and was in labor. And they did an ultrasound and they said, oh, this child will not make it. That's why the panicky reaction where all of us were called. And with the pediatrician and the peds surgeon and I, we got ready for this. We had a couple of hours to think it over, get some idea. This was the ultrasound, and this is basically what you see in the ultrasound. I'll come back to it in a little bit moment. But basic thing is that in the fetus, the lung is basically a secretor. It secretes fluids. And these fluids actually are then egressed out from the larynx. They come out from the larynx, they get swallowed, they get urinated, they go into the amniotic fluid. And that's how a fetus is. If you have a block in the trachea, then these lungs are they are distended with the fluid, so they are distended. So here, basic thing that you see is distension of the lungs. And you get fetal ascites, you get polyhydramnios, and all these features were there on this baby's ultrasound. So here we are. This is pink because a labor loom uses pink drapes. And this was the plan. The mother is already dilating. The fetus was going to be out soon. We planned that, of course, there can be no other option but a vaginal delivery because of the dilated cervix, and we planned an exit procedure. So I would say the chief guide was a pediatric surgeon, Dr. Sandeep Agarwala, a year senior to me in medical school, great friend. He got it organized. So we had people here. It was primarily a resident team with Sandeep Agarwala in charge, I number 2, and obstetrician, neonatologist, pediatric surgeon, otolaryngologist, we were all there. We of course made sure that we had the equipment around. We sort of made a makeshift small operating table just to, on the side of the mother, because you couldn't quite disconnect the umbilical cord from the child as it came out. So right next to the mother. And we got ready, and he came, as was expected. And the pediatrician tried to intubate and failed, not unanticipated. Over to us, local anesthetic and tracheostomy. So as you can see, the umbilical cord is still attached. The child is fairly pink because he's on placental circulation. We used a vertical incision because we frankly didn't know where the obstruction would be and whether we would actually find any lumen in the trachea as we went low. And we did the usual tracheostomy, dissected the straps. As we started doing this, the child obviously started to turn gray and gray. The placenta was probably separating. And who made this video, I have no idea. Someone from the obstetric team knew that this was possibly a big moment and they were doing something about it. You can see the child has gone into arrest. The pediatrician has in the meanwhile got IV access, and they are doing cardiac massage, as you can see, as you do in a 1.4 kilogram child. And frankly, from my point of view, it was rather difficult because this is a situation where the child has never really had good oxygen. So the carotid was gray, the IJV was gray, the trachea was gray, and of course you didn't quite know what was what. And but you could feel the trachea. I think I initially found the prevertebral. I initially found the prevertebral fascia, and then we sort of found the trachea, and we did the tracheostomy. And when we did the tracheostomy, we got a gush of fluid, which is not quite what you anticipate because the lungs were obviously full of fluid. So we got a gush of fluid which looked almost like venous blood. Frankly, it was all quite brown. And yes, then we put the trachea in. So again, back to where we were, having some difficulty in finding what's what. Child is arrested, IV line is secured, pediatricians are doing the CPR, so to say. Find the trachea mainly by palpation. As I said, everything looked a bit gray, it was a bit difficult. And we had never quite had the opportunity to read. Open the trachea and then you see this fluid come out from the trachea. Again, a bit unnerving. You can see the trachea now. Now it looks better, now that the fluids come out. 2.5 mm tracheostomy tube. And you can see the child is going pink. So the child turns pink immediately after that. You start oxygen, you start ventilating, child goes pink, heart rate comes back. And this was our first exit procedure. So that was exiting from chaos. We now clamped the umbilical cord, and the total time that we had taken was 10 minutes. That's what the pediatrician told me. But yes, partly because of the fact that the child had some support through the umbilical cord on the ex utero but intrapartum situation. So child made it quite good. He needed a lot of support. He was in the pediatric ICU. Our pediatric ICU is very good. 1.4 kilograms is not something that bothers them too much. Nevertheless, many issues with this child because exit procedure has many issues. These kids do not quite have a situation wherein their lungs develop very well because it's been distended because of the fluid inside it. But yes, by the time he was 2 months or so, he had come to 3 kg and he was neurologically intact and hardly needed any ventilatory support. He had a trachea still, needed some positive pressure support. And we felt we had made it, but we hadn't because this child then developed pneumonia and died. The autopsy confirmed what we had thought on the ultrasound. And yes, disappointing. Nevertheless, a small step because we have certainly gained some experience with the exit. We had learned how to do that. We had become educated. We were about the 45th case in the world. We were, I think, the first case in the subcontinent, certainly in our institution. And that was about it. The child didn't quite make it. But when we scanned the literature, we found that it was really unusual for children to make it. So only 2 survivals reported from prenatally diagnosed laryngeal atresia till that date. And as I said, so many things go wrong with these patients because they have fetal lung distension, thinned out alveoli. They have pneumocyte damage. They have issues with tracheobronchomalacia because they haven't quite progressed well. So with all those issues, this child came so far and didn't. As we reviewed the literature, we found that this was something that ENT surgeons actually do need to get a fair bit of involved with because some 13% of exit procedures were actually being done for chaos. Commonest was for congenital diaphragmatic hernia. That's quite another different story, even more exciting than this one, I must tell you. But ENT surgeons do get involved. So anyway, this time we were ready, we knew, and in 2012 we had another situation quite the same. This was a lady referred to us at 24 weeks of gestation, and she had a big neck mass. You see it better there on the MR. You can do a fetal MR. You can see this big neck mass, which was sort of thought that could be a teratoma or could be a goiter. The fetal medicine unit is very well developed with us. They did what was necessary. They put in a needle and sort of sampled the cord blood and told us that the karyotype was normal. They checked the TSH. They said that was normal. This was probably not a goiter. And we were pretty sure that this was a teratoma. The child was kept, the mother and the child were kept under observation. You found that as the child grew older, the size, the neck mass got bigger and bigger, and also the patient went on to develop polyhydramnios, which indicated that the patient wasn't swallowing well, which again basically meant that the esophagus was being compressed by the neck mass. So this time we planned an exit with cesarean section, because as I had said, with a cesarean section you get a little bit more time, because with deep anesthesia and full uterine relaxation you can delay the placental separation, and if you delay the placental separation, then you have a little bit more time to achieve what you want to achieve. So this was the plan, and this is it. So we are all ready. We have done a practice drill. We are there. The obstetricians first did an ultrasound, not that they had not done it before, just to make sure that where the placenta was before they made the incision. This is the uterus being opened up, the amniotic fluid draining out. There is polyhydramnios, and that's the baby's head, you can see. The baby's head comes out. We are careful not to take too much of the baby out, because if you take too much out and you decompress the uterus, the placenta will separate. So you have to keep it fairly tight in there. And you can see the huge mass, and that's the intubation by the anesthesiologist. Failed again. I come in, rigid scope. Hopefully you can push in a rigid scope where you can't. Failed again. You can see the umbilical cord is still attached, and he comes to the table right next to the patient, right next to the mother. And we do the horizontal incision on this time, because we know where the compression is and we know what's below it. And we do know that the trachea might be deviated or pushed to any one side by the Mars, so you don't quite know, and you sort of open up and we achieve the tracheostomy. The problem was it was so deep that a normal tracheostomy tube can't quite go in. Actually, there's such a big mass out there. So anyway, we managed with a cut endotracheal tube, but it was a very unstable situation in such a small child with such a small neck. And indeed, the tube got displaced on the table itself, so we did it again. And now you see that the thymus, you can see the thymus is being dissected off. You got a little bit more area there and put in the tube again. But inherently, it stayed an unstable situation. You couldn't quite, you put a tube in, the child is still on the umbilical cord. Even though we have arranged, we have got the airway, the child is still on the umbilical cord. Finally, we actually intubated, because once we got airway, we had lots of time. We pulled the mass up, held the mass up and tried to intubate, and we finally did intubate. And that was the most stable situation. Very soon after, the next day, we went ahead and removed the mass, and that was it. So as I said, multidisciplinary management, we did a practice drill before, because this time we had time. We used very deep inhalational anesthesia and uterine relaxant so that the placenta would not separate. We did not deliver the child completely so that the placenta would not separate. The cord was not clamped. And of course, there was a fair bit of bleeding because of all what we were doing. But again, a successful exit. Uteroplacental circulation went on for 70 minutes. At least we kept it on for 70 minutes. How much of it was actually circulating, we didn't quite know, but we cut the umbilical cord after 70 minutes when we was totally sure the patient had been intubated and everything. So airway was secured. Unfortunately, again, it didn't quite do very well, because that huge mass had done so much else to the child. So we did excise the mass. It looked good for a few days, but we couldn't extubate the child. He would go into distress. So we did a tracheostomy. He had probably bilateral cord paralysis. And ultimately, the child had aspiration and died. Of course, the histology confirmed a teratoma. So somewhere, but not far enough. Some travel, but not good enough. So let's fast forward to 2017. This was number 4. Again, you can see the classical signs. The lungs are distended. The diaphragm is distended, pushed down rather than up as it should be. There's a dilated trachea. You can actually see some obstruction there, and enlarged hyperventilated lungs. So we know what is happening. The problem is it's a twin. It's a twin. There are two babies. Two babies. One is normal, one is not. You don't know which one is, which one is not. So the problems keep coming. Fortunately, we came step by step so that we were a little bit educated. So anyway, twin pregnancy. One twin has chaos. We don't know which one of them. And fortunately, we had a referral fairly early. So we did an ultrasound, we did an MR, we sort of made sure what it was. We confirmed this was chaos. So we discussed with the parents. It's a very valuable twin pregnancy because this is a lady who was someone who was having difficulty conceiving. She was already 44. She had conceived by an in vitro fertilization after being primary infertile for 15 years. She had twins, what they call a dichorionic diamniotic, which basically means 2 sacs rather than 1 sac. So very valuable baby or very valuable babies and twins. Not that the mother could afford to lose this child. But nevertheless, such difficult decisions, and I'm not so sure how you can ever have these kinds of conversations with parents. But this conversation is something that happens in obstetrics now and then. So what the obstetricians did was to do amniocentesis for both twins and confirm that they had normal karyotypes. At least that was a good thing. And then selective fetal reduction. So selective fetal reduction is a way of actually taking away one twin so that the other twin can develop well. So difficult conversation. Nevertheless, and the parents everybody thought this might be the best way forward, because here was one twin who would probably have a significant problem when the twin was born, and it would be unwise to compromise the other twin because of this twin. So they went in for selective fetal reduction but could not achieve it, because with such large lungs they could not get to the heart. Basically, selective fetal reduction means you inject potassium into the heart. They couldn't do it. So then both babies are coming to term. One of them has a problem. That is what it is. And here we are all prepared. We run our practice drill, our teams in place. And this is a planned one, as always. Twin one comes out, cephalic, limp and apneic. So you're a little bit worried, but we could intubate. We could intubate and then we extubated. So that was the end of the story. The child was okay. While we were doing this, the other twin is ready to come. This one's a breech. So you can't take it out half. It's a breech. You have to take it out full. So it comes out full and we intubate. And by now we had this video laryngoscope so you can see. So they are intubating, we're all watching, and you can see the larynx there, and it looks pretty okay. So everybody's hoping they will intubate. Here comes the tube, but basically they can't intubate. You can see that the tube goes into the glottis, and when they push, it doesn't go. So then rigid bronchoscopy. We come in, the bronchoscope is a little bit, how much should I say, rigid, so you can push it through. And as we push it through, we actually get a gush of fluid. Just look, because we have rupture. There's only really not a very thick obstruction, a fairly thin obstruction. And as we push it through, we rupture through it and the fluid comes through. So now we think that this should be okay, but though some fluid has come through, the opening is not good enough to be able to ventilate the child. So we're still not ventilating. So we have decompressed, but we are not ventilating. So we do the trachea. And then after we did the trachea, we did the umbilical cord clamping. And this time it took 6 minutes. All said and done, everything. Intubation, bronchoscopy. So anyway, this time we had so many bad experiences where the child hadn't quite made it. We didn't know quite enough. This time we just kept the child in hospital. The child was in hospital for 6 months. We didn't let the patient go home. Of course, there was the other twin, so the mother had the other twin, but the mother stayed in the hospital. She would feed the child, the tracheostomy child. She would feed the child in the nursery, but she was around, and the family was basically camping around in the hospital. At 6 months, we went ahead and did a reconstruction. It would have been unwise to do it earlier, but at 6 months, or I think 5 months, 20 weeks of age, we went in, we did a posterior and anterior cricoid split, and we put costal cartilage grafts, and we put in an endotracheal tube as a stent for 2 weeks, and extubated in 2 weeks, and this is lovely. So finally, we had a patient who had not only said, but we had also done a laryngotracheal reconstruction and had a great airway. You can see the child extubated, comfortable, no trachea, breathing well, very satisfying. Except that after a while, the child went into fatigue and had to be reintubated. Extubated again after some steroid and everything, again needed to be reintubated. So basically, I said to you that these are patients who have distended lungs and they also have tracheal issues. They also have issues with the alveoli. And we started to look for those other causes. So we did a flexible bronchoscopy. A pediatric colleague, Professor Cabra, he put in this flexible scope. And what you can see, there's obvious tracheobronchomalacia. So even though we had a great subglottic airway, we had sorted the problem. The child had secondary tracheobronchomalacia. So we re-tracheostomized. And this time, the patient went home with a long-term tracheostomy. The child is now 5 years of age. We tried to decannulate last year, but we couldn't because the cords were not so mobile. We've done a Kashima. It's very good now. Tracheostomy is blocked. Good cough, good vocalizing, speaking, gaining weight. The twin is 17 kgs. This girl is 13 kgs. She's ready for decannulated, but not yet. Hopefully, if you sort of speak to me 6 months later, I can tell you the child's decannulated. I would hope she can. It doesn't seem like a problem now. We seem to have crossed the hill. So basically, 4 kids in the last 12, 13 years who have had the exit procedure for chaos. It's totally a team effort. We've had 4 near exits. Whenever Arvind goes for the exit procedure, for some reason the child gets intubated, which is of course great news. So, but 4 near exits, 4 exits. 1 has survived, which is really not bad statistics if you look at the literature. Functional airway, functional swallow, functional voice. I think we are ready now. Even if we have a 5th, we should know. Totally a triumph of collaborating together. We have some very competent and, more importantly, very nice people in all the other departments who work together, look after the kids so well that the little bit that we do becomes worthwhile. We have climbed many steps. We learned the exit, we got the airway, we sorted the pulmonary issues, we also got the laryngotracheal reconstruction. There's still other issues, I must say, but we can talk about it later. But it's been satisfying to come so far. I hope we go further. Thank you.
Thank you, Alok, for such a wonderful talk. And I'm impressed to see such a dedicated, hard-working team of yours. I remember you told me that you had told about it earlier also. But it's a great teamwork, and I think he needs another applause. I give him this thing. So I hand over to
I would like the chairperson to please felicitate the speaker, Professor Alok Thakur. I would request Dr. Ramalingam to please felicitate the chairperson, Dr. Ishwar Singh and Colonel Manoj. For the next session, I would like to invite the chairperson, Major General S. Girish and Captain Himanshu Swami to please chair the next session.
Morning, ladies and gentlemen. We are starting the next session. That is a session 3. We have 5 speakers in this. And this is essentially on the laryngeal framework surgery and related subjects. For the first session, the first speaker for this is Brigadier Ramalingam. He is currently the head of ENT and head neck onco at BLK Max. He has been in the armed forces and he's a renowned onco surgeon, head neck onco surgeon, and has immense amount of teaching as well as clinical experience. He is also the founder member of multiple associations, especially he is also one of the main strengths behind Voicecon. It's our pleasure to invite Dr. Ramalingam for delivering his presentation on laryngeal framework surgery and overview. Since we have some technical challenge regarding the videos, I would request other speakers for this session to kindly check in with the technical chaps regarding whether the videos are functioning appropriately so that we can actually cut short on the time.
मिल जाएगा ना नहीं आ जाएगी हमारे हाँ शेयर मैं वहां से शेयर
तो पानी पिला देना है। नहीं है। Uh, Morning, everybody. Thank you, Chairpersons General Girish and Group Captain Himanshu Swami for introducing and saying few nice words about me. I don't know whether I deserve. Anyway, um, uh, see, when we were making program, actually this particular topic we missed out totally. Finally, we realized that we are doing Voicecon and nobody is talking about laryngeal framework surgery. So my colleague Dr. Neha pointed out, sir, we are missing something really important thing, which everybody wants to know. I said, what? Laryngeal framework surgery. Then I had to reschedule my talk. So let's go over it. There's a hospital where I work and my colleague, and we have voice clinic, we are the team. So you don't have a pointer here? Pointer? This one? Okay. So initially phonosurgery, coined by, I mean, more popularly known, and Ishiki first coined it as thyroplasty. Then European Laryngology Society made it laryngeal framework surgery, and phonosurgery is a broader term. Okay. So phonosurgery is a broader term. Now Ishiki, father of phonosurgery, who is no more, God bless his soul, he departed this year only, few months back. I'm going to talk about a little bit of thyroplasty basics. So if you see, this is the animated video. We do take the measurement from thyroid notch to lower border, and this is the lower border of the thyroid cartilage, ala. So we do, we find out what is the midpoint. At that level is the vocal cord situated. And the window is made a little bit away from the midline. In case of females, it's about 4 to 5 millimeter. In case of male, it is 5 to 6 millimeter. And then we make the rectangular window. I'll be talking about the sizes and all. And the cartilage is removed. And then implant is placed. So this is the, as I told you, this measurements. Creating window is very, very important. As I told you, is about 4 to 5 millimeter away from the midline, because if you don't keep it away, what will happen? The anterior commissure area that gets more medialized and it creates strain. So this is very important. The upper border, it should be absolutely parallel, because here thyroid cartilage, it takes a little bit downturn known as the thyroid tubercle. If you follow that, then your window will become slanting. So we don't want that. So it should be absolutely parallel. Yesterday you must have seen in live surgery workshop, Gangaram, we did a thyroplasty.
Male larynx is big. So that's why the height is about 5 to 6 millimeter of the window and width is about 12 to 15 millimeter. Yesterday we did 6 by 14 millimeter. And in case of female, the height is about 4 to 5 millimeter and width is about 10 to 12 millimeter. There are different procedures. This is first is injection laryngoplasty where the paraglottic space is filled with either hyaluronic acid or hydroxyapatite or any fat. The second one is thyroplasty where implant is placed to medialize the vocal cord. And third one is arytenoid rotation. I will talk about it also. There are many different shapes of silicon implants have been described. Type A is actually Ishiki's original creation. Then type B, then James Kaufman made it like a boat shaped because the mid portion of the cord, it should be medialized more. The type C, type D, type E, I don't think anybody is using nowadays. It has gone out of repute. Changes in the implant system, just to tell you quickly, this is the Ishiki's type. And Montgomery implant, it is available in India, but it is very costly. The entire thing is was about 15 years back, it was about 75,000. Now I think it is much more than that. And it comes with pre-formed implants. So you have to select the size and put it. It is very fast, but the cost is very prohibitive. Netreville implant I have used in 3 cases. Is again comes with the preformed, you have to cut it. That time when I did, it was 3,000 rupees. Now I don't know how much it is costing. And Viacom, it is not available in India. It's just for your knowledge for the PG students. Why this is popular? Because once the implant is put, there is a locking device. You put it from outside so that it doesn't extrude. Gore-Tex implant, we started doing recently. Dr. Neha and me, we started, I think we have done about 5 cases. And because indications are definitely very rigidly we follow. Otherwise, we depend on, our main this thing is silicon. Gore-Tex is put just like, earlier good old days when you used to pack the nose with the ribbon gauze, long ribbon gauze. So like that, you keep on putting in layers till you achieve the medialization thyroplasty. TBFMI is a very good this thing. It is titanium implant designed by Gerald Frederick of Austria. We use it. I have done about 36 cases. We have published a paper as well. But it is, it reduces the operating time, but cost is more. It costs about 17 to 18,000. Whereas the implant is, this is one of the thing, and I'll be showing you one video as well. Now, my friend Dr. Ashok Purohit, he has invented a novel technique of putting the titanium screw to medialize the vocal cord as well as arytenoid. In this case, this patient came from Bangladesh. You will be hearing his voice also. After putting the implant, we realized that there is a little bit posterior glottic gap. So how do we do it? So instead of doing a proper arytenoid adhesion, we inserted this 12 mm titanium screw to medialize the vocal cord, and his voice improved tremendously. What are the advantages? It is restricted only to external larynx, so no endolaryngeal scar, nothing on the vocal cords. It can be reversed, except arytenoid adhesion, which cannot be reversed. And quality of voice production is far superior than the injection laryngoplasty. Now, arytenoid adhesion, why? Here, as you know, the larynx consists of 2 biomechanical subunits. One is anteriorly, it is membranous, and posteriorly, consisting of arytenoids and cricoid cartilage, is cartilaginous portion. So, if there is a posterior glottic gap, then only medialation thyroplasty will not improve. So here comes the arytenoid adduction. This is again in 78, Ishiki developed originally this thyroplasty. How many of you know that Dr. Ishiki was a plastic surgeon? He was not a ENT surgeon. Believe me, laryngology has been developed by non-ENT guys rather than ENT people. Starting from Klein Saucer, Chevalier Jackson, everybody, you name it, they are all non-ENT guys. So what he used to do is cricothyroid separation, cricothyroid joint separation, and then go upwards, retract upwards, and take a bite at the muscular process of the vocal arytenoid, and bring it out anteriorly, and mimic the lateral cricoarytenoid muscle, like this, the vectors of lateral cricoarytenoid muscle. And then came Maragas. Maragas, he created a window, posterior window, which I've been following now. Here, after you cut this window, what happens? You can feel the muscular process as a rice grain, and take a bite of 30-proline and bring it out anteriorly and tie it. This is a video of type 1 thyroplasty. Where is So I borrowed this from my colleague, Dr. Neha. Yeah, my original one has become very old. So I decided this is a well-made and well-operated surgical scale. So this is the surface marking, hard bone, thyroid cartilage and cricoid cartilage. We are infiltrating with adrenaline. Jalocan with adrenaline. Incision is given at the midpoint, what I have shown on the beginning. I'm just fast forwarding it because otherwise the cows will come home or people will throw me out. Subplatysmal flaps are being raised. Once you have done, you separate the strap muscles in the midline, what you are seeing. Once the strap muscles are separated, on the affected side, you take with 2-0 silk and retract it so that your ala becomes more like this. I'm not using any gadgets like master retractor or some self-retaining retractors. I don't use, because I want my operating field should be very, very clean and looks very nice. Now the measurements of the window, as I told you, from the V of the thyroid notch and lower border, meticulously taken with using corneal caliper, and then suppose is I think it was 18 millimeter, and the half of it is 9 millimeter. At 9 millimeter, you take a we use the cautery to mark it, because if you put any marking ink, it will smudge. So we use cautery, and about 4 to 5 millimeter away. And this is how I delineate the lower border of thyroid ala. This is my way of doing, because as I told you, the arytenoid, thyroid tubercle comes down. So we put like this and first mark it, so that lower border is marked, and you know that this is the way we have to go, like parallel to that. So next, meticulously you take the measurements, and one thing you should know, that posterior inferior corner of your window should not cross the oblique line where strap muscles are attached. Why? Because if you go further, there's a chance that when you're putting the implant, you may dislodge the arytenoid cartilage. So that you have to be a little bit careful. And here we are outlining the window. So you can see that she is really doing a wonderful surgery, clean, bloodless. She has a terrific surgical hand. Now the cartilage of the window is taken out with the help of thin Prius elevator. If this doesn't cut, means we are using 50 number blade, is a young tap, that's why. Otherwise you may have to do drilling. I'll show you again in some other. Here you have to elevate the inner pericardium all around. Most of the videos you will soon be getting in YouTube. Some are already available, but they have become old. I'm going to upload some new ones by the end of this year. So silicon is block is being carved out. The implant is being carved out, taking the measurements very meticulously. 1 mm difference also can make hell of a difference in the outcome of the surgery. So, like I showed you how you make type B implant, this is what is happening. Tomorrow during live surgery workshop, I mean not live surgery, the hands-on workshop, we are giving you real silicon blocks to all the participants. Somehow we have managed, I said instead of using rubber, you must use real silicon block to get the feel. This is the type B implant being carved out. And you have to score. Why you score? Because it opens up. She will show you in a minute. So this is the scoring system. Why you have to score about 2-3 scores? You have to do 2-3 scores, so that this opens up. So posteriorly, you must have seen posteriorly it is a little thick. So first you have to insert the posterior one and then bend it so that you can insert the anterior one. Now it is nicely placed. Once it is placed, then you have to do we do a FOL to see the position of the vocal cord and the approximation, and then we secure the implant with a thioprolene. That's what I did yesterday. I hope you people have seen in Gangaram Hospital. Once why we are doing this? So that it prevents the extrusion. We have done more than 300 plus implants, but so far nothing has extruded except one Netravalle implant which I had put in a gentleman. After 10 years, he coughed out. He was in US. He coughed out and he showed me. I have that implant. Yeah, are you able to hear this sound? Huh? Audio is there. Anyway. Anyway, छोड़ दो. See, we have to do. This is a TBFMI with the. Again, I will skip this issue. Once, let's go to the creation of the window. With TVFMI, the only problem with TVFMI is it comes in only 2 standard sizes, one for female and one for male. So you have to make the window also as per the description. You cannot make window as per your wish. This comes in when you are choosing the larger implant for a male. It comes in the literature how much this thing. I think in this case 13 by 6. I think. So once the window is made, here we are cutting with 50 number blade. And in the calcified area, you can use drill. You use 3 mm cutting burr, and the window is checked because this is very important. Otherwise, your implant won't go. And here I am cutting the inner pericardium superiorly, posteriorly, and inferiorly, and then trying to put the implant. It didn't improve, so here we are doing Margus window. As I told you, I'm going to show you arytenoid direction, and here we are using the remote and making a tunnel through the window posteriorly. Remember, when you are removing varicose window, that cartilage, that is the lateral wall of piriform fossa. So you have to be careful. You should not injure the inner pericardium arch. Then we palpated the muscular process. We have taken figure of 8 suture and then bring it out anteriorly like this. And then we ask him to phonate. Usually with arytenoid direction itself, patient improves, patient's voice improves. And here we are, once you judge how much depth is required, you bend with a special forceps which comes with it, pliers. You have to bend it. Then you can put this titanium implant, and it can be secured with Proli. That's what we are doing. You can see. So once that is done, we recheck again, and we are happy, and we close the strap muscles, suture the strap muscles back, and close in layer. Okay. Now these are the some of the. He had thyroidectomy, following which he developed this voice. Recognition of us.
हाँ जी, मेरा नाम जसबीर कौर है। मेरा कल ऑपरेशन हुआ, उसके साथ
Here
मेरी
we have
बहुत
done
ही
only
सुंदर
visualization
आवाज आ
of
चुकी है।
And this is the guy who came from Bangladesh.
Dr. Mohammad Tawhid Alam. I am from Bangladesh. I
He's a
developed
doctor by profession.
left-sided vocal cord procedure.
After thymectomy surgery.
That was done on.
So in this case, we had used that screw to medialize the arytenoid.
I came here, BL Kapoor, Jawar. My name is Dr. Mohammad Tawhid Alam. I am from Bangladesh. I developed first sense of voice following thymectomy operation. It was done in 2014. Yesterday,
This patient I had operated in, see, can you see the huge posterior glottic gap here? So in this case, this I operated at Dinath Mangeshwar Hospital. I think 4 years back, 5 years, 4 years. So here we had to do a arytenoid direction. And with arytenoid direction, see the result here. And listen to his voice.
मेरा नाम नरेश शाह है। 1 साल पहले मेरा ऑपरेशन हुआ था। उसके बाद मेरे आवाज़ में बहुत फ़र्क आ गया, जो मैं बराबर बोल नहीं पाता था। वो भी दूसरा ऑपरेशन किया है, तो उसके बाद अभी मेरा आवाज़ एकदम अच्छा आ रहा है।
Yeah. As I told you, we started using chiroplasty using this thing. This patient had undergone type 4 correctomy by me earlier, and his voice was very low. In this case, we didn't want to use silicone block because there is no muscle mass. See, there is no muscle mass. I'll just show you. So, yeah. See, there is no muscle mass. So we had to find out a way how to improve it. Here, you need not have to have standard big window. You can have a small window at the level of vocal cord, and you have to put strips of Gore-Tex. One with cartilage which is removed. Initially, we take 30 roll in so that we can keep it in position. And this is Gore-Tex 4 mm strip. And secured. Once it is secured, then it is approximated. Okay. This lady.
मेरा नाम कमला है, मैं यूएसए में मेरा थायराइड का ऑपरेशन हुआ था, उससे आवाज बैठ गई है, अब मैं इलाज कराने। मेरा नाम कमला है, अभी सर्जरी हुई 2 घंटे पहले, अब मेरा आराम है, आवाज अच्छी है।
And we decided that it is better we do chiroplasty with Gore-Tex. Type 2, as you know, erector spasmodic dysphonia, lateralization of cords done, reversal procedure. Anyway, this is what we used to do earlier. I did about 12 of them earlier by placing silicone blocks, but later on this is a very old video. I don't want to.
Cartilage. Applied as 2 laminae are retracted.
And the voice belongs to
and the
my dear friend Priya Datta's wife, Karuna Datta, who is here amongst us. This is what we do. We did. And what I found that probably with the passage of time, the
voice is tested intraoperatively,
coming out.
Adjust for the exact amount
we have
of
modified.
lateralization.
This time I did, sorry. Oh.
Botox injection.
We have modified this. I would say Ramalingham's modification, you can say. Because I borrowed this idea from Japanese people. They are using the titanium bridge, which they have not marketed outside Japan. So I said, why not we do in our own way? So I used the titanium mini plates to get the particular shape.
Early one morning,
and this guy had undergone 5-6 times Botox injection. He was very unhappy. So he came to us for help. So we told him that this is what I'm going to do. And in the midline, we are separating it. We are using drill also. Once separation is done, the inner pericardium is meticulously separated, and we use this silicone block to find out how much separation is required for improvement of voice. We found out it is 3 mm. So we are doing that carving with 3 mm, and here we are cutting it desired length, and this one is being given a shape so that the separated cartilages can be held in position. finally this is the shape. You have to put two, one above, one below. So once you have done, it has to be secured with proline as well as titanium mini screws. Here I am doing securing with proline 20. And once it is done, we check with fiber optic FOL, and then we are using the 4 mm titanium mini screws. Okay, and after that you close.
अप्रोक्स 1.5-2 साल हो गए थे और वॉइस मेरी बहुत खराब थी और अब मैंने डॉक्टर रामलिंगम सर के जरिए थायरोप्लास्टी
And
टाइप 2
this we
करवाई
did
है
about 2 years
और
back.
मेरी वॉइस काफी
His voice is still fine. He keeps ringing me up now and then. Type 3 shortening of vocal cords. I'll just quickly finish. This is for puberphonia. Firstly, what we do, we have to push the anterior commissure backwards so that the cord can be shortened. Again, about 4 mm we have taken, and then we cut on either side and push this cartilage. Once this is done, inner pericardium is elevated on both sides, and we push it and ask the patient to phonate. When he says that it is fine, then we try to put. Earlier I used to take suture straight away, but then I realized that suture may cut through over a period of time. So we started putting mini plates while doing the like this. We used mini plate, and over mini plate we started putting the sutures. Like this. And we close the wound.
اسمم عبد البديع از افغانستان.
This person is very typical.
24 ساله
He was about 40 something.
از افغانستان
He came
آمدم
with his
استقبال
voice.
خود عمل
And we
کنم.
said this is puberphonia. He came from Afghanistan. I operated. After operation, when he rang up his wife refused to talk to him, saying that you are an imposter. Then his friend had to tell that he has undergone surgery. While in RR we did this.
Hi, I'm
Tall,
Kumbali
handsome,
Preet,
6 feet 3
student
inches,
of Delhi
very
University,
nice
studying
boy.
BCom past first year, and I'm
But
very
he was very
uncomfortable with my
disappointed with his
voice.
voice.
It's a big downer, and I
Therapy.
think it's very
And he wanted a
feminine,
good voice.
and
He was, girls used to, mock at him because of his voice. Then we did the surgery.
My name is Binay Preet. I got my was operated
He
on
was so
26, so
grateful.
my vocal cords
After this,
operation, I
after
feel much
about 6
better
months,
now
he
because
came
I
back
got
and
a
said,
manly
"Now
voice
I am
and I'm very
participating in
comfortable with
debates.
it."
I am standing first and all that." Uh, this is type 4. It is the lengthening of cord. Yesterday I did with lengthening in the patient. What you do is you have to do cricothyroid approximation. We used to use this elastic we used to put in between and tie so that it doesn't cut through. But later on, I just quickly I'm going. We started putting the titanium mini plates over that we used to tie, so that it doesn't cut through. Thank you. Before I fade away.
అండన భీముడార్త జనబాంధవుడుజ్వల బాణ తోణ కోదండ కళా ప్రచండ భుజతాండవ మూర్తికి రామమూర్తికి రెండవ సాటి దైవమిక లేడంచున్ గడగట్టి బేరికా డాండ డడాండ నినదంబుల జాండ మత్తవే దండంబు నెక్కి చాటిదన్ దాశరథి కరుణాపయోనిధి.
Thank you. Any questions? I think we're running late, so I suggest I'll hand over to next speaker.
Dr. Neha Sood. She is currently working as a principal consultant at BL Kapoor Max Super Speciality Hospital. She is a passionate otolaryngologist with over 19 years of experience. She has done various fellowships in India and abroad. I request Dr. Neha Sood to kindly proceed with her lecture and request her to kindly stick to the time.
Okay, good afternoon, everybody. Um, I'm here to talk about on a topic called voice lift. And before I start, I think it is very important for us to realize the importance of voice. Voice, like our fingerprint, is unique to every individual, and that's the reason we know Amitabh Bachchan, Lata Mangeshkar, Morgan Freeman. If we lose our voice or the quality of our voice deteriorates, it hampers everything in our life. From our personal to our professional lives, everything gets hampered. So it's very, very mandatory to be having a clear and a good voice. Now, coming to voice lift. So before I start, this is our team, like Dr. Ramalingam just showed. Coming to voice lift, today is the era of everybody wanting to look fit. Men want to look like Hrithik Roshan and women want to look like Katrina Kaif. People are getting facelifts, Botox to get rid of their wrinkles, and they're getting fillers to get high cheekbones. So why not with your voice too? I mean, so this is what the concept is of voice lift, to enhance your voice. So why do we need a voice lift, like I just mentioned, and is it necessary? I think voice lift is necessary if you want. Oh, how do we wait, full screen? कैसे करना है? This is slideshow only. Can you make it full screen? The slideshow you are. Oh. Okay. So voice lift is important or necessary if we want to enhance our voice. So just briefly talking about the history or how was this term introduced. So initially voice surgeries or voice procedures or treating voice disorders was only done for medical reasons, for tumors, for lesions, and now we are coming to an era, like I said, where we want to enhance our voices. So this term, आगे नहीं जा रहा. It's not going ahead. Okay. I'll do it. It's okay. I got it. So the term voice lift was coined by Robert Thayer Sataloff, and it has been now progressively used in throughout the world. People are doing procedures or surgeries for voice lift. Now, who are these patients who require a voice lift? Aging voices. We all are going to age. Our voice is going to weaken. Medical disorders, young and middle-aged people who want a voice enhancement, professionals, singers, lawyers, or who use their voice a lot and tend to lose their voice because of some problem or the other. So as we all know, over a period of time, the vocal cord pliability decreases, they become stiffer, and it makes it more difficult for them to vibrate, and that's the reason the quality of the voice deteriorates. A lot of factors contribute to this. They could be genetic, our overall health, medical conditions, lifestyle factors like smoking, drinking, laryngopharyngeal reflux. So cosmetic phonosurgery or voice lift surgeries enhance these take care of these age-related changes and enhance our voices. So people who are good candidates, people who are very self-conscious about their voices and they want it to be enhanced, they are the ideal candidates. These surgeries or procedures should not be done in individuals who are themselves not ready. It's like doing a plastic surgery. If the patient himself or herself insists that this is what I want, then only you should go ahead. There are certain all the medical conditions which can lead to your voice problems can be, these can be the areas where you can go ahead and do voice lift procedures. So in all these patients, we should always try and start with therapy, neuromuscular retraining, speech therapies, exercises, medication before you plan any procedure. So as I said, we start with speech therapy. Then the next comes implants or surgeries or injections or any other procedure which will enhance the voice. Again, these should only be done once the patient has gone ahead and done all the therapies, taken speech therapy, muscle relaxation exercises, and still is not benefiting. So we need a multidisciplinary team of laryngologist, speech and language pathologist, a singing voice specialist in case we are treating singers. So how do you go about evaluating? Like any other voice disorder, you will take a history, which is very important. See the intent of the patient. What does the patient want? Talking to the patient, a physical examination, a video stroboscopy. You can do a voice analysis, a voice recording. So I will be showing a few procedures which are used to do this voice lift. The first and foremost is injection laryngoplasty. So injection can be done via two ways, transoral and transcutaneous. The transcutaneous is the most preferred or the most popular method, though transoral also can be done where you put in the flexible scope through the nose and a needle through the oral cavity. The more popular way is the percutaneous. You can go through the cricothyroid membrane, transthyroid cartilage, or through the thyroid membrane. Here again, the cricothyroid membrane approach is the easiest and the most preferred by most laryngologists. The common materials which we use are agarose, radius, and Restylane. We have used agarose in a lot of patients, which is now not available, and we are using hyaluronic acid at present. So this is a short video which shows us how this procedure is done. So the most important is our landmarks. We palpate the cricothyroid membrane, and we have to go a little paramedian on the opposite side and then view the needle from inside and then manipulate it to inject wherever you require. This is a small video of how we do this procedure at our setup. This is hyaluronic acid, which is in a pre-filled syringe. We use a lumbar puncture needle, 22 gauge. Like I said, surface marking is very important, and a good local anesthesia is very important. You need to explain what you're going to do to the patient. We give, at our center, we are giving 2% xylocaine in the skin, and we gave a intratracheal block with 4% xylocaine. This anesthetizes the larynx very well. And like you can see now that I have attached the lumbar puncture needle to the peripheral syringe, and Dr. Ramalingam is on the scope here. And after palpation, this patient has a left vocal cord palsy. So we go a few millimeters lateral to the midline on the right side. You puncture. Once you see the needle inside, that's when you start manipulating. You have to first assess where you want to inject and how much you want to inject as you're injecting. So now you will see the laryngoscopic image. Once you see the needle, and you have to manipulate it through the cord into the paraglottic space. And once you're there, because it's all about palpation and feel, so then you start inject a little bit. And if you feel that you can see the medialization here. This is a very, very good video. I think you can actually see the cord bulging, and as we are injecting, you can see the phonatory gap is being closed. This patient, along with hoarseness, had aspiration, and he was on a RT. And fortunately, and he was more concerned about his aspiration. So once we did the injection, he was off his RT and his voice had improved considerably well. So this is the same patient, and he's actually a teacher by profession, and he had CA prostate with METs. And can you hear? So after injection, नहीं, but I want the sound. ऐसे ही चलने दो, ऐसे ही चलने दो. So this is a few days. This was a few days after the injection, and the voice quality improves after 7 to 10 days when the material spreads. I think everybody can hear my 10 voices. थोड़ा इको कम कर दो please. And then you young with METs, and he was already suffering because of disease. So he lives in India and is We leave the fat for some time for the fluid and the fat to separate. We drain the excess of the fluid, and what we do is we run it through a cannula between two syringes to break the fat into smaller pieces, and this is injected under the microscope. So again, here the injection is done in the paraglottic area. We make sure that we over inject because 20% of the fat gets absorbed, and you don't want the patient to lose his voice after some time. The fat lasts longer than much longer than hyaluronic acid. So this is the voice post injection. So another procedure which can be done is steroid injection. So this technique can be used to inject hyaluronic acid too. So here we had a patient who had hoarseness of voice, and he had these small nodules. You can't call them nodules, but small lesions, and at the junction of anterior 2/3 and posterior 1/3. So again, we gave local anesthesia, and here what we did was we used a lumbar puncture needle and we bent it twice so that it was angulated downwards, and we made a thyroid membrane puncture so that the tip of the needle was pointing downstairs, downwards, and then you could manipulate it on either direction and inject. So now once you see the needle inside, it's in the midline, so you can manipulate it in either direction, the left side or the right side. So we injected this patient. This was after a lot of speech therapy and LPR treatment. He was not getting better, so we injected Medrol, and after a few weeks, these lesions had gone away. So we can inject hyaluronic acid again with the same technique. Okay, so the next procedure which can give you a voice enhancement are Botox injection. So this patient is suffering from adductor spasmodic dysphonia, and he came to us for the second time for injection. So again, under laryngoscopic vision, we inject, we do a cricothyroid membrane puncture, and we inject into the thyroarachnoid muscle. But it's just finished. The last 2-3 slides. Okay, this is his. अभी भी नहीं जा रहा है. Anyways,
suffering from HD spasmodic dysphonia since long time. Hereby visited many doctors here in Afghanistan, Pakistan.
Don't waste time. So this lady had abductor spasmodic dysphonia, and under EMG guidance, we injected the posterior cricoarachnoid muscle. Once you state the larynx and insert the needle, you ask the patient to sniff, and you know that you're in the right place, and that's when you inject. I'm sorry, the videos are not all the voices are excellent. I want you to hear the last patient's voice actually. So muscle tension dysphonia, I'll just quickly
My name is Farhad, and I'm from Afghanistan. I have this voice problem.
So he came to us with this
8
voice.
months ago. I realized it when I was in an interview. Wife, I can
He
talk.
did some laryngeal exercises, and immediately after that,
My name is Farhad. I'm from Afghanistan.
taught
I
him
came here for
laryngeal
treatment
relaxation
because I
exercise.
lost my voice some 8
Send him to
months
the
ago.
sent him to the
I
psychiatrist
hope I
for
can get well soon.
evaluation, and he's doing very well now. Okay, so these are my last two slides. This is an innovation which, this was my second thyroplasty, and this is an innovation which Dr. Ramaningam suggested, and it turned out to be great. So we've already shown you the thyroplasty. I will just show you. Now released, and making sure that they do not get loose. The last slide, I think, can be a brand ambassador for Voicecon. So this video, Dr. Ramalingam showed me.
मेरा नाम असीम भल्ला है, मैं जलंधर पंजाब से आया हूँ। मेरे को सारी मतलब लाइफ प्यूबरफोनिया था, और कुछ कपल मंथ्स बैक 2 महीने पहले मैंने एक स्पीच थेरेपी ली थी, जिस कारण मेरी वॉइस लो हो गई, लेकिन मेरी पर्सनल सेटिस्फेक्शन के कारण मैं अपनी
After a lot of conversation, he actually did it correctly therapeutic.
मेरा नाम
And this is his first surgery.
मेरा नाम असीम भल्ला है, मैं पंजाब से आया हूँ, और मतलब मैं प्यूबरफोनिया से सफ़र कर रहा था, और कुछ वीडियोस देखी मैंने डॉक्टर रामालिंगम जी की, और उसके बाद मैं स्पेशली इनसे मिलने पंजाब से दिल्ली आया, और अपनी मैंने सर्जरी कराई डॉक्टर रामालिंगम जी।
Thank you, Dr. Neha. We go on to the third speaker, who is Brigadier Rakesh Ditta. He's going to talk on laser biophysics. Knowing Brigadier Rakesh for so long, I'm sure that you'll enjoy the presentation because his presentations are par excellence. Rakesh, as a friend, I just have a request to you that please contain it to little less than the time that was allotted to you.
I'll try to catch up on time.
Hypoglycemia is setting in.
Yeah. So are we good? Yeah. So good afternoon. I know we are running pretty late, and I'll try to catch up time. It's already 1. This is a talk on fundamentals, and this is primarily addressed to the postgraduates, and essentially focused on a lot of people who are just wanting to revise their basics. Okay, so please just take it with that stride. So, in fact, this is a talk which I've taken 3-4 times earlier, and I love taking this talk because it just grasps and gets me also to understand the basics, what we are really doing. So when we are talking of light, everything actually is an electromagnetic wave. There's a theory which says everything is a wave. So this is where we start off, and we say that these waves are created as a result of an electric field and a magnetic field.
Most of them actually come from the sun. And since they're a wave, they have a wavelength and they have an amplitude, that is the power, and they travel at the very low speed of light. And when we see them, it's visible light. So we are seeing part of the spectrum. But if you see the spectrum from radio to gamma rays, you can see that spectrum and this thing. All it essentially is that it's carrying different amount of energy. But it's a miracle, it's actually the same thing. So what is laser? Laser is this particular electromagnetic wave, which has been amplified by a particular technique. Oh, let's not get into too much of theory, but it's been amplified by a stimulated emission of radiation. Basically, laser is a light, and I'll try to explain in a different context what exactly is the difference from light. White light, when we are seeing, has got many wavelengths. It's sort of a mixture of a lot of things. It's multi-directional. It's not really always going in a straight line. Even if you see from the projector, it's going like in a multiple direction. I can see it in my eyes. It's not synchronized. Whereas a laser light, on the other hand, is monochromatic. That's got a single frequency or a wavelength. It's directional, very, very directional, and it's got coherence. So what does this coherence word mean? A new word coming in here. So this is a way to understand actually. When a group of soldiers is marching, they're all the same. So what we are saying, they're all of the same wavelength. They are all marching in the same direction. And they all are coherent, they are all in the same phase. So if you understand it this way, it's very easy to understand. I think this one slide will do half the job. So if you have a group of soldiers marching down Kartavya Path now, and if you see a Bharat in Karol Bagh, you'll understand the difference between white light and laser light. A Bharat is people are randomly dancing in all over, and there are all types, and of course there is no coherence. So if you understand this, I think you'll understand the difference between a laser light and a white light. Some more basics, very, very basic thing. We use the word laser, like CO2 laser, from the medium from which it is coming. There is a machine to produce, amplify, and deliver a laser beam, which we all buy, these costly machines. And the properties, when this physics is meeting biology, when it falls on you, multiple things are going to occur. And what occurs depends on this type of laser beam and many other factors. We'll just skip to them immediately. So there are 4 effects which essentially occur when light is falling on tissue. And these 4 are on the right hand side. This is the beam, I guess. So photoablative, thermal, chemical, acoustic. Light has to give up this energy, so it can ablate. It causes some heat, it causes some chemical reactions, and it can also cause some sound. So this is how the energy is being released when a particular light is falling on tissue. So the first effect, or the photoablative effect, is what we are using diode lasers to ablate tattoos. So this is something where it divides molecular bonds, and the ruby laser is doing this. Chemical effect is, we all are more familiar with the last example, that is the photodynamic therapy, and also lasers being used for acne. And what is happening is we are inducing a chemical reaction. In PDT, what we are doing, we are trying to induce a chemical reaction which causes the damage. We are not really having laser kill anything. The acoustic or the mechanical effect is something which induces a physical transformation. Shock waves, when we are using it for geometric calculi. What we are using mostly in ENT is the thermal effects, where laser energy is being converted to heat. And if it is slowly being done, it causes some amount of coagulation or necrosis around it. If it's being done very rapidly, a very intense beam of light is coming, of energy is coming, it causes vaporization. And this can be reflected in our terminology as if we have ablated the tissue or we have cut the tissue. So this is the photothermal effect which we are talking about when we are talking about lasers. And this tissue effect depends on multiple things. The type of the laser, that is the wavelength, as we already said. The depth, this determines the depth of the penetration. The laser frequency will determine how deep it will enter that tissue. The type of the tissue, where it is falling, will it react different if it were water or bone? Yes, we'll see that. And the fluence is a sort of complicated word again, but basically means how much energy is going in a particular small area. So we have now on a surgical side 5 things to control. The type of the laser, which more or less is already mostly decided unless you are choosing between diode and CO2. So we have to choose the type of the laser, the tissue it's falling on, the size, the spot size it's falling on, the power and the timing. So these 5 parameters have to be controlled when we are using a laser beam in surgery. The laser beam, if you see this graph, it's a very interesting graph which tells us which laser beam has how much of penetration, and this is all based on the penetration is based on the wavelength of the laser, and the type of the tissue will be different. Some will penetrate deeper, some will get stopped, some, as we were mentioning in the morning, will act only when there is hemoglobin, and the next thing is the spot size. So the spot size is, obviously if it is in a small intense area, there will be more energy delivered. If it is diverse, if it's wide, it will be less. So this is also not very difficult to understand, but it's important to keep this in mind because we may use the spot size to have different effects, thermal effects. If you remember, we had thermal coagulation, we had cutting, we had ablating. The type of the tissue, which is the chromophore, which is referred to. If you see on the right hand side this graph, this is the chromophore. It tells us that which laser acts and absorbs how much of energy. So this also varies, and what is important is that carbon dioxide is something which is actually being acted upon by when we are putting it on water. The power of the laser, as we said, just see this, if it is more, with a smaller spot size, it will have a cutting effect. Reduced power with a wider spot size, it will have a hemostatic effect, and very high, it might even actually cause a bit of ablation. The next thing is the exposure time. Now this is a laser which has just fallen and caused this effect. Now the exposure time can be continuous. I have a torch and it's continuously going. I can have an intermittent sort of mode, or I can have something which is very, very fast, with that ultra modes. So this is important to understand. Why? Because when I'm continuously doing, the thermal damage will be different because it takes time for that heat to dissipate. The water is in the tissue is a sort of like a sink where the heat is going to go away. If I put it continuously, it will char, it will heat, it will cause scarring, it will cause fibrosis. There will be a surrounding zone of necrosis. Whereas if I give a very short burst and then wait, then let the heat get dissipated by the smoke as well as by the water there, then give one more, I will have a different tissue effect. So the exposure time and the pattern, intermittent or continuous, will have a very important this thing. And you can see that in this particular graph where you have a continuous mode, or you can have various pulses which are now in a position to deliver even larger energy to have an overall similar energy. No laser biophysics is complete without a bit of safety in mind, and we need to understand that lasers, when tissue is being exposed to a laser beam, it can also cause damages, and the damage is now in 3 large forms. I'm just categorizing them. A collateral damage, that is you don't hit the right tissue, you aim it separately. A laser plume, which can, because it's a tissue where we have seen that some Warren particles can actually get exploded and come into the plume, and of course a fire hazard. To prevent collateral damage, we have to protect both the patient as well as ourselves at times. So directly in the surgical field or indirectly, and we need to just keep this in mind. And you must have seen this cautionary sign, and there are SOPs on most OTs which will tell you to have a particular flashing light when the laser is being fired, and to use protective goggles. And this is very familiar. You would have a wet piece of towel which is wrapped around so that an accidental shot does not cause a damage. The next is fire hazard. Many of these gases which are being used in the airway are volatile and can cause fire, and therefore this is a very rare thing, but it's a real thing. So it's important to use precautions, and at times even these laser flex tubes or protective tubes exist, and it's advisable to use them. And the last but not the least is laser plume, as we had mentioned in safety. And what this mentions is about the toxic particles or the viral particles which are actually in the plume now, which need to be taken away. So these 3 are the points of biophysics which you need to look at safety point: the fire hazard, the plume hazard, and the third was the collateral damage which we are doing. So I think I have saved some time trying to be fast. So if there are any questions of this thing, you can address now or maybe during lunchtime. And again, in the end, I'd like to thank Dr. Ramalingam and his team for a fantastic thing, and thanks for a patient listening.
Dr. Manjunath. Dr. Manjunath is from Yashwantpur, close to Bangalore. He has done his fellowship in University of Alabama at Birmingham, USA. And he has done his MBBS and post-graduation from Yashwantpur. Over to you, Dr. Manjunath.
Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Ramlingam and his team for giving me this opportunity. I'd be speaking on office-based laryngeal laser surgery. It's interesting to note that laryngeal surgery started off in the office in the late 1800s, and with the development of better anesthesia techniques, it moved on to the operating rooms, and then in early 2000s, we started making its way back into the office with the development of better endoscopes and fiber optic fiber lasers. So it all started with Zeitels publishing his paper in 2007, started using for basically papillomas and dysplasias with a pulse dye laser. And it's been shown to be very safe and effective. There have been many papers on this. So this is a setup. You need a processor and a scope. You can either use a transnasal esophagoscope or a bronchoscope or even a laryngoscope, flexible laryngoscope with instrument channel. Only thing is with the laryngoscope, you won't be able to pass through the beyond the glottis and suction out the secretions if there are any. Obviously, a medical grade monitor will help. Endoscopic forceps, especially if you have to take a biopsy from leukoplakia or anything like that. And the lasers, there are many lasers, KTP, diode, thulium, others. Suction, obviously very important, especially to suck out the plumes or secretions from the tracheobronchial tree. Coming to the scope, like I said, you can either use a flexible bronchoscope or a TNS scope with digital chip technology. 4.5 to 5.2 mm scope can be easily navigated through the nasal cavity. Working length is usually around 600 mm, or if you are using a laryngoscope, it's 300 mm. And this is the cross section of the scope. You have the camera here, the tool, the fiber optic, the light fibers, and this is the working channel with the laser fiber, and the instrument channel is usually around 2 to 2.2 mm. Lasers, these are some of the lasers that have been used for office-based laser procedure. The commonest used is the KTP and the pulse dye laser. What I use in my routine work is the diode laser because it's quite economical. And sometimes I've also used a holmium laser because holmium is always available in most of our hospitals since urologists use that. and KTP is quite expensive, and that's the reason, I mean, I've not been using it. Anesthesia, lignocaine is a commonly used anesthetic that's been used. We all know that it has a duration of 45 to 60 minutes and onset of action within 90 seconds. This is the maximum dose that you can use, and usually around, it comes to around like 2% xylocaine, it comes around 10 to 15 cc's. Toxicity, CNS toxicities or severe CNS is more common, like dizziness, lightheadedness, visual disturbances, tinnitus, and in some severe cases you can have seizures as well. Allergy is very rare. So what are the indications for office-based procedure? It's usually for the treatment of vascular lesions like ectasis and varices. Can also be used for epithelial and subepithelial lesions like nodules, polyps, papillomas, keratosis, webs, etc. Can also be used for treatment of stenosis in the subglottis as well as in the trachea. Contraindication, these are basically relative contraindications. They're not absolute contraindication as such. Unstable cardiopulmonary status is one of them. Anxious patients, sometimes, I mean, you can counsel them. Sometimes, I mean, they're too difficult to counsel, especially if they have a very bad gag reflex, then they're not good candidates. Allergic to local anesthetics is very rare, but if you know they're allergic, then better to avoid. Large lesions, you may not be able to do it in one single go. Either you can do it in the operating theater, or you can just stage the procedure like 2 or 3 times. And malignancies, obviously, at present, they're not an indication, but we don't know. Maybe in future, there may be an indication. It's not moving. Yeah. So this is how I understand. Different variants of and this is one way of it. What I commonly use is the gargle technique. Here, have a bronchoscope, somebody has to keep at a time or half an hour at a time. Have a kinescope, spread and the instrument channel, and in section you can just make the xylocaine drip down. So that is much better compared to your bronchoscope for these purposes. This is a polyp excision. Of course, this is not a laser thing, but I just wanted to show this because I mean, even with the this thing office-based procedure, you can get a good result. Yeah, and if you have a left-sided lesion, it's much more easier. If you have a right-sided lesion, you can either do it in the same way, or you can just rotate your scope 180 degrees so that the lesion comes to your left. This is because the instrument channel is to the left, I mean to the right of the patient, and the camera is to the left. By rotating the scope, you get a better view as compared to, especially if it is an very close to the anterior commissure. And any blood trickling down can be sectioned off. And this is a case of anterocommissural webbing post leukoplakia excision. You can see there is still there's a little bit of recurrence on in the anterior commissure as well as some webbing. So I'm using the diode laser here to ablate that keratotic plaque as well as excise the web. Diodes. Diode, and if I'm using it on a vocal cord, usually I'm very low on the settings, like about 2.5 to 3 watts. But if it is for a tracheal, or a subglottic lesion with a stenosis, usually go higher up, like 8 or 10. And you may ask, like, there will be again, there will be a recurrence of the web, but fortunately with the diode laser, I have not seen much recurrence when you excise the web. And like I said, if you want to see the anterior commissure much better, you can always rotate the scope 180 degrees and then you can work. He's been on regular follow-up and I've not seen recurrence. In fact, he's from Dibrugarh, Assam, and I met him recently on my trip to Arunachal. Before coming here, I was in Dibrugarh. So I just spoke to him and he's doing well. Yeah, just for want of time, move on. This is a case of recurrent papillomatosis. Was operated initially in the operating room when he came with large fronts of papillomas, and then yeah, after 3 months or 4 months, he just had some recurrence anteriorly. So I'm just ablating that. Office laser procedure is a very good tool for papillomas because they keep recurring. So every time taking them to operating room will be quite a burden for the patient. So if you ask them to come every 3 months, and if I see small fronts of papilloma, I just remove them in the OPD itself. And there will be laser plumes. There will be plumes from the papilloma, so it's better to use N95 mask when you're doing this. Just ablate whatever, and sometimes even the NBI and or the eye scan will be of use here. One difference between KTP and diode is that KTP is, this is a contact laser and that is a non-contact. So in non-contact laser, you can see the tissue and laser interaction. However, it's not possible in the diode laser because you have to take out your fiber every time you burn some tissue and then see the interaction. But the advantage is, yeah, there's less of collateral damage with the contact laser. And this is 3 weeks after the procedure, and there's no recurrence as of now, and there's no webbing as well. So this is an interesting case of tracheal granuloma. she had a, tracheal resection and anastomosis. She had a very long stenosis, about 6 rings, and then it was a long-standing tracheostomy as well, like about 15 years. She was tracheostomized 15 years back for OP poisoning, and then she had a tracheoesophageal fistula, so I had to repair the tracheoesophageal fistula, and then do a resection anastomosis. So posteriorly, she developed a tracheal granuloma, and this was ablated using laser again. Here I'm using a very high wattage, about 8 or 9 watts. This was something around 3 weeks, 3 months post resection anastomosis. She didn't have much symptoms, but to be on the safer side, we just removed it. She was able to walk 2 flights of stairs without much difficulty. And operating on trachea, it's much more easier as compared to the vocal cords, because vocal cords are always mobile, whereas in trachea, you can go on for a longer duration without much difficulty. So this is post procedure, and you can see the granuloma has been completely removed. Of course, there is some scarring from the resection anastomosis, because since it was a long segment. And this is one more case. He came to me with very bad stenosis. In fact, the stenosis was inferior to the tracheostoma. And he came on a wheelchair. Actually, he was so bad, and then initially treated with this thing, operating room procedure, endoscopic techniques, and this was very low. Just like 2 or 3 rings above the canine. We didn't go for the resection anastomosis, to endoscopic technique. So then I was decannulated by the time on the area, so it was decannulated again. Didn't opt for the resection anastomosis, went for this. And this is a subglottic stenosis. This is after 3 weeks, and then after 3 months, I guess. So has been doing well. And this is a case of scarring at the bronchus level, at the lingula. This is a patient with venous granulomatosis, had his subglottic stenosis corrected with the laser procedure, and then we saw there was some scarring at the bronchus as well, at the lingula, the superior and the inferior lingula, and then this is a KTP laser being used. So you can see there's some opening of the scar band. The inferior lingular bronchus was scarred. So with a good anesthesia technique, you can go, I mean, this is to demonstrate that you can go as far as the bronchus level as well. It's not just the larynx, go up to the bronchus. And this one was done just last week before I came here. And then this was a papilloma over the base of the tongue. And this was done, I mean, my friend who had bought a the disposable scope, the ambu scope. So he just wanted me to try in that. So this is a papilloma on the base of the tongue, and then the same diode laser, but only thing the scope is different. The scope is a disposable scope. So quite okay, but not up to the, I mean, the regular scopes. And every time you fire, there is some flash of light. Yeah. Okay, I'll just fast forward this. Okay, so what are the advantages? Obviously, it's economical, it's safe, and it saves time. You just need 30 minutes for, if you need 10 minutes procedure, you will be in the operating room, it will take 1 minute, 1 hour. So, and better autonomy for the surgeon, you can choose your time of procedure. It's not dependent on the operating room timings. Obviously, privacy for the patient as well. So in my experience, I mean, I've been doing this for the last 6 years, more than 100 cases. It's mostly for the airway stenosis and papillomas, and sometimes for pre-malignant lesions and polyps as well. Toxicity, one case of lignocaine toxicity resulting in seizures, and this was in fact my first case. The first case went for a seizure, and then instead of stopping the procedure, I mean, following that, I started thinking what went wrong. Indian patients have less tolerance for lignocaine as compared to the Western patients. So Western patients, we were using 4% lignocaine, and then started using 2% lignocaine. So, and then from then on, I've never had any toxicity issue. And one case was abandoned midway because of patient anxiety. I mean, he had half a granuloma removed, and then we completed the procedure later on in the operating room. So what the future holds is, like Zytals predicted in 2007 that by 2020 there will be 0.1 mm endoscope and image guided laser surgery aimed at intraoperative tumor margin. This was his prediction, but unfortunately we are no way closer to, as far as this 0.1 mm endoscope is concerned. Right now the smallest endoscope is 1.62 mm, developed basically for middle ear evaluation through the transnasal route. And but as far as image guided laser surgery is concerned, we have come a long way. NB has better diagnostic accuracy, and this has been shown by many papers as well. Yeah, thank you for your attention. If there are any questions, I'll take, or else we'll discuss in the lunch. Oh, thank you. Thank you so much.
Last speaker today, he is Dr. Sachin Gandhi, and he is going to talk about the lasers in early glottic cancers. Dr. Gandhi requires no introduction to this particular audience who are interested in laryngology. He is in fact has been the voice of voice surgery in India for the last 3 decades or so. Trained in Pune and currently the head of Department of Laryngology at the Dinanath Mangeshkar Hospital. He has had innumerable amounts of awards and association memberships. He has been conferred the fellowship of the Royal College of Surgeons, and he also conducts fellowships in laryngology accredited to Maharashtra University of Health Sciences as well as Royal College of Surgeons. Dr. Gandhi, it's such a privilege to have you here. Over to you.
Thank you. We'll just go fast. I mean, mostly on the images and the clips. Let's hope we'll get the text. Thank you. Thank you very much. Okay. It started with punch forceps. So, management of early glottic cancers endoscopically or transorally started with punch forceps in early 19th century. Then again diathermy was used, cryotherapy was used, and then started with CO2 laser by OSOF, and then again it has gone ahead from CO2 to KTP laser and other modalities which has been described. We'll go one by one. So basically, indications with which the patient comes. These are for just the beginners in their practice or in the field of laryngology. So basically, a short history of dysphonia. You have to not to miss exposure to tobacco products, any chemical industry, alcohol giving rise to reflux and developing into malignancies in the glottis, which is well known. What could be the gradation or grades? Basically indicated for carcinoma in situ, T1A, T1B, that means limited to one chord extending to the opposite chord without restriction of the movement. T2A, when you can see the carcinoma going on to the opposite side, but with the reduced movements, that is T2B, there is a conflict. People going along with Steiner would operate them transorally. People going along with Remakel or maybe me would not really operate and send him to the oncologist for surgery, laryngectomy. Histopathology, because we have been seeing different types of carcinomas, chondromas, and many other types of carcinomas, this laser surgery should be limited to squamous cell carcinoma of the larynx. This has to be kept in mind. So we have to confirm on histopathology it is a squamous cell carcinoma and not other variant of the cancers. We have already seen this in the morning lectures. Laryngostroboscopy, high-speed camera, eye scan, NBI. Whether imaging is necessary when both the cords are mobile and you see a likely malignancy on the vocal fold? I don't think so. I don't do for each and every patient. But in which patients I would definitely like to do imaging would be the lesion in the anterior commissure or anterior one-third of the cord, just to rule out the invasion of the thyroid cartilage. So that would be the indication when both the cords are mobile and there is a suspected malignancy. Again, transoral laser surgery, radiation. Most of the institutes or most of the surgeons sending the patient for radiation. Partial laryngectomies have been described, were quite routine maybe 20-25 years back, but because of advent of radiation and transoral laser surgery in many of the institutes, it is rarely practiced nowadays. What type of excision we have to do? The margin which we have to cut, because why we go in for radiation or transoral laser surgery? Because of the functional integrity, or we want the phonation to be as normal after the surgery as possible. To have the phonation as normal as possible, you have to cut, not maybe radically, but with a good margin. What would be the ideal margin? Is 2 millimeters surrounding the tumor. There are people who are saying, why 2? Why can't we have only 1 millimeter margin? And that is called as ultra thin margins. Okay, but I have practiced this, I have tried this, but really this 1 millimeter margin really gives away. I mean, it's not that tissue which you can again hold with the forceps. So it tears in between. So I think 2 millimeter margin in routine practice would be enough to have oncological removal, binding towards oncological principles, and having a good phonatory outcome. So narrowband imaging, again just to summarize, enhances the contrast of the mucosal surface without the use of a dye. So no need to pass in a dye and then enhance the or differentiate between the surfaces. Early diagnosis, basically important is the extent of lesion, because again you are going to do chordectomy, you are going to remove, and if you want to have a good functional outcome, then you should know the extent of lesion so you can focus or limit your surgery. Okay. To check the margins after the resection, you can put in an NBI and check the margins are free or not with the help of photo diagnosis, or this is NBI. You can see with these images. So this is the lesion, and you can see really the interface between the normal mucosa and the pathological tissue. So these are the normal vocal cords and it is the pathological tissue. So you can limit the surgery in this particular area and not extend beyond or deep into the tissues. And how this will help is optimizing the preservation of the normal mucosa, again giving good phonatory outcome. I mean, just to summarize, what are the disadvantages or what are the limiting factors for radiation? Because IMRT or IGRT, which are the better options for radiation, giving minimum side effects like swallowing difficulty or respiratory distress after the radiation. There are only few centers in India, so patient has to travel, go there, find a residence in that particular place, stay there for one month, and then come back. So there are only few centers along India, and really cobalt and the therapy is not really indicated or not has been advised as a therapy. So this is limitation of the centers across India. So patient has to spend not only for the treatment but for his stay and post-operative swallowing difficulties and breathing difficulties. Just a bit about papillomas presenting as malignancies on the vocal fold. When you see a young patient having diagnosed of a squamous cell carcinoma on the vocal fold without any risk factor, that is a 23 years old male patient having squamous cell carcinoma of the vocal cord, but you go into detail and there is no history of any tobacco consumption, chemical or any other thing, then what could be the etiology? The patients and relatives are going to ask 10 times. You should also think why he has developed a cancer there. What you have to do is send that for checking is this tissue having HPV virus. So HPV serotyping has to be done for these patients. These labs are available in Mumbai. Your pathologist will send it and then check whether this is HPV positive or negative. If it is HPV positive, then you know the etiology of that cancer, and if it turns out to be HPV positive, then these tumors are quite radio sensitive. Okay. Yeah, space. Yeah. And if again radiation for, if there is a multifocal papillomas, then you send the patient for radiation. If it is a localized papilloma, turns out to be malignant, maybe I am doing and I am going to publish this series, you can do laser chordectomy and keep a follow-up with PET scan and again NBI and stroboscopy. Okay, the advantages again, this is low cost because this is one session management plan, useful for young patients, because young patients given radiation would develop radiation induced carcinoma, second primary after 25 years. The most important practical thing is revision surgery in case of recurrence. If it recurs after radiation, then patient has to go in for laryngectomy. There is no other option available. Even if it recurs within 2 years of radiation, no oncosurgeon would really, and I will not touch that patient for laryngectomy. Because why? Because the wound doesn't heal. I always tell the patient that your expenses would be more for antibiotics rather than your surgery. Because I have seen these patients really developing tracheocutaneous fistulas. So 2 years you have to manage if there is recurrence by just doing laser surgery transorally. Then after 2 years going in for laryngectomy. But if after laser surgery you can repeat it twice or thrice. I have repeated a patient, he's coming in for last 10 years to me, and I have done his laser surgery for the recurrence 3 times. And even if it recurs, then you can straight away send him for radiation after 10 years. Okay. Okay, now only thing is, what about the functional outcome as we compare radiation and laser surgery? So the functional outcome as far as voice is concerned are quite equal whether you give radiation or do chordectomy, laser chordectomy. And this paper, many papers have been published, and I don't know, but my article also has been published. I have compared patients with radiation for head and neck CA and my own chordectomy patients, and functional outcome is equal for in both these groups. Okay. Histopathology I will just tell you, all these points have to be communicated with your histopathologist while they are checking the margins. The first millimeter has to be neglected by the pathologist. Why? Because the tissue shrivels and there is always a thermal damage for the 1 millimeter. So they have to discard 1 millimeter and then start checking in for clearance of the disease. Preservation, there are multiple techniques. How after the surgery, still the patient has good voice. I always tell my patients, immediately following the surgery, the patient would have hoarse voice because he has lost that particular tissue on the vocal cord. But after 3 to 6 weeks, as the wound heals, he will start having a normal or near normal voice, and this is because of the neocord formation. Always. So I explain to all these patients, because remember, patients when they come over, the relatives and patient would say, आवाज गया तो भी चलेगा, लेकिन ये कैंसर अच्छा करो. But you operate, the next day you are going to start getting calls from their relatives and their referring physician की आवाज आएगा, आवाज कब आएगा. So you have to explain to these patients, and this is very important. Remember, we are going to go ahead how to get back. Okay. And again, now see, this patient has undergone type 5A chordectomy. That means that the lesion was in the anterior commissure. So after the surgery, the disease was cleared, but he developed anterior web. But still his voice was nice because the surgery was limited to this anterior commissure only, and you can see the mucosal waves on both the cords in the remaining tissue. So it's not, I mean, so you limit your surgery. This is on a high-speed camera. So preservation of normal mucosa in the remaining vocal cord. Then you can use various techniques to reduce the thermal damage, like hydrodissection, ice and cold saline application. You can again go in for ultra pulse lasers, sharp scissors, just to cut over the non-adjumatous tissues. Again, you should have a good exposure with various anesthesia techniques like apnea technique, high frequency jet ventilation. We are going to see them as we go along. Now, how much to cut? So these chordectomies have been devised as you go deep into the vocal cord tissue. Okay. So when you excise only the epithelium, it becomes type 1 chordectomy. When you go deep with the epithelium and lamina propria, then it becomes subligamentous chordectomy or type 2. So you have included lamina propria, the ligament and the epithelium. If you remove 2/3 of the muscle, vocalis muscle, it becomes type 3. When you go up to the thyroid perichondrium, it becomes type 4. when the the excision goes beyond the membranous vocal cord. That means the anterior commissure, the arytenoid, the supraglottis or subglottis. Then it becomes extended chordectomies. So only the epithelium type 1, epithelium plus ligament type 2, epithelium, ligament and vocalis muscle 2/3 of it type 3, perichondrium type 4, shown in these figures. These are the figures are drawn by my fellows. I think this is by Darshil. No? Now extended chordectomy involving the anterior commissure, 5A, extended chordectomy type A, posterior lens type B, 5B, ventricular fold, that is superiorly, type C, below into the subglottis, type D. So these are all manageable cases. I mean, I'm not going to show, trying to tell you how we do it, but this is all possible, and you should know the anatomy by learning the pathologies. So just to go ahead fast, superficial epithelium, that means carcinoma in situ. So this is type 1 chordectomy when there is a leukoplakic patch or carcinoma in situ. This is all pre-op and post-op images. Now subligamentous type 2 chordectomy is when this is pre-op and this is post-op. So the vocalis muscle is intact, the ligament and epithelium has gone. Now why you have to remember this? Because when you remove this much of the tissue, then this automatically becomes a phonosurgical procedure because the bulk of the vocal cord is still there. And type 1 and type 2 chordectomies would become itself a phonosurgical procedure. Now this is a lesion. Brigadier Stellingen, I will finish in next 5 to 7 minutes. So this is the lesion. This is after chordectomy. This is, I don't know. Sound ka? Voice lecture. We'll see a few clips I will cover. Yeah. I can hear, but I don't know. So type 1 and type 2 doesn't need any phonosurgical correction. When you go deep, you remove bulk of the vocalis muscle, that becomes type 2 chordectomy. I think we'll just okay, let the clips go along. Now this phonatory gap would be more after the surgery in these cases. So these patients would require phonosurgical correction, and they have 1/3 of the vocalis muscle in which you can inject fat and have a good phonosurgical correction. It's not going ahead. Just remove that. This is type 4 when you have reached up to the thyroid pericardium. In this case, you have to do thyroplasty, as Brigadier already have shown in one of these clips. Okay. Now just go in short. I will explain you. So you have to use. You have to have a good diagnosis. You can use multiple techniques. I am using a 3D camera to just check the depth of the lesion. NBI to check again. We have already seen stroboscopy to limit check the lesion. See the mucosal waves normal on the left vocal cord and absent on the right vocal cord. Now just principles. One, first is you have to have a good diagnosis and check with the endoscope. So you have to check with the 0 degrees endoscope, the lesion. Then you have to check the lesion, the extent. You have to check the anterior commissure, the lateral extent, and the extent below the vocal cord with the help of 30 and 70 degrees endoscope. For any transoral laser surgery, you have to see all the borders of the lesion. Unless you see all the borders, don't start excising either with scissors or laser. So this is the undersurface of the vocal cord I am able to see with 70 degrees endoscope and nicely the anterior commissure. Okay. Again, a retraction of the ventricles to expose the lesion nicely, do hydrodissection here to limit the thermal damage and have a good mucosal preservation. So these are principles of airway surgery, but this is more important for cancer because you have to have a good oncological clearance of the disease. I think I'll show you flick clips and then we will stop. And you can excise, you can mark the incision first. Always mark the incision first and then start excising from below upwards. Don't start from anterior to posterior, always start from posterior to anterior. Why? Because if there is a bleeder, the blood would come down and we can suck. But if there is a bleeder anteriorly, it's very difficult to clear. So it's always start from posterior to anterior end. Okay. Then completion of excision. After the excision, again check with 0 and 70 degrees whether you have cleared the disease from all along. Always take a linear incision and not a curved or a circular incision. Okay. Because this is the principle of phonosurgery. Because edge to edge contact is important. For always remember, vocal cords are not like a paper. They are three-dimensional structure. Okay, so they always have a base. So you have to also remember not the margins but base of the tumor also. Okay. Yeah, your histopathologist has to check. This is just type 3 chordectomy, a lesion going to the opposite vocal cord. This is a lesion going up to the opposite vocal cord. Remember, I've been telling you when it goes along the anterior commissure to the opposite cord, check the clearance of the thyroid cartilage. And when you excise, you have to excise it from the thyroid cartilage and go and dissect the thyroid cartilage also. This is just last week I've done. This is 24 hours after the surgery I've done the stroboscopy. It's showing the thyroid cartilage. Just a short clip of this patient. This is pre-op stroboscopy. This is endoscopic. Then again marking the incision. Just wanted to show you the clearance in the entry curvature. Okay, we'll just. Two minutes, we'll finish. Yeah. I'm just going to show one clip of KTP laser, and that's actually all. And one fat augmentation after type 3 carotidectomy. Let it go. He has already shown Manjunath, but remember, OPD procedures are patients who are unfit for the surgery. I'm not going to show in detail, just going to show you the patient. See, no neck extension, diabetic, hypertensive, small mouth opening. I will not try to fast forward it because then it will again hang over. इधर क्लिक करे तो प्रॉब्लम यहाँ कर सकता हूँ now I am using KTP laser for T1 lesions but which are bulky, and then following these patients after 3 months and taking a margin with the CO2 and checking the margin completion. So 17 cases, this paper is again due for publication. Only one case. So this is fat augmentation. So there is this is the last slide. So this case, pre-op stroboscopy, growth on the right vocal cord, underwent type 3 chordectomy, that is removed bulk of the vocalis muscle and injected the fat when I confirmed the margins were free of tumor. Actually, we are not able to hear the voice. And this is after 12 months of fat augmentation. There is a good glottic closure and good voice. We are not able to hear the voice, but that's okay. Okay, I think that's fine. Thank you.
So much, Dr. Gandhi. With this, we come to the end of this session.
These are my present publications of all these series which I have done. I have published around 3-4 papers. See, the 5 year survival is 93.5%. This is my own series, and larynx preservation rate is around 99.3%. So I think everybody should learn and try to get over these patients with good diagnosis and laser surgery. Early diagnosis, good diagnosis.
Yeah, with that, we come to the end of this session. And of course, I'm sure that you are all waiting for the next session, which is lunch. Thank you, ladies and gentlemen, for being a very pleasant audience.
I would like you to please felicitate the speakers, Dr. Ramalingam.
Come closer.
Dr. Neha Sood. Dr. Rakesh Datta. Dr. Manjunath MK. Dr. Sachin Gandhi. I'll request Dr. Ramalingam to please felicitate the chairperson, Dr. Major General Dr. Girish. Captain Himanshu Swami. The next session will happen after the lunch. We all.
Lunch is laid out on second floor. Please proceed there, and we'll assemble here in another half an hour's time. Thank you.
सब क्या
Good afternoon, everyone. It's a pleasure to be here. And without wasting any more time, I hope all of you please wake up after a nice, sumptuous lunch. It's my pleasure to invite Dr. Rakesh Srivastav. He's a senior consultant laryngologist at Lucknow, and he's been doing a lot of surgeries. I think everybody knows Dr. Rakesh. He needs no introduction in the field of laryngology, and he's been the organizing secretary of International Conference of and on voice disorders, and he's a life member of the Association of Phonosurgeons. I welcome you, sir. Look forward to listening to your talk.
LVA for inviting me to talk one of the upcoming part of in medical specialty, especially in healthcare sector, that is artificial intelligence in laryngology. I have been into this field for last maybe 13 months after I read about DeepMinds and reading about the child prodigy that is Demis Hassabis, who has influenced me because he was the CEO and founder of DeepMind and the father of deep learning, that is Geoff Hinton. So from that I got into it, and then I realized I was already late by almost 6-7 years to venture into this artificial intelligence. And now it had got a major thrust in healthcare sector. So I thought I should also start some project. So I got hold of engineers from IIT Kanpur and TCS. And then finally we did one study, which is now at the verge of publication. And I'll be presenting the preliminary findings. So it is basically made of binary classification of benign and malignant on the basis of white light and narrowband imaging of laryngeal cancers. So without going into the detail about the history, I think the turning point in deep medicine started off in 2000 and in late 1990s, when this concept of deep learning has come up. It was the father of deep learning, that is Geoff Hinton, who has given a new name for this artificial intelligence, that is deep learning, and how the convolutional neural networks, which helps in classifying the various patterns which we see on imaging. And the major breakthrough, which is I think the Nobel Prize winning break in artificial intelligence, it has come up in 2018 when AlphaFold has been introduced into it, and it was the unfolding of protein, which is going to tell about the disease pattern, the drug research, the target of the drug, genomics, everything is based on this AlphaFold, because this was a major discovery which was done by DeepMind, by the team headed by Demis Hassabis, and which will lead into the faster research into, we have seen it in COVID time also, the immunomodulator which has come up because of the research by artificial intelligence. It has come up into the market within a short period of time, within a month time. So global artificial intelligence, if we see it is going up, the investment is going, even in India, if you see the figure, the market is going by 42%. Indian healthcare industry is going by 50% during the forecast period. And if you see it in US also, it is multiplying at very fast rate. So coming to the component of what is artificial intelligence, we are most of us, we are using AI on our mobile. We are using Siri. We are using various other applications like Alexa. They're all based on AI. There are three main components, that is artificial intelligence has got a machine learning and natural language processing. So machine learning has got deep learning, which I will cover up in my further talk, because the uh, the imaging part of our healthcare, which has got almost the 80% of the data, is based on images. So everything starts from deep learning, and that is how we'll come up one by one, and I'll show you how it can be applicable in laryngology practice. So what Dr. Eric Topol has said, eventually doctors will adopt AI and algorithm as their work partners. This leveling of medical knowledge and landscape will ultimately lead to new premium to find and train doctors who have the highest level of emotional intelligence. And he has written a very good book. I think every doctor should read that. That is Deep Medicine, and it is available on Amazon. So that is a starting point, and he is supposed to be the father figure in Eric Topol on artificial intelligence. So what is deep learning? Deep learning is basically it is drawn from the concept of biological neurons, which everyone having in their brain, and it has got a multiple layers of perceptrons. So what are perceptrons? They are basically neurons. So whatever input we give, it has got multiple hidden layers, and it gives the output. So like we have in brain, so like in our brain, we give an input through the dendrites, it goes into the cell body, and through that it goes into the axons, that is the output. But in that part of it, there are multiple layers. So whenever we give an image to a model, so it analyzes all the edges of that. So what the images? Images are two types. One is RGB images, we all know about white light images, and other are the gray image, that is black and white. So what it does, it divides into various pixels, and every pixel has got its own value. So on that value, it decides about the how the image will look like. So once we start analyzing an image, we divide data into data sets into a training image, the training data sets. Then there is a testing data, and in between the training and testing data, there is a data which we call as validation data sets. So what is a training data set? Training data set is, suppose I'm a laryngologist, I seen this laryngeal image, I diagnose it by labeling this is a benign polyp or benign nodule. So that is a training image. So what the computer does, once it is given an unknown without label image, it start diagnosing that this is a polyp of the vocal cords, or this is a mild dysplasia, look like a mild dysplasia or leukoplakia. So that is how the evolution starts. And what models are there? Models are already there in the market, and they are basically all the models which are computer generated. They are basically meant for RGB images. Like we have a cat and mouse, we have a table, chair, like that. So on those models, we run this medical images. But now the medical images data, the model has also come up, like BMNet models are there, which are specifically meant for the medical imaging data. So without going into the detail, because this is a part of deeper part of the mathematics part of it. So we don't want to go into codex how that is done, because this has been done by the engineers with whom we are working. So but basic thing any doctor should know about what are the training data, what is the testing data, what is validation data. So whenever we are taking some project, we take suppose 100 images of laryngeal images. So we divide it into as a 70% as a training set, then 15 images for the validation set, and 15 images for the testing images. So we test that our whatever model we have created in training images, we test it on the testing data. And then we predicted that our model is predicting a correctness in the model is that it is 90% correct or 97% correct. So that is how the computer reads the image. So it focuses on region of interest, then it divides into multiple layers, and then it focuses on suppose this is a squamous cell carcinoma image, histopathologically. So one by one it starts focusing, and finally it comes to the last output, that is keratin pearl and nuclear cytoplasmic ratio, and then it comes to atypia, and then it finally gives the impression that this is a squamous cell carcinoma. So like that, the computer analyzes it. So for any project we start doing it like that, we have to know a few basic things, because we all the doctors, we know about sensitivity and specificity. So, but engineers, once you start working with engineers, they use different terms like recall and precision. Because, but if you see it, it is recall is same as sensitivity, but precision is little bit different from specificity. Specificity means we always talk about the negative values, and specificity means how many are positives. So if you take it like that, because these terms you should know once you start developing a model and you are working with the engineers. So this is a very common chart, we use it. This is has the condition true positive and false negative, that on the one side of it, this is known as sensitivity, and does not have the disease, that is false positive, which are otherwise they are negatives, and they are true negatives, which are specificity. So specificity, we always talk about the how many we are able to tell the whether this is a malignant or whether this is not a malignant. So not a malignant is very important. Labeling a patient with a cancer who does not have a cancer, that is specificity is very important. And then we have to know about the positive predictive values, that is the true positive and the false positive. False positive, they are not having a disease. So predictive value is very important for diagnosing it. Now coming to if you see the recall and sensitivity, they are the same. That is true positive divided by true positive plus false negative. And if you see the sensitivity, that is also the same. And there is another term which is often be used by engineers, that is F1 score, is an average of precision and recall. That I will come later in my discussion on it. So true positive rate is true positive divided by true positive plus what are the false negative. False negatives are basically are positive cases, and false positive are false positive divided by false positive plus true negatives. Another term which is often being used in artificial intelligence, that is ROC curve. So whenever we are dividing the data into two sets, that is in binary classification we call it as a benign or malignant. So two ways like that, whether this is a cat or whether this is a dog, like that. So if you see it is a receiver operating system, it has got a true positive values and it has got a false positive rate. So on this data we decide, we give the prediction, like if the curve is more on this side, more towards left side, that means your prediction value is very good, that is 0.9 or higher than that. So area under cover is, they are true positive and the false positive, the area under cover, which we represent by 0 to 1. So if it is 0, that means your model is not good. So if it is 0.8 or more than that, it means your model is working very well. Now coming a little bit about the what are the where the AI is used in practice. We are using in various forms. One is a machine learning algorithm can be applied different types of data, including numerical as well as complex image and video data. Cloud video intelligence has often been used in robotic surgery. Like robotic surgery, if you this type of software will remember that how many times in a surgery you have used this forceps, whether you have used a RT forceps, like that. So all the data will be there, and from the next time the computer itself will start analyzing that which instrument will be required for that. for that particular step. So cloud video intelligence is that part. Natural language processing is used in OPD, and also now it has been used in OR also. You don't have to just if you are, even if you are speaking on the at the time of surgery, it will start dictating it. It will have automatically that feedback will be there, and it will start writing the operating notes. Virtual scribe is used in now the very common during the COVID time. People are using as a OPD chamber, and there are many AI-based medical transcription format is also there. So whether there are other indications like BCI's EMR, BCI is basically brain-computer interface. I'll just move forward that AI companies in US and India. In India, there are many companies which are working on AI healthcare, but the main ENT practice, they are Cure AI. They are doing a wonderful job because they have got C certification. Many C certified algorithm are there which are used by even in NHS. It's like X-rays. So X-rays, they are using it for diagnosing tuberculosis, pleural effusion, pneumonitis, like that, without a human intervention. So with that software, with more than 90% sensitivity, they are using it. And in India also, people are trying to develop that. Many projects are going on that X-ray and imaging part. So doctors who are using, or the radiologists who are using imaging as a MRI, CT, they are in danger, because if the AI start diagnosing it correctly, and we are seeing it every day that radiologists miss the diagnosis. So if AI has got a 0.9% value on ROC, so it will have an impact on the practice of radiologists. So doctors with pattern like dermatologists, there's a one company in Gurgaon itself who has developed a derma app, which is now being very frequently used to diagnose various type of skin lesions. So and these few are approved by US FDA also. If you start writing about an article on AI, you have to follow this guidelines which has been given by AI Consortium. That on that lines you have to write an article, because there will be doctors, there will be engineers on into it, and there are many parameters you have to consider it before writing any article on AI. So just a brief about what AI has done. You have seen the retinoscopy. Diabetic retinoscopy has now been, and it has been done by Google Alphabet, and it has got a very high sensitivity and specificity that, and they have used the Indian data from Arvinda, and there is another hospital in South. They have taken 130,000 images, analyzed by 54 ophthalmologists, and then they come down to 9 retinal specialists to label them. And it has got that much prediction value that even in a grocery shop, you can go and just get your retina examined, because we are seeing so many cases of diabetes with the diabetic retinopathy is rising incidence. So application in otolaryngology is very wide. Is from starting from BERA, you can diagnose it very easily. There are temporal bone scan which has been used for otologic surgery, genomic prediction for squamous cell carcinoma, acoustic voice features, robotics, now being used with AI. And there is a combination of brain-computer interface with artificial intelligence. Maybe in future time we'll see CI will be CI will disappear within 4 or 5 years with BCI, because now Neuralink has come, and there are 3 more companies which are working on brain-computer interface. So they are based on whatever thought you have it, the bionic part will do it for you, like lifting an object in a amputated arm. So the thought will go into the brain-computer interface. It will work like a search, and it will do the motor activity what you thought of it. So CI is, if the BCI has taken over, then CI has got and it is less invasive, except for the Neuralink electrodes, which are invasive one, Other has come up through jugular. They can go up to the superior sagittal sinus. They can use it auditory cortex sensation, and then it can be used for the speech recognition. So for cochlear implant to brain computer interface, that will be the future of it, and this all is based on AI. This is another interesting article which is written by an Indian. It is published in Translational Medicine. It has been reported very widely by Eric Topol also, that this is a simple test which we do it with any mobile app. So app, you have to download it, you have to put it on the patient ear, and there is a few fine chirping sound it will give at a very 150 milliseconds. It will give a sound, and then it will detect the reflection from it, the sound, and then it will take out the algorithm like that, which type of whether the child was having a middle ear effusion or not, and it has got a very high prediction value. And this thing has been approved by US FDA also. So this is a simple way of doing it, and it has got a 85% sensitivity, which is almost equal to our tympanogram. So comparison of a convolutional neural network model, vocal fold normality, that is, these are basically article which has come up in laryngology journal, from Journal of Voice, Nature Medicine, and they have proven, and most of them, they have come out on binary classification. And our work, which we have done it, is also on binary, that is benign and malignant. But now we are doing it in subclasses basis. This
So
is another.
Just 2 minutes to go, sir.
Yeah. So vocal biomarkers, another interesting part of it, predicting a disease pattern just by listening to the voice. And we always face the problem in diagnosing whether the patient is having adductor spasmodic dysphonia or muscle tension dysphonia. So with these biomarkers, in our laryngology practice, we can able to diagnose it. And regarding various other systemic neurological diseases like Parkinson's, multiple sclerosis, we are able to diagnose best by vocal biomarkers. So our study is based on 636 images. On we have used a 444 training data, 125 testing, and 67 validation images were taken from 399 patients. Total of 240 white light images and 204 NBI images. If you see the data, it is not properly balanced. So more of white light, less of NBI images, and we have run these images on 5 different models. So models are basically are already there in the on the Google set, so you can use it in that way. So what ROC curve we have average we have seen around 0.7. Sorry. If you see the white light, our ROC is 0.83, which is quite a reasonably good. But on NBI, our ROC is less. But you are going to ask me that NBI has got a more sensitivity. The reason being is there are two things. One is the data is less, and other thing is all the models which we have used is basically based on RGB. That is white light. They are based on white light. There's no algorithm like which is based on narrowband imaging images. So future research, I think the future how the laryngology practice will move. It will move from imaging radiological laryngobronchoscopy. It will be diagnosed by AI. Voice analysis, we already know now we are moving towards vocal biomarkers. Airway assessment by video classification model. Vocal biomarkers predicting the disease and prognosis. Medical device like laryngeal pacing on the basis of physical activity, and signal generation using a pulmonary function test. Treatment, we already know video cloud intelligence and digital surgeries. Robotics program and R&D instrumentation, haptic feedback, which is very important. I think Dr. Dabas will going to cover it, that haptic, how much is important. AI for surgery, we are able to do the surgeries on this intraoperative guidance using a navigation system, 3D reconstruction. There is another part of it that is visual odometry, that is knowing the depth of the tissue, one from other, that is which RT is coming after that, which structure is coming after that. So that will be there once we mix everything, that is imaging, preoperative imaging with. So why AI cannot replace physician? That is important thing. That is because empathy will not be there. Physician has to non-linear working. It requires creativity and problem solving and skills that algorithm and robots never have. AI needs predictability, interpretation, and we have to know the condition of the soft tissue or tissue at a large at the time of surgery. Complex digital technologies require competent professionals. Interpretation will always remain a human territory. But it will have an impact because the less of paperwork will be there once we start using AI. And it has been seen there has always never been a tech versus human. And it has been reported that human error had decreased by 85% in cases of metastatic breast cancer through deep learning. Once we have to analyze 20 lymph nodes from the axilla for a breast CA, it is a very difficult task for any pathologist to diagnose it. So it has been rightly said by Antonio, that's right, that machine will not replace physician, but physicians who are using AI will soon replace those not using AI. So with that, I end my talk, that is, scientists should stop analyzing animal intelligence and start studying about human stupidity. Thank you.
Thank you very much, sir. That was really very nice. And definitely humans have to, doctors have to accept AI as a part of our general practice. And if it helps our diagnosis, improves the cure rate, why not? And we are not going to get replaced by AI in at least this generation, so don't worry about it. Yes, do you want to take questions or you take questions afterwards? Okay, thank you very much, sir. I'll now invite our next speaker, Dr. S. Thirunavakarasu. He's a consultant pediatric ENT and airway surgeon from Chennai. He works in Child Trust Hospital, Rainbow Hospital, and also in Apollo. He was incidentally my senior when I was doing my graduation and post-graduation. So welcome to my city, and we look forward to listening to you.
Thank you, Sarika, for your nice introduction. By the way, that was me, taken long back. So I think I'll have to get Rakesh's help to change my picture in, in the Google. So. Yeah, right. Okay, here we go. So I've given us management options for bilateral vocal cord palsy in children. It's not just management. There are many options. That means there is no single mode we can cure all the problems in bilateral vocal cord palsy in children. So any high-pitched stridor with normal voice, no problem in swallowing. So immediately we can come to at least a suspicion of bilateral vocal cord palsy in children. So then the next step is to do a scopy, flexible laryngoscopy. So what you're seeing here is the good adduction, but there is no abduction. And when you are doing flexible laryngoscopy, you'll have to see whether there is a paradoxical movement. There may be some movement. You'll have to be very careful in diagnosing bilateral vocal cord palsy, because in children will be agitating and moving, and there will be some amount of movement, may not be much abduction. You'll have to be very careful in diagnosing that. And this is the yield of scopes in my institute of almost like 10 years period. Here we have a vocal cord palsy of 30 patients, that is 3.38%, and in that congenital is 15 and acquired is 15. That acquired means idiopathic, later on developed. So these patients are almost like not very common, but if you have a referral center, then you may have to see these kind of patients. Then what is the management? How to manage? There is a dilemma, because you don't have a clear-cut study to say one single modality is very good, because the evaluation comparison of individual technique is hindered by decannulation rate, because we are thinking only about the decannulation. Are we talking about the voice and the swallowing? Because before doing a surgery or any modality, when there is a patient with bilateral vocal cord palsy, there is only breathing problem. But now after procedure, there is other problems, maybe voice and swallowing. Do we have any criteria to evaluate those things is the question. And the etiology is, like as I said, either it is congenital or idiopathic. These two are majority. Only very few patients with neurological issues, when you correct the neurological problems, that will be all right. And degree of airway obstruction, you can't clearly measure the degree, because there will be a very loud noise, but the child may maintain SpO2 status without any problem in the room air. Whether to address that patients or not is the next question. And the small number of case series, wherever you go all over the world, the case series is very small. So we cannot take one single series as a important series to take as a method of choice. And surgeons' expertise and specific surgical technique. This is based on the infrastructure what you have and what kind of place you are working at. And the management, there are different types. First and foremost is the temporary management, because the child will be coming to you with the emergency. So what are you going to do? You will have to temporize the problem. Either you have to intubate the child or do a tracheostomy, or sometimes you can do suture lateralization. But you can't leave the child like that. You have to do static procedures like posterior cordotomy. Sometimes you may have to include the supraglottic part in Kashima procedure, or arytenoidectomy, posterior cricoid split with the costal cartilage grafting, or dynamic procedures like denervation or reinnervation. So one good paper, in this paper, this is a recent one where they have evaluated all the surgical techniques, and they are also not able to come to a conclusion. This is the one single thing you can do. So there are multiple options. You can go through this paper. It's a very nice one. And this is our data. Between 2017 and 22, we have done 11 patients of posterior cordotomy, because that is the one situation where we do some kind of a static procedure. So generally, either we wait for the normal recovery. If not, we are going for static, means we do a posterior cordotomy. And among them, 6 patients were treated primarily as posterior cordotomy. That means avoiding tracheostomy. We are straight away going ahead with the posterior cordotomy. And 4 patients were primarily tracheostomized. 1 patient underwent unilateral suture lateralization, that failed to improve, and then underwent tracheostomy. And 1 patient underwent endoscopic posterior cricoid split with costal cartilage grafting. So this is the ideal situation where you do a transnasal flexible laryngoscopy after suspicion. Then you are seeing here there is good adduction, there is no abduction. Sometimes there may be a paradoxical movement and flickering will be there. And this is the posterior cordotomy on one side. and you can see there is a nice posterior glottic improvement. So our idea is to give some posterior glottic improvement. This is the ideal situation. We would like to do this kind of a surgical modality so that the child can improve. This is not working properly. Okay, this is bilateral vocal cord palsy. So this is posterior cordotomy. I prefer to use co-ablator. This is one situation I like to do co-ablator in posterior cordotomy, and another situation is supraglottoplasty. Otherwise, I don't use co-ablator for any procedure in children for airway. Immediate post-operative on the table, you can see the same child, how nicely it improved, so that straight away you can avoid tracheostomy. So this is a 1-year-old child with bilateral vocal cord palsy. We don't know whether it is a congenital, came late or not. So we have a problem in abduction. So since it is a 1-year-old, I try to do suture lateralization. I didn't want to do tracheostomy. So I thought of temporizing with suture lateralization. The needle is inserted and the loop of 3-O-proline is pulled out of the laryngoscope, and then I put another needle over the vocal cord through the false cord, and that is pulled up, and this is inserted into the loop, and then the loop is pulled from below. So this will be railroaded into it and coming out of the neck. So it is buried under the neck, under the skin in the neck, and you can see there is a nice posterior glottic space. But unfortunately, the same night it slipped into it, and child came again with the stridor. So I had to do a tracheostomy for that child. Can you change this? Change a battery or something? So again, stridor. So I had to do tracheostomy. So this is another child. This is straight away tracheostomized because I didn't want to do any suture lateralization, and then did the posterior cordotomy on one side. And this kind of small children, if you do posterior cordotomy, you have to do both sides before decannulating. So you can see the posterior part, nice glottic opening. So that means once that is improved, then you can decannulate. This is after decannulation, same child. Peri-tooth syndrome. It will be very frightening to see this kind of sound in the OPD. The patient came to OP, then move please. I did the transnasal flexible laryngoscopy. There is bilateral vocal cord palsy. Please. So I have to do tracheostomy immediately. It's muscle wasting. This is Charcot-Marie-Tooth syndrome. This is a progressive muscle wasting. Then there's no point in waiting for anything of spontaneous recovery or anything. So move. So I have to do a posterior cordotomy for this patient, and you can see the posterior part, posterior glottic space nicely opened. And same sitting, we have closed the tracheostomy. One hospitalization. Now see, same child breathing normally, and his voice is also nice. So this is another child. This is a congenital bilateral vocal cord palsy. You can see good adduction, but there is no abduction. Move, please. Please move the. But the same child, after 8 months, you can see there is a spontaneous recovery. So this can also happen. There is a study says at least 50% of the children will improve within 2 years. So we can wait up to 2 years for bilateral vocal cord palsy to recover on its own. Move, please. So this is paradoxical movement.
Inspiration.
Listen, inspiration, expiration
Inspiration,
shouted by
expiration.
someone outside.
Inspiration, expiration. Inspiration, expiration. Inspiration, expiration. Inspiration, expiration. Inspiration, expiration.
So during inspiration, it is closing. We have to be very careful in identifying this paradoxical movement.
Inspiration, expiration. Inspiration, expiration. Inspiration, expiration. Don't say anything now.
So this turned out to be a myasthenia gravis congenital. So we had to do tracheostomy and wait for the recovery. We are waiting. So this child, we had to do a left cordotomy. You can see there is a posterior glottic improvement little bit on the left side, but it's not enough. So I had to do a right side cordotomy. Move, please. So this is after right side. Play, please. So after both unilateral and bilateral cordotomy, still there is no improvement at all. You can see the adduction alone, there is no abduction at all. So the child is on trach for 2 years, waited, no improvement at all. Then, move please. Came to this paper, this is by English. They have done a posterior cricoid split with the costal cartilage grafting endoscopically. So I thought of doing this, trying for this child. Move please. So I'm using a Lindholm retractor to retract the false vocal cord, and I used diode laser to split the mucosa in the posterior cricoid plate. And then used the sickle knife to cut the posterior cricoid plate. Once the posterior cricoid plate is nicely split in the midline, then I used a balloon, 7 size balloon, to dilate that. So once the balloon is used to dilate the posterior cricoid plate, then I thought of retracting the plate in the midline. I used various instruments, nothing worked. Then I used this pyloric retractor from the pediatric surgeons. Then I retracted the midline. Once that is done, I took a costal cartilage, carved it nicely to fit into that posterior part, and endoscopically I tried to just to tuck in. It was very difficult to do it. So then, tried with the multiple instruments. Then finally I used the round knife to just to press it in the lower part, and then pushed it from above so that the costal cartilage graft is nicely tucked into the split posterior cricoid plate. So once that is gone inside, that means the posterior part will be widened, and don't have to do any suture or anything, because once you tuck it in, it can slide into the space. Okay, nicely fit into it. And then I removed that suture and applied a little bit of tissue glue over there posteriorly. So this will seal the mucosa so that the graft won't jet out. And then I kept a stent, which is custom made stent. I used the nasopharyngeal airway silicone tube to cut into the size, and then used the Littenberger needle carrier to inject in the subglottis and also in the supraglottis. So both the thread is pulled out and tied under the skin in the neck, so that the graft will be there. So now you can see the graft. I have sutured the upper part of the upper part of the stent, so that there won't be any aspiration throughout. So now it is kept in the lumen just above the vocal cord and anteriorly sutured under the skin. So this is the stent. Okay, move please. So this is idiopathic BBCP. This is the ideal situation. When there is an idiopathic patient, if you do just a posterior cordotomy, the child will be all right. You can avoid tracheostomy in that situation. Move please. So this is the one-sided posterior cordotomy. Yes, almost over. Yeah, the posterior cordotomy, and we can see the posterior glottic space. So by this technique, you can avoid tracheostomy. Next slide, please. Next slide, please. Yeah. Okay. So this is our results. So all the 6 patients who underwent primary posterior cordotomy achieved adequate airway and normal swallow function. That means we have avoided tracheostomy in all the 6 patients. And decannulation has been achieved in all 5 tracheostomy patients for corrective surgeries in varying time frames. So average period is 8 months. The last patient, what we did in 2022 is awaiting decannulation. The voice quality is assessed with GRBAS. Although serviceable, showed mild to moderate impairment in the parameters of grade, roughness and breathiness. Asthenia and strain are normal in most of the patients. So there may be some abnormality in voice, but that is adjustable. So though we are able to achieve the decannulation, what happens? This tracheostomized children, especially the infants for 1 year or 1.5 years or 2 years, it is going to be a very difficult situation. How to avoid that? One good paper by Professor Rutter from Cincinnati, he demonstrated 74% success rate of one technique where he does endoscopic anterior cricoid split and posterior cricoid split and balloon that area, and then put a 1 size extra endotracheal tube, ventilate for 7 to 10 days, and then extubate. So that way he is able to avoid tracheostomy in newborns. So next please. So this is the thing what they have given in that particular study, and almost like what we have done. And probably the future will be, the next slide please, will be the future direction will be the selective reinnervation. So we need to have alternatives to tracheostomy. That is the idea, because any bilateral vocal cord palsy we can do tracheostomy and leave them. But how the patients are going to be with the tracheostomy is the question. How are you going to manage with the newborn infants with the tracheostomy is the question. And there needs to be a larger studies whether the posterior cricoid posterior chordotomy is good enough, because we have done a very limited surgeries, almost like 11 cases. Whether it is enough or not is the question now. And we need to have multi-center studies, because there will be only limited number of patients. We don't have a referral pattern. So multi-center studies to standardize the treatment, and the future direction would be to selective innervation, like whatever we can do in the future, maybe with the help of AI, with the laryngeal pacing or something like that, we can move forward. Thank you very much for your time. Thank you.
Thank you, sir.
Any
Thank you very
questions?
much. It was very nice videos, and especially challenging because pediatric airway is a lot more difficult than an adult. So a very nice series, and I hope next time you are able to present even a larger database. Thank you. जब होगा तब होगा डॉक्टर एस
The next session will be chaired by Dr. Bhavna Pant and Dr. Oh, yes, sorry. I would like to call Dr. Ramalingam to please felicitate the chairperson. For the next session, I would like to call Dr. Bhavna Pant and Dr. Ritika Roy to This is his topic. This will be counseling transoral robotics.
Now I would like to call Dr. Surendra Kumar Dabas, and his topic is transoral robotic surgery, supraglottic laryngectomy. Dr. Surendra Kumar is a Senior Director, Surgical Oncology and Chief of Robotic Services in BL Kapoor Super Speciality Hospital, New Delhi. He is an ex-consultant at Head Neck Oncology in Rajiv Gandhi Cancer Institute and Research Center from September 2011 to February 2017. Chief of Head Neck Oncology and Robotic Surgery in Rajiv Gandhi Center Institute and Research Center from February 2017 to April 2017. He has also been a Director, Head Neck and Thoracic Services in Fortis Memorial Research Institute, Gurgaon, and Director, Head Neck, Breast and Thoracic Services in Fortis Hospital,
And docking, initially we used to say that it may take around 30 minutes, 40 minutes, but docking now it takes not more than 2 or 3 minutes. Now this is the XI latest robotic system which is available in India. But if you think of other country like Korea and US, we have a single port system nowadays, which is more flexible, even with a flexible camera. So now we are using 3 arms. Center is the camera, which is 8 mm camera, and rest 2 arms are 8 mm. That's a bipolar Maryland and spatula on right side. You can see the exposure, you can see the tumor on left side of epiglottis and going in a follicular aspect on the left side. Now the surgeon is handling all the instrument through the console and you can see an exposure. So view you are seeing right now is 2-dimensional view. What we see at the console is 3-dimensional view with a good depth perception. So you always attempt at least more than 5 mm margin in supraglottic laryngectomies. In base tongue, we attempt around 1 centimeter margin, but in supraglottic, 5 mm margin is sufficient.
So this is the anterior margin on the left side. So the things which we are worrying about when you are doing a supraglottic laryngectomy, one is superior laryngeal nerve, second is the branches of superior laryngeal artery. So when you encounter this vessel, you should always bipolarize them. So this becomes a type 2 supraglottic laryngectomy, median supraglottic laryngectomy we say, where we are taking of the epiglottis, and this is the suprahyoid epiglottis, and we are taking some part of the pre-epiglottic space and the part of the vallicula on the left side. And you always use the cautery in a cutting mode, either the dry cut or the wet cut. Wet cut means you are not doing any coagulation. The wet cut is always used in mucosal surfaces, otherwise there is a lot of charring and the mucosal margin will be less. Once you have given the mucosal cuts, then you use the dry cut. The dry cut is a very good way of cutting the tissues with minimal coagulation. There is no charring, no fogging. When your assistant is helping you a nice way using two suctions, one for retraction and one for just taking all the fogging inside. And this is the real-time video, no editing in this, and it takes not more than 5 to 7 minutes. And if you have a good exposure and you are doing it since a long, does not take long time. But the next step is you orient the specimen, send the specimen to frozen section, just look for any microscopic positive margins. If it is there, you again go inside and re-resect the margins. The last part is you always do a good coagulation, because many times the patient can bleed, either the venous bleed or the arterial bleed. Once you extubate the patient, they have basically hypertensive episodes and they may bleed. So now these patients can be extubated on the same day, and you want to discharge the patient the next day, you can do, but this oral feeding will be started after 4-5 days, and we always start with a soft diet, not with a liquid diet, and with the help of a swallowing therapist. So at least we keep the Ryle soup for 1 week at least, because we don't take out the Ryle soup on the next day. At least 1 week, because our patients are not so good with the swallowing therapy, and we need and good, we don't want any aspirations. So once this is done, pathology is seen on frozen section, margins are negative, we extubate the patient and send the patient in the room, and next day you can discharge with the Ryle soup. So this is how we do supraglottic laryngectomies. So this was type 2. So we do type 1, type 2, type 3, type 4, all supraglottic laryngectomies. But my say is that we always prefer to do nave, not salvage, because salvage patients' healing power is less. But when you do nave and in T1, T2 tumors which are node negative, the results of surgery are better than chemoradiation in terms of oncological outcomes and functional outcomes. Now, what are the indications of doing supraglottic laryngectomies? What are the NCCN guidelines? We are talking about that. So as we know, the laryngeal structures, supraglottic, glottic area and subglottic area, and the maximum chances of cancer in larynx, the main site is glottis. What we are talking about today about laser surgery, endoscopic surgery, we always talk about vocal cord cancers. And the second most common site is supraglottic cancers. Now the difference is the supraglottic cancers always required assessment of the neck, and I will say the neck dissection is always indicated in all supraglottic tumors, because the incidence of neck node metastasis is very, very high. So now we know the structures: epiglottis, A fold, P fold, vallicula. These all comes into supraglottic tumors. So I will say ventricle is the one site which is basically the most difficult site to assess. So we always advise surgery only in T1. We say go for radiation therapy, because the area you will resect has high chances of aspiration. The most common site where we can go for surgery is epiglottis. I say PE fold and AE fold. So it should not be crossing the midline on PE fold, otherwise your airway comparatively more and aspiration chances are high. So this is the NCCN guidelines, which says that the tumors which are amenable for surgery, or we say laryngeal preservation surgery, the first thing which comes into mind is the endoscopic surgery. The endoscopic surgery covers both laser and robot, and or you can go for open partial laryngectomy, where you don't have a facility for laser or robot. Even till today, the people are doing open supraglottic laryngectomies, or you go for radiation therapy. Now, this is a type of supraglottic laryngectomy. This is type 1, very small limited space tumors like epiglottic tip, A fold, ventricular fold. These are the type 1 where you just excise with 2-3 mm margins, and normally in these tumors, neck dissection is not required except in few tumors like epiglottis, which is having a high chance of lymph node metastasis, and this is the midline. So this is type 2 where we are resecting the part of pre-epiglottic space, not the full pre-epiglottic space, and it is type 2 and type 2b. And the type 2a is excision of laryngeal surface of epiglottis located above the hyoid bone, and it includes half of the suprahyoid epiglottis, not up to the infrahyoid part. Type 2b is you are performing it till the hyoid, below the hyoid bone. We said total epiglotectomy. So in type 2, we are just taking the part of the pre-epiglottic space. Now in type 3, we are taking the full pre-epiglottic space. You can see that. This is the hyoid bone and this is the full pre-epiglottic space. So this becomes type 3. So you are taking the part of epiglottis along with the pre-epiglottic space. It becomes type 3 median supraglottic laryngectomies. So type 3A is resection of T1, T2 tumors extended up to the petiole of the base of the epiglottis and including the pre-epiglottic space. Type 3B is T1, T2 tumors of infrahyoid epiglottis extended up to the ventricular fold. Means you are resecting more below. So the chances of aspiration is more in this type 3B supraglottic laryngectomies. Now 4 is more advanced. 4 means when the tumor of supraglottic areas are going to the hypopharyngeal areas. So these are the patients who have higher chances of aspirations. So you need a good swallowing therapist when you are resecting these tumors. So again we say when you're doing supraglottic laryngectomy type 4, these patients should have N0 neck. Otherwise, if you go for radiation therapy in these patients, the chances of aspiration will be more. So type 4A is when you're taking over the tumors of threefold regions, which includes lateral free edge of epiglottis, A fold and pharyngoepiglottic fold along with the extensive ventricular fold. And we are resecting the free edge of epiglottis, threefold region and the ventricular fold. But in type 4B, we are going more toward the piriform sinus, the medial part of this. So this type 4B is the one which has the highest chances of aspirations, and even the vocal cord can become fixed when you are resecting this part. Not because you are resecting the vocal cord, because you are just, the innervation of the vocal cord are violated or you just cut them. So these patients aspirate more. So now this is how we are evolving in the laryngeal treatment. So now we have a lot of debates about RT versus laser surgery in T1 vocal cords. And the same we are arguing in T1 or T2 supraglottic tumors. So we were talking about total laryngectomy, partial laryngectomy. Now if your patient fails on chemoradiation and you still have a residual tumor in epiglottis or A fold, many times when you don't have a facility for laser or robot, people talk about doing laryngectomies. If your tumor is limited to the anterior surface of the epiglottis going to the vallicula, you talk about total glossectomy and laryngectomies, very morbid surgery. So now when you have access to endoscopic approaches like robot and laser, you should always offer them laryngeal preservation surgery. So this is how we tackle supraglottic areas by open, robotic or laser. Now we have a lot of papers which says that if you offer them laser or robotic supraglottic laryngectomy, the survival is more than open surgery and it is more than chemoradiation. So now what are the selection criteria for robotic supraglottic laryngectomies? So the first thing is good exposure. The second thing is if T1, T2 tumors. Now the good exposure means when you put a retractor, if you can't see the epiglottis, it is very difficult to do an supraglottic laryngectomy. So, and if you cannot see the tumors, you can't see the margins, it's very difficult to resect it. And when you put your robotic arms, before starting the robot, you should see your robotic arms are not coming into your view to resect it, otherwise it's difficult to take out the margins. So first you see the exposure, do the docking, see your robotic instruments are put inside and you can see the tumor, then you start doing robotic laryngectomies. Otherwise what happens, you start doing it and in between say I cannot do it, you are charging the patient for robotic arms and you are not doing a procedure completely. Then you come for open surgery or you do a halfway surgery and then go for radiation therapy. The first assessment is exposure. Second, you should select your patient very wisely. It should be T1, T2 supraglottic tumors. And again, you see the volume of the tumor also. If the volume of tumor is very high, it may be a big tumor, but exophytic tumor, it is better to handle with robotic arms. You can handle them. But endophytic tumors, again, they can be T1, T2, but sometimes you can't handle them. Then you have to select your tumors very, very wisely. And selected T3 supraglottic tumors with the exophytic tumors, I will say that, then you can go for it. And you should always see the pre-epiglottic space invasion should be minimum. It should not be up to the hyoid bone. Otherwise, you are just taking the hyoid bone and then your aspiration chances more high. Chord should be always be mobile. You should not attempt in paraglottic extension or fixed chords. It is not advisable. Or if the tumor is going to the base tongue and more than 50% of the base tongue is involved, then you are just doing a half surgery or with the positive margins, again going for radiation therapy, again outcomes are not so good. And we say the tumors which are only involving the minimally piriform sinus involvement is there, then you go for surgery. If the medial wall, lateral wall, both are involved and you're going for surgery, outcomes will be poor. Again, what are the exclusion criteria? Same like fixed chords, paraglottic space, thyroid, they're all for laryngectomies basically, not for laryngeal preservation or laryngeal conservation. Surgery should not be attempted in these patients. And the one thing, poor oral exposure, you can't use a robotic system to do surgery in these patients. So these are the papers. Many papers have come about supraglottic laryngectomy, timing, blood loss. We know that the blood loss is very less when you're using a robotic system. The timing improves with your more experience. And we say for type 1, it takes maybe not more than 10 minutes. For type 2, it takes around 15 minutes. So it depends upon which type of laryngectomy you are doing and how much you are experienced. And you always do frozen section, because in head neck frozen section is must, because you never know what is the microscopic mucosal margins. And you have submucosal spread in supraglottic cancers and in hypopharyngeal cancers. So always frozen section is advisable. So this is our paper which was published in 2009. We have published for HPV negative supraglottic cancers. Though we know most of our patients are HPV negative, and we have compared the results with radiation therapy, and we say the oncological outcomes when you do surgery in these patients is much better than the patients who are treated with radiation therapy and who are HPV negative. And now what is the difference between endoscopic surgery, laser versus robot? See, the main is the technical benefit of AI, you can say. This is the part of AI. So now how you're handling your robotic instruments, the degree of freedom you're talking about, the visualization you're talking about. Like you have a straight vision in laser surgery, you don't have a straight vision, you have endoris instrumentations. These are the advantage of and technique. Now how you are handling your cases, what are your selection of criteria for your patients is same. But this technique just give you benefits how you handle your tumors. Your surgery becomes forehand surgery. Assistant is there sitting with you and using two suctions, one for retraction, one for suction, and you have two instruments in your hand. That becomes forearm surgery. So handling the tumor becomes easy. Again, tremor filters. These are all technical advantages that you don't have any tremors. And what is motion scaling? Motion scaling means when you move your instrument at the console. If you're moving 10 centimeter like this, the movement inside the oral cavity will be only 2 centimeter. This is what we say motion scaling is 5 times, but basically divided by 5, you can say that. So that's why you're not doing any injury to the patient, because you're not seeing the patient on the table. You are sitting away. You can't see. So sometimes you're just moving like this. You can injure the teeth or the tongue or maybe sometimes the eye. So the motion scaling helps me to that to avoid any injury to the structures. And future is what we say telesurgery. So telesurgery will be possible with AI, and you can sit comfortably very away from the patient and you can advise. Nowadays we are doing teleproctoring. What is teleproctoring? Means I'm sitting here and advising someone sitting in Hyderabad or doing robotic surgery, and I can guide him, now go this way or that way. This is not possible in laser surgery. So this is the future. I can say that today you can discuss about why can't we go for laser, why robotic, but what we need in future is all how you can train your next generation. So this is our experience. We are doing transoral robotic surgeries in 2013, and we have done maybe around more than 1000 TORs till now. But I will say only 10% are supraglottic laryngectomies, Why? Because the selection criteria should be very strict, and your experience should be good when you're doing supraglottic. You start with tonsil, then you go to base tongue, then you go to epiglottis, then you go to IE fold, and then go for PFS. Now, if I'm a starter and going to PFS directly, I will not be a good surgeon. So this is training, how you train yourself. And sometimes even what we do, we are doing even surgery in N1 disease. And N1 disease, again, we say it is not with ENE, it is without ENE. And then the benefits of surgery are more as compared to chemoradiation. But again, with the experience and with your data, you will come to know where you should advise surgery to your patients. So this is how our training is going on, a transoral robotic surgery, either it is base tongue, tonsil, or supraglottic. But again, now a lot of people are just talking about TORS. But again, TORS, I will say, is not an easy thing, mainly in supraglottic areas. For base tongue, tonsil, I will say it's easy, but supraglottic is not easy. So this is all from my side, and I'm happy to answer all your queries. This is the future now, single port system coming, which is snake robot, which is a flexible system with a flexible camera. Till now, we don't have any flexible camera in any of the technology, but this technology is having a flexible camera. So you can go more deeper, and this single port system has 4 arms, camera and 3 more, all are flexibles. So through 2.5 centimeter exposure, you can go deep inside, and even you can think about doing lasers, doing vocal cord resections with these finer instruments. And maybe in future, we never know in next 10 years what instrument we are making, but this AI technology is going to help us more in future. There are multiple companies coming with robotic system, but till today, the only one system which can be used in head neck is Intuitive or this Da Vinci. All other systems are coming. They are not having any access to head neck surgeries because they are not focused on that. But maybe in future they will be developing more instrument for that. So this is how we are going into robotic surgery. So this is from my side. Thank you so much, sir. Head neck till today is Da Vinci only, sir. Sir, haptic feedback till now with no robotic system. So now what is haptic feedback? I say with more experience. So now you can visualize the tumor, one. Second, when you hold the tumor, you can very easily say that you are holding the tumor or you are holding the normal tissue. That this comes with experience. Or when you are cutting it, so when you are cutting through a tumor, there is a lot of charring. And when you are cutting away from the tumor, from the nape area, then there is no charring. So haptic feedback will be available, and Da Vinci is making a haptic feedback, but it may take time. So, answer.
How many cases do you get with T3 supraglottic lesion? There must be a lot of it because supraglottic is very rich in lymphatics. So let no to either.
Sir, very rarely you get T3 with, I'm saying limited T3 tumors with N plus N1. We have done. We don't do with bilateral neck nodes or with N2 nodes. Again, I'm very rich, sir. But I think T3 tumors, 60% chance of lymph node mets, 40% they may not have. So I'm saying 60%, so 40% they are not having it. So you have to select your, see nowadays if you're doing a PET CT, you are not sure, PET CT is showing no uptake in the neck, still you can have node positive. So what we do, ultrasound is better than PET CT in finding a lymph nodes in the neck, and we do an FNAC. So we combine ultrasound plus PET for finding a lymph node negative neck. Sir, we are doing PET scan in all of our patients, basically, all patients, sir. And now, sir, we are getting a lot of second primaries also. That's why we are advising PET now. See, I've seen a lot of patients with base tongue tumors then having a second primary in the lung. Very high chances. But if I treat the base tongue and patient was having a lung cancer also, after some time he comes back and we say it's a metastatic disease. So PET scan nowadays in a private setup where we have to answer all the patients ki why you not done this test. Now patient comes to us, PET CT karao mera. So 10% incidence of second primary is very high, and if your plan is being changed in 10% patients, I'm happy to doing a PET scan. And now PET scan are available at cheaper rate also, not like 25,000, 29,000. People are doing in 11,000 also. So we advise them to go there and get it done. For local imaging, I always prefer to get an MRI done, but for distant imaging, PET scan is, we are advising them being in a private setup.
I would like to call Dr. Ramalingam to please felicitate the speaker.
Now I would like to call Dr. Manish Munjal. He will be giving a talk on management of difficult access during MLS. Dr. Manish Munjal is a senior consultant at Sri Gangaram Hospital, awarded Lieutenant Governor's Gold Medal for Best Registrar across all specialties in Government of Delhi hospitals for the year 2006. He is a founder member Asia Pacific Voice Association. He published many award-winning papers on voice as well as head neck surgery. Now I would like to welcome Dr. Manish Munjal, sir. Please come.
Sorry?
Zoom पे मेल आई होगी ना Zoom लिंक की, उससे आपको लॉगिन करना पड़ेगा.
This is all internet connected. तो मैं दो next कर सकता हूँ. कर गया हूँ.
मैं आपका कर ही होगा, मुझे Zoom नहीं पूरा. इंटरनेट कनेक्टिविटी चाहिए सिस्टम से.
ये हॉटस्पॉट से ये हटा दो.
ठीक है, मैं देखता हूँ उसमें Zoom देख लीजिए.
Wonders of technology. Sorry, I was caught in surgery till 11 and didn't get a chance to see this mail. Yeah. Mail आएगा. Yeah. नहीं. Thankfully, no videos. What should I type?
नेहा मैम के नाम से सर्च कर लीजिए, उन्होंने मेल भेजी होगी आपको.
Invitation.
हाँ जी.
Invitation में. Okay.
यहाँ पे Zoom का लिंक होगा नीचे.
Okay. Oh, this Zoom link was this for this. हो जाएगा. हाँ.
Recording in progress.
The mute. Okay. Now shares. Yeah.
Desktop पे. साउंड भी क्लिक कर दीजिए.
ये बंद कर दूँ. This is muted. Just a minute. Yeah, now it's muted.
Thank you. Sorry for the little delay, but I didn't know we have to link it through Zoom only. Thank you so much for being a part so far, and I hope you had enjoyed yesterday at the Gangaram Hospital for the surgical workshop. And please do give me a feedback. I intend to carry on this thing later on as well, and in coming years. And whatever you want, whichever way you would like it to be, we'd like to have your feedback. You're very free to tell me. This is a little bit of a conceptual lecture. Even I was thinking, I mean, we face this problem almost on a daily basis. What needs to be done about it? So a lot of people can give me a suggestion as to how they do. Let's make it a little bit interactive. I won't mind it at all. And we have all the stalwarts. We have all the people who are experienced. We have the people who are technologically endowed. This is the Olympus area. What can be more technologically evolved than this area? And we have you youngsters at the back who have new ideas. So whatever you can tell me. So coming to the, excuse me, coming to the fact that all of us are doing a laryngoscopy, and for a resident who usually comes to us, it seems like a straightforward task mostly. But is it that easy to put in a laryngoscope and start surgery? As you see a person doing the sword swallow, it may seem too easy, but it is all very, very technical. And we all know the horrors. At least we have all seen broken teeth, we have all seen tongue injuries, we have seen hyposthesias of the tongue. People come for many, many months, they will haunt you after a small little polyp surgery with the inability to taste and having less sensation. It's a very, very difficult thing to to manage with them. And at the same time, it is difficult to treat it also, because you have never told them about these things. Most of the laryngology complications of laryngoscopy we don't tell patients many a times. What about while uh, thinking that it was all a good exposure, while doing the extra zealous tightening of the screw of the Klein's braid, the suspension system, when you take the laryngoscope off, there's sudden gush of blood in the whole mouth, and you realize that something has got torn, whereas you never injured it. So that is the lateral tonsillar pillar. The pharyngeal folds get that get torn, and forget about the result of the surgery. The patient doesn't let you live for the next 15 days because of the pain that the person has in swallowing. Very, very bad circumstances may lead to subluxation of the arytenoid. And there has been a case or two where I have seen a total quadriplegia happening due to a post laryngology surgery. And spinal injuries, dislocation of atlanto-occipital joint, C7, C6 fractures, they have all been reported. So you must have this thing in mind, that it is not simple to put just a blade and tighten it. You must have a predictor. But what predictors have been there for us so far? We don't actually do predictors. We just see a case and we post, because he's walking in, he's healthy or she's healthy, and we just think, oh, there's the polyp. The flexible endoscopy has made our task much easier. You put in the scope, you don't even see what is the thing. That includes me also at times. And we do that. But our predictors so far have been usually the patients themselves. They will tell you, oh, by the way, I wanted to tell you, I've got these loose teeth and I wear dentures. I've got these dentures. And he says, oh, yeah, we'll manage them, or we won't manage them. Sometimes a sixth sense, when a person is coming, a fat, obese, or a elderly person, then you think maybe this thing would be a little bit tough. And our old good friend, the anesthetist, but alas, he usually tells you at the end of giving the relaxant only, oh, Manish, this is not looking very good. You'll have a tough time. But I've given the scoline. Now you think what you want to do. So it all happens every day. And what we have really to have been having with us so far till recent times has been a very proud scale called the Malampatti scale, because it is well known all over the world. we follow, and we like to tell, it's almost in every postgraduate exam, examiners like to ask the complete visualization of soft palate, not too much of visualization, then the complete destruction. I used to think that this is the best classification for laryngoscopy, but it is not. It is only to assess the ASA grades of anesthesia, whether the anesthetist can actually think of intubating, may be of help. Even they are not too convinced about all aspects of Malampatti now. Then we come to the Cormack-Lehane scale, and in this we have now the modified scale where the 2A, 2B concepts have also come, but I just wanted to mention it. A grade 1 where you now start talking about the laryngeal exposure, grade 1 where you can see everything, grade 2 is partial, grade 3 only the arytenoids, and grade 4, as Dabas also mentioned in one of the things, that only the supraglottic hardly is visible to you. So what is the problem with these airway predictors? They are not made for suspension laryngoscopy. They are made for intubation laryngoscopy. That is the problem. They are indicative, although they are not reproducible. The teeth interference of an anesthetic laryngoscope blade is absolutely different. Everything is based on the lower teeth, lower alveolus, whereas our direct laryngoscopy is based on the upper alveolus. The neck positions are different. We want our patients to have extension and semi-flexion, whereas the anesthetist wants to have a neutral or a slightly extended position. The blades, of course, needless to say, are totally different. They do very well with a curved blade. Their tubes are curved, and we are doing it with straight instruments, and our blades are straight as well. The blade placement is different. For them, a good snuggish vallicula is all that you need to lift up the epiglottis, see a little bit of the cord, and put in the tube. Whereas we have to put it after, we have to suspend the laryngoscope while retracting the epiglottis, isn't it? So that is a problem here. And intubation tubes are curved physiologically, as I said earlier. Unlike MLS instruments, you have very few MLS instruments that can even think of bending a little angle. Only the tips or the distal tip, you will have a little bit of an angle. So the tube placement, and if the worst scene comes in intubation, there is always a good anesthetist who can put in a tube with a tactile stimulus. He doesn't need to see the larynx. He will just keep a go, and it's in. I've seen so many of them. I don't know what they do. It's like a master. They can just follow the air passage or something like that. Whereas what will you do then? He says, I put the tube, now the patient is yours, and you're looking inside, there's nothing visible. So the prerequisites have to be met first of all, and ideal principles of microlaryngeal surgery are absolutely a must. We must try to achieve a flexion at the chest, which is the C6, C7, and extension at the atlanto-occipital joint further. And the suspension laryngoscopy must give us the ability to free both hands. This is basically the Zeitel's postulates, which have been mentioned in the paper, and I also believe that they are all required. There should be a conformity of the distal laryngoscope blade, and it should show the entire glottic aperture in a V-shaped format with an open glottis structure, and the tube should come down as much possible. Even if it is interarytenoid, it should be able to go down as much possible onto the posterior glottis. There should be an unobstructed view, therefore, and an extended view of the airway, especially for vascular malignant lesions, should be met. And if you now really want to think of what needs to be done, is getting a score that can be done before as a predictor for a laryngeal airway, and that is a very good fine paper. Most of you might have read who are very interested in laryngoscopy, but laryngoscore is now something that we must all get back to and also start reproducing it in our papers as much as we can. Now it has basically a total of 11 characters, in which the most important ones are at the right there at the top, but all of them are important. It may include the incisor gap, less than 4 or more than 4 centimeter mouth opening, the thyromental distance, that is an important criteria. In some papers it's mentioned as 4.5, but greater than 6.5 is ideal, and less than 6 gives it a higher score. The upper jaw status, dental status, is divided into 0, 1, 2, 3. They're all marked, and the people with no teeth are the best, and the people with the teeth which are protruding outside are the worst. So if you got good set of teeth, you will be actually a higher value of laryngoscope, which is not desirable. Trismus is a really bad a criteria, and it has a full score if there is even a little bit of trismus. Mandibular size, macroglossia, glossia, micrognathia, degree of neck flexion extension, any history of previous radiotherapy or surgery, they all carry marks in the negative. And finally, modified Mallampati, because at the outset, how you look at the mouth carries a bad score if it is too bad. A grade 4 Mallampati is grade 3. So we have a mark of total 17 that can be the most negative in a laryngo score. And if you look at classing it away, then 0, 1, 2, which is actually good laryngeal exposure, will have eventually a median laryngeal score of less than 6. And it has been shown in papers that if it is less than 6, in almost 94% of the cases, you will have a good laryngeal exposure. Whereas in class 3 to 4, which is grade score more than 6, there will be a good amount of problems up to the range of 40%. And if the laryngeal score is above 9, then you will have many more problems, like 67%. So we are basically trying to think of what to do about these DLE, or at least above the 6 laryngeal score. And if you do not have too much of time to analyze all the variants, then the upper jaw dental status I was saying, and the macroglossia, micrognathia, the degree of flexion, and this thing, they all are statistically significant as compared to a few other parameters. So what options do we have? Even if we have a laryngo score, we have to do sometimes the surgery, but of course, well prepared person is halfway done, and that is how we should travel. If you talk about making such approaches for DLE, then you would think of the best thing that could be non-invasive. You're after doing a micro-invasive procedure. So if you want to aid with a non-invasive approach, that will be the best. But there would be some approaches which could be internally invasive, and some approaches where you would require some external invasions. So in the non-invasive approach, this is something which is good to carry out for youngsters. As I said, you should try to improve the exposure by keeping the head in slight extension flexion position, and you must remove everything that is below the head. Try to remove the head ring and all if possible. A good anesthetist would also help you in relaxing the your muscles as well as the patient's muscles. So you must have a deep relaxant, and you must wait for the relaxant to take effect. Please, this is important. At least 4 to 5 minutes after intubation, patient on tube is better than doing a scopy immediately with a rigid scope. And then always when you're inserting a laryngoscope blade, it should not be over the dorsum. A heavy tongue will always give you more difficulty in exposure. Go from the side, watch the floor of the mouth, and then once you are just at the side, try to visualize where the endotracheal tube is going, and just then follow the endotracheal tube up till the epiglottis, lift it, and then go in. This is one of the safest and the best sliding approaches. There is a lot of use of guards, dental guards, titanium guards, silicone guards that are there, but they can be a hindrance if you are having a DLE. A direct laryngoscopic exposure where you're already struggling, if you take another 5 millimeters of space to put a dental guard, will have a problem. So one of the things that can be done, not always, is actually use a long wet gauze spread evenly over the teeth, and to prevent injuries of chipping and all, but they should be reasonably strong denture lines so that you can gain just that little bit of an extra space, and it does help to distribute a little bit of pressure around. As for the laryngoscope blades itself, I will show that picture. The anterior blades, multi-angle laryngoscopes. We use sometimes the suspension the gallo laryngoscopes rather than the chest pieces. They are better. Usage of alternate ventilation methods like jet ventilation, a compression on the larynx, and just the required with assistant, and the use of neck strap, which we always use in our systems, is most helpful. These are the various types of laryngoscope blades, ranging from the Dido to the Lindorms to the triangular blade of Zeitels, and up till the glotticoscopes that can be used depending on what you need. But the aim should be achieving the triangular open aperture of the larynx, and never try to use a size more than what the person requires, because a smaller size in that area is always easier to be put. If it does the job, it should do the job. The use of neck strap is a very simple, almost inexpensive thing that we follow. These are Velcro straps, and they are available in almost all OT anesthesia trolleys. One strap, as you can see in the second picture, goes and then binds to with a buckle belt on the side surface next to the neck on the side table, and the other goes on the different direction. When they come together, you can put a gauze or something and then strap it. While the laryngoscope has been after the laryngoscope blade has been inserted, it really improves the visualization by 20-30%. And then, for example, in the last left centered figure, if with the best exposure, if you have got this kind of exposure with the pressure, you can actually see an anterior commissure polyp or something that is there in a difficult laryngoscopy. For internal invasive approaches, I don't know what to call this stitch. It was given a thought and taught to me, at least, by our friend who visits us a lot, and that's Paul Castellano. He uses the epiglottic stitch a lot, and I have used it in a few patients where with a Leichenberger's needle, or with even a laparoscopic needle blade, or sometimes even with a long needle holder, you can stitch through the epiglottis when you're doing a endoscopy with the Macintosh blade, the anesthetic blade, and you take that stitch out and then hold the stitch in your hand, and when you're putting the laryngoscope blade after that, you can just tug the epiglottis up so that it doesn't keep on falling in short epiglottis and difficult visualization. It's a very helpful tool sometimes. Of course, the other things look drastic, but we have done them. For example, a very protruding teeth in an elderly person where you are doing a T1 glottic, you would not hesitate in a T1B or a lesion for a adult, where it is absolutely imperative to remove the lesion with margins. If the teeth are coming in the way, you can discuss removal of the upper teeth and then replacement with dentures. And we have done a couple of cases with a lower alveolar split in very heavy necked individuals where there's obesity and short neck. You can actually do an intraoral, call a plastic surgeon, do an intraoral mandibular split, and then once you have done the procedure, it absolutely makes your airway absolutely straight. Go in, do the scopy, come back, he will do the 2 plates for you, and the person can eat soft diet from the first day at home and shift to heavy diet later on. We have tried in a couple of cases internal condylectomy also in this OSMF, where there was absolutely very poor mouth opening, and we did laser cutting with the plastic surgeon and a condylectomy. It improved the laryngeal exposure, but a post-op is really problematic. This is the diagram that Castellano had sent me.
when I had asked him about how he manages it, and this is the Lichtenberger's needle which he put through the epiglottis and pulled it back, and it straightens up the epiglottis a lot. It is also used widely in neonatal laryngomalacia surgeries, but in an adult also it may be helpful. As for the external approaches, these are the last to be followed. There is an option of doing endoscopic trans-hyoid approach these days, where you make a small horizontal 2 to 3 millimeter incision over the prominent Adam's apple, best done only in the males with protruded larynxes, because an anterior post larynx sometimes itself a difficult thing to do. And then after dividing the fat and the thyroid membrane, you can go inside and see the epiglottis directly. It is still not a great angle, but with a 0-degree endoscope, a tilt up, you can do a one-hand surgery mostly, but a two-hand surgery is still difficult. And of course, the midline laryngofissure technique, which we have done many times. There is a plated patient, neck plating was done, where there was absolutely no scene of doing a laryngoscopy, absolutely nothing. The patient was in flexed position. So in such situations, you have to give a horizontal incision, do a vertical split midline laryngofissure, the larynx, and it should be going through the Broyles ligament, absolutely in the midline. You can put two needles up and down and see with a laryngoscope whether you can see the needles, and then cut it, expose it, and then you can do a mid-caudal lesion or whatever you want, and sometimes a cordotomy for even this paralysis, bilateral abductor cord paralysis. So this is how it should be done, and later on suturing or plating of the laryngeal cartilage can be done. The future, of course, holds that something more technological must be done. These surgeries, or whatever said, are a little bit mutilating for the patient. And there is an instrument that I will be just showing some picture about. It's curved instrumentation with curved rigid video laryngoscopy. There's an option of doing what the boss also mentioned. This is the transoral ultrasonic surgery, and then there's transoral robotic surgery, and then there's total flexible laryngoscopic surgery. So this is a view of the air track instrument which has been developed in Middle East, and this is an air track system where the person, it's been made in such a way, it's kind of a laryngoscope blade inspired by the CMAC, where you lift the tongue and you can even manipulate the tilt of the angle. The blade and distal is can be manipulated further, and then you have curved instrument like the frontal sinus forceps and all that you can put through with the blade. And there was a paper about it, somebody has published in from Mumbai and done some surgeries with this system also. But of course, it's not entirely precisionful. You have to have some other things later on. This is the oral endoscopic ultrasonic surgery TAUS system. We are standing at Olympus. It is made by Olympus people, where the instruments have a flexible camera. So even if you have and they use the FK retractor, which is also used in robotic surgery. And once you get a visualization up till the epiglottis, and you can lift that up, then you can use endoscopic rigid and flexible cameras to further visualize. The transoral robotic surgery, already the VAS has mentioned, it has improved the access due to its multiple degrees of freedom and excellent visualization of tissue. But of course, disadvantages include heavy cost, bulky instruments, and loss of fine precision. Finally, the thing about single port, I think this would be the future of even the difficult access, provided we have a multiple use port system, just like our laser, whereas a thin fiber, at least lesser than the size of our normal distal laryngoscope orifices, can be inserted through the system, and we can do our precision surgeries. So I think I would be as short as I could, because even I need ideas on this system. But it'll be great to know from all of you if you have any other thing that you could do for improving laryngeal exposure. I'll be happy to take back my own ideas for myself. Thank you so much. Thank you, ma'am.
Thank you, Dr. Munjal. I would just like to ask from you, do you have any experience regarding using rigid endoscopes inserted in the routine
Zytals. Yeah.
laryngoscope? Can we have
Which
angled?
angle of course, yesterday we did the first surgery in the workshop with an angled endoscope. We had a base of tongue lingual cyst, congenital lingual cyst in a child who was 4 years. It was an area which is at the roof of your surgical access. So we could not use even a laryngoscope blade. We had to use a tongue blade, which is the Boyle Davis blade. And after that, we took a suture on the tongue, pulled it up, and then we inserted a 70-degree endoscope for direct visualization and a radio frequency curved into this coblation curved instrument, and did the surgery very well. It was the first surgery yesterday, and we have been using it even for subglottic lesions, angled scopes and all. When you want to see the lower part of the surface cords, if you have a cancer, we use multiple broncho endoscopes with different angles many a times.
It would be better to have a slot in the laryngoscope itself, that is rigid laryngoscope.
Okay, so yeah, that is there. The stores.
They are bringing up that model.
The video scope is there with two kind of ports. The only problem that I am facing, I don't know about others, is that I mainly like to use laser in most of my laryngeal surgeries, and it is not compatible with carbon dioxide laser systems because, and it is very good for demonstration and taking photographs because the 3D photography is possible with those camera system, which is not possible with our conventional microlaryngeal systems. But that system is very good for images, and if you're publishing a book or somewhere writing an article, I have that scope as well with me.
Thank you, sir. It was a very wonderful presentation.
Yes. Oh, yes. The Weirda from stores, I use it. Although I would not say that is the best system for access, for exposure. Yes, for side exposure. But sometimes I have found it, sir, that for anterior commissure difficulty and all, it is not that great. For posterior, it's great. For doing paraglottic surgery like myoneurectomy and all, it is a wonderful instrument. And so
Suspension laryngoscope, many times what people do is they force it too much.
Yes, yes.
In fact, to see the anterior commissure, you have to withdraw the scope a bit, so you can press it and see.
Absolutely.
People have seen what they do is they push it.
So this is at the place where you feel, because that's the place where you curse the maximum. No, at least I do the maximum. Bring it back. The epiglottis plops in. Do it further. You don't get the chords play away. So there, this epiglottic stitch is extremely helpful. It just does not let the epiglottis slip down. So just sometimes you try. I've used it in such situations. There was this case just not so long ago. He was a post radiotherapy CA larynx, and I had to just take a biopsy. And one of my junior colleagues, he tried doing it under GA biopsy, and he abandoned the procedure. And I said, this is a cancer. How can we abandon it if it's an endolaryngeal cancer? We'll still have to go because this flexible endoscopically wise, we were also not able to do it. He was just not tolerating a laryngeal this thing. So we gave him, and he was tracheostomized because of the growth. That was also the thing. So finally, that's why the flexible was also not helping. Then we went in with the epiglottis stitch, because even I struggled for 30-40 minutes, and then I decided to do that stitch, and then we could take that biopsy. So because maybe the radiotherapy also had closed down the larynx inlet a little bit with all these things.
Your suspension system, whatever I saw in your suspension, that is the approach.
Yes.
You just try the Zomed one.
Okay.
I'm using Zomed for last 20 years.
Number one is Zomed, and I'm also thinking of the Kalelkar Gallo system. That is also good. That 5-piece, no?
Zomed is
okay. I know the black handle that you use. That one. Okay. We have the other one. The other one also. Okay.
The alignment is fed. I mean, your
But the laryngoscope is Klein saucer. Okay. So you're not saying the blade is okay, but the suspension. Okay, right. See, I learned something. Great. I think we should have a panel discussion on difficult exposure. This for the next time, Neha. We should. It's a fantastic thing. You know, so many people with so many good ideas. Yeah, because everybody has his own way of dealing with this thing. It'll be such a good.
So I would like to share one thing.
Sure.
I motivated a patient who was very
Where is
difficult.
this voice coming from? Oh, sorry, ma'am. All right. Okay. Sorry.
A very difficult to intubate patient was there in front of me. I motivated him to lose weight. He definitely came to me for 6 months, like 2, 3, 5 kgs, lost weight. Like, it was a benign
So you
lesion.
found it much because BMI was one major criteria, and any BMI above 30
We can
is.
send these patients to wellness clinic.
It's a
and-
good idea again. That's a great idea. But if it's a malignancy, you might not have that time.
Then I would like to do tracheostomy, sir. So better to take biopsy and start the
So,
treatment.
I mean, as a private a person knowing the cost of managing a tracheostomy even at home, I mean, these days we try to avoid it even till the last moment. There were cases when we used to have endophytic growths ready to close down the larynx. Nowadays, I have started debulking the larynx to a large extent during the biopsy. And if a patient is a T3, because we know till T3, the person will do well with the radiotherapy. So in T3 lesions, especially if I find an endophytic growth ready to close down the larynx, a person coming in stridor, we have managed to save the tracheostomy in such cases. And it is absolutely a wonderful thing to achieve almost at the cost of, even not, better than the other things. So tracheostomy, although can never go away, that's the life-saving thing, but somewhere it is not required, we should try to avoid. Sorry.
Thank you very much. We are running short of time, Manish. No more questions for next speakers also, please. We are going to have a wonderful quiz session. The quiz master is Brigadier Rakesh Datta. He is known for quizzing. So I request all of you, please stay put and we'll try to finish as early as possible. Next.
Next, we'd like to invite Dr. Ashok Prabhakar Purohit. Dr. Ashok Prabhakar is an eminent and well-known face in the field of otolaryngology. At present, he is an active member and president of Laryngology and Voice Association. He has several achievements to his name, including innumerable publications in renowned journals, both national and international. He has been guest lecturer at various conferences and CME of significance. Besides this, he is a man of great spiritual and moral values. He is a household name when it comes to ENT problems. So I'd like to welcome sir. He would be talking on pediatric airway, where I burn my fingers. Welcome, sir.
Good evening. Thank you, madam, for a nice introduction. I must first congratulate Dr. Ramlingam and Neha for such a wonderful arrangements and wonderful place and beautiful conference. And Manish Munjal for yesterday's pre-conference CME. So this is my thing which I just want to share with you. It's surgeons, we always keep on learning. So many times your patients are your teachers. We keep on learning things from our experience. So I want to share a pediatric airway where I burnt my fingers. Of course, you know, pediatric airway is a very delicate airway. Anatomically and physiologically differs from adults, and pediatric airway needs to be handled with utmost care. There's no doubt about it. So no, not this way. Pediatric airway requires a lot of precision and accuracy. So it has to be handled with really a very care. The reason why is so because you know it's a very small airway with loose mucosa. 50% reduction in radius leads to 16-fold increase in resistance, and just 1 mm of narrowing leads to 75% of blockage of the airway. And increased airflow velocity results in negative pressure at the, which is the Bernoulli's principle, everyone knows. So when we have a child with stridor, we can judge the stridor with just a patient's presentation, that in generally supraglottic, glottic or inspiratory stridors, where you have this, we have the subglottic upper tracheal stridors and biphasic. So we can judge the things just looking at it. This is a very diagrammatic representation how you get the blockage. Sorry. Here you can see the adult airway doesn't get so compromised as it happens in pediatric. So this is what is a reason. But here is a only single airway. You need to give anesthesia. You need to use a lot of instrumentation through it, protect the lungs and keep the child alive. This is the most priority thing. All the airway procedures are tailor-made. You cannot decide that I want to do this procedure, I plan this. You have to have on-table decisions. Most of the time you know nothing, but you need to do everything that to save the life of a child. This is a thing which is in Marathi. Why I'm saying this, in spite of using a lot of my efforts, lot of my knowledge, lot of my experience, and with lot of patient counseling, this is the thing which I got. They are demanding 30 lakhs rupees from me for doing good for the child and not succeeding with good consent. So now what I've started doing, it's a video, not after I got couple of notices. This is not that I'm always doing blunders. It was not a blunder. You know, we have taken proper consent with the patients, relatives, everything. But they said we took the signature on blank papers. This has happened. So this is very mandatory. To the patient and has to be recorded. This is lot of problem in your safety. So I first insist every one of my colleagues that when you deal with a patient where you find there is going to be a risk factor involved, you should have a proper consent. This is all my experience things which I am sharing. So you should have a proper consent with the patient, relative, and of course on paper. Next. So I'm sharing few cases. This is Nasir Sheikh, a precious baby, full-term delivery, stridor since birth, cyanosis, saturation 78%, DL scopy where we found a thick glottic web. Intubation was also not possible. Tracheostomy was done, patient improved. The child was very bad. It was not suitable for any other intubations or something. We did the tracheostomy. Next, please. Child got settled with tracheostomy, was shifted to NICU. They were taking good care of him, but suddenly got obstructed because of some secretions. Next, please. Meantime, the this is a different. Meantime, the laser, because of little temptation for just excision and trying to improve the airway, laser microlaryngeal excision of the glottic web was done. Patient was on tracheostomy tube in ICU. Tracheostomy tube got blocked and child went in a distress. While suctioning, the tube got decannulated and there was a horror. Next. In ICU, nurse couldn't reinsert the tube. Neither the tube was put by the doctor on duty, and ultimately the child was lost. Next, please. What thing we got from the thing is, don't be overconfident about the neonates. Always suture the tracheal flap to the skin, which helps in the day one till the stoma gets properly channelized, because it takes around 48 hours or more than that to have a nice channel where anyone can just remove the tube and put it back. So it has to be, you are not always there with the patient. So it's better you take the flap, because I used to avoid the flaps to reduce the trauma to the trachea. But as far as safety is concerned, now I make a fab flap and suture it to the skin. So always keep a tracheostomy instruments and the proper headlight and the instruments and very near to the patient. So any time you reach there, even if I would have gone there, I would have been helpless because the stoma was closed.
11-month-old child with the acute breathlessness, inspiratory stridor, shrill cry, no history of foreign body aspiration, treated in ICU as a acute croup, acute laryngotracheobronchitis. They did all X-ray chest and everything, but they couldn't find anything except the croup, and they were treating him. Child worsened, started having very bad stridor, was not improving, not responding, not responding to anything. The I was bad, he was becoming toxic. Then when we did the scopy and we found there was a glottic foreign body, which was a piece of a coconut, and child did not have actually mouth to hand coordinations, and there was no history of foreign body. But later on when we inquired, her elder sibling, the girl, his sister, had fed him with a piece of a coconut which got aspirated, and no one thought about it and was being treated for an infectious disease. And this was a thing, the edema started increasing, the child became worst. So ultimately when we removed it, the voice improved, the child immediately got well. So this is what So what is the moral? It's every case of pediatric stridor needs to be scoped. Even though we are suspecting an infection, I still prefer that has to be scoped because we can do it a local endoscopy. Missing of airway foreign body can be catastrophic. So this is video. This is how we scope the patient. It is small child, even 1-day child in OPD. We can do the scopy with this is Olympus system. It's a 2 mm scope where you can just tie the child with wrap the child, because otherwise makes a lot of struggling. So it's become very easy to see. It's very comfortable. It's not a very risky procedure. You can see this foreign bodies or whatever pathologies. So this is endoscopy been done in the OPD setup itself. Next. This is a Neeraj, 3 years old, subglottic stenosis, laser assisted MLS done, decannulation failed. Actually, we shouldn't be trying this, but this is a place where we try to salvage future thing. As he said, doing a tracheostomy, sending home a child has become very difficult. Trachea re-explored, anterior wall reconstruction done with a conchal cartilage. I generally prefer to use many times in children conchal cartilage. Small silastic T-tube was placed. Patient improved, started talking, and the child was discharged. We should have different shapes of T-tubes. I still use, not very frequently, but I still use T-tubes in adults, but not now given up in pediatric group. On the day of Diwali, 4 a.m., a frantic call came from a hospital, a remote hospital ICU that Neeraj is gasping. Severe hypoxia, I could hear the bradycardia, the tachypnea, everything on the phone, and the panic in that small ICU. And immediately that mother had called me up, but she was quite clever in that all whatever the noisy environment. I told her to just cut pull the tube out, and she told that person over there to pull the tube out. The tube was pulled out, and immediately child got settled. And then I requested those fellows to just put a small endotracheal tube through the stoma. So the chances of T-tube blocking are very high, and passing suction to a lower arm is not so easy. Use a T-tube in a small children with lots of caution. Parents should be taught very properly the methods of cleaning the tube. This is how you should teach them, if you are at all putting a T-tube, how to clean the tube, how to pass the catheter. They should have a suction machine or a foot suction at home, and it should be managed very well. So I invented a small tube. This I have used in some patients, where I use a silastic tube, and through that I made an opening and made it a different T-tube with a removable tracheostomy inside. Jayashree, 12-year-old, accidental strangulation. She was having some playing or somewhere and got strangulated, intubated and ventilated, extubated. After 4 days, started getting breathless, diagnosed to have lower tracheal stenosis. the standard dictum patient walking to your OPD with breathlessness, with history of intubation, always think of stenosis. So it was a bad stenosis video. She was constantly having
तुझं नाव सांग.
जयश्री.
मोठ्याने नाव सांग.
जयश्री.
हां. काय व्हायला लागलं तुला?
श्वास घेताना त्रास होतो.
काय त्रास होतो तुला?
So again, I don't know why they wake me up at 4 a.m. and 5 a.m. I'm not understanding. But again, 5 a.m. she became gasping, cyanosis. We did a tracheal dilatation through the stoma. A small endotracheal tube was placed. Patient improved. She was treated with endoscopic laser excision and repeated dilatations. Now we were insisting on going for a stenting or some procedure because she was from a very remote place. But her father was very adamant. He said, no, my child is very good and I want to take the child home. And she was discharged. This is how we did it was not a balloon dilatation. We did with bougies. Patient was discharged. She was very happy to go home. 1 week later, she became breathless at home. And before she could reach me from a distance of 55 kilometers, she tried to reach at many places in between with even the government hospitals. And everyone said, no, we can't do anything. You go where the thing was done. So, and the PM showed wrist stenosis with complete airway obstruction. So don't leave trachea without a stent in a rapidly progressive stenosis, or go for a definitive surgery. Never leave them without stenting or a definitive surgery, because they are going to recur and land up with problems. Ashim, post-head injury, intubated, put on ventilator, tracheal stenosis, tracheal reconstruction, T-tube placement, later on breathing well, but couldn't, constant aspiration of saliva and food. So laryngoscopy was showed a T-tube between the glottis, keeping the cords constantly open. What had happened was, when we did the reconstruction, we put the tube where we were very confident that is in the subglottis, not touching the vocal cords. But when the extension was removed, it slipped up and it became impacted between the vocal cords, and he started aspirating with very breathy voice.
नाम बोलो. पूरा नाम बोलो. जोर से बोलो.
So we had to again take it out. Again we have to explore the neck because it was not fitting inside properly. So
नाम बोलो.
हशीम यासीन मदारी.
जोर से बोलो.
हशीम यासीन मदारी.
स्कूल में कौन सा स्कूल में जाता है?
माजीशाला.
On the top, because it was done with the rib cartilage. So always confirm the position of the stent by doing a direct laryngoscopy before fixing the stent or the tube. Like we saw in the morning, Neha's presentation, that they were doing an endoscopy. It was just a single 5 minutes job, but we should not miss it out. Otherwise, we could have saved his second procedure. 1 month old child with a stridor diagnosed as a bilateral abductor palsy. Laser right cordectomy done. Patient did well. Nasogastric tube removed. Oral feed started. All these areas are inaccessible, so we tend to use laser. Actually, it looks glamorous, but it has to be handled with care again. So the cordectomy was done. Mother, with her over enthusiasm, fed the child half a bottle of milk, and the child had a massive bout of reflux and aspiration. The child was again intubated and sucked, and somehow we could save that child. So what is the moral is that avoid cordectomy, as the chances of aspiration are very high, and particularly in children. We should try for a Tharu's, what Tharu has morning afternoon showed, this posterior cricoid split and the grafting. That looks more interesting. And feed them with, always, if you at all do something, feed with nasogastric tube till you are confident that the child is not going to aspirate. This is a tracheostomy for juvenile papilloma, very repeatedly recurring. So the child was put on, did the tracheostomy, was sent home, never came back for a very, very long time. And when it came, this was the scene that the flange of the tracheostomy, the tracheal part of the tube had been already got slipped inside the trachea. So this was the thing, but child was comfortable. So we did not have much problem with life, but we had to do a bronchoscopy and take it out. So this is the child. This is not the same tube. I just shown the cut and made it. So always insist on changing the tracheostomy tube every 4 to 6 months, because they are from a very long places. They don't turn up to you and may land up with this type of things. Surgeons after the operation, medical students after exam, they always say, I tried our best, but can't say anything now. Thank you very much. So this was my some experiences. I don't.
Thank you, sir, for a wonderful presentation. Last one. Next speaker is Colonel Dr. Karuna Datta.
The one he told in the first case, the child, and I had the same experience. My child, I started to trying to change the tube in the ward, to change the tracheostomy tube. And the thing is, one is of course making it suturing the trachea to the skin. That's one part of it. Second part is always remember, even if that is sutured, if you try to remove it in the ward, the child starts crying when you do all these procedures. And when the child cries, there is thing called as tracheomalacia. You are not able to locate the tracheal stoma because it's always sucked in. So that is the difficulty when you are doing this in the mouth. So that the rectum is now take the patient to the dressing room at least, and then with all the preparations change the tracheostomy.
What you told, in a 3-year-old child, I had put in a T tube, cutting the horizontal limb, I had put a tracheostomy tube and sent him home from Srinagar. He had come. After 3 months, he comes back. I don't find the T tube. It has slipped into the trachea. So I had to do a bronchoscopy and take it out. That is one. Another person, 17 years old, I had put T tube and sent him. Somehow he couldn't come from Iraq. But when he decided to come, en route at Doha, he developed breathlessness and he was admitted in Doha hospital. The doctor was frantic and he rang me up. What have you done? I said, it is T tube. So it is blocked. He is gasping. I said, pull out the tube. How can I pull out the tube? I said, you just pull it. It will come out. But somehow they could clear everything. They got a CT done and all this. Then patient was shifted. I changed the T tube. I put a tracheostomy tube inside and sent him as stenting. And he really did well. Later on, we decannulated also. So these are few things what I'm telling. And now Monday I'm going to operate. This gentleman came from Yemen, army chap. We had done supraglottic laser excision completely. I had put a stent, that is Montgomery T tube. I cut and put it there. Now he comes after 2 years because he didn't get leave. And I examined, I found grade 4 stenosis. I got the CT done. I didn't find anything in the upper, and but outside the suture is hanging. So luckily, my radiologist, he had done little lower cuts, and I found out this tube is lodged in right main bronchus. And Monday, I have to do first thing is take out the tube, and then do this thing. So like this, we always burn our fingers, and we learn from our mistakes. Thank you.
And the aspiration is much common in children after doing a laser protection. So you have to keep these children intubated, with a laser tube for at least a week, or give a trial for you discharge the patient, make it sure, then we discharge. It's very common. Two of my kids got admitted in other hospital and got a call from there. They aspirated and died.
I would like to invite Colonel Dr. Karuna Datta to deliver a presentation. Dr. Karuna Datta has done her PhD Neurophysiology in 2016 from AIMS Delhi. She has done an advanced program in digital health and imaging in 2021 at IIS Bangalore. She has completed the 15 projects, including military funded project setup, Human Sleep Research Lab at AFMC Pune, India. And she has also developed a translational therapeutic model using Yog Nidra for chronic insomnia patients. She is involved in development of standardized family module to teach communication skills. That was granted copyright by Government of India in October 2020. She would be speaking on evaluation of excessive daytime sleepiness.
Thank you so much for the introduction, and I would like to first start my talk with the thanks to Dr. Ramalingam in particular, because he thought of this topic, and I hope I would be able to align this topic to the need of Voicecon. So, as you know, the topic is very interesting, of evaluation of excessive daytime sleepiness. And we have seen a lot of surgeries. We saw AI, we saw very happening things in the afternoon, and I have a very pleasant duty to make sure that you don't sleep during this sleep talk. Now, the important thing here is that this is something which the patient often comes with, or more often doesn't know that he has it, and you discover it during an interview. So hence the relevance, and I'll just take a short time to finish this topic in totality. So I come from here, where we have a accredited sleep lab from AFMC, where not only do we have a 2-bedroom suite, but we also have portable monitoring, since I am in the Department of Sports Medicine. So now this to start with, what is excessive daytime sleepiness? So as the word says, it is not sleepiness alone, it is excessive, and excessive is often categorized that it is inability to maintain wakefulness and stay alert during the major waking episodes, with sleep occurring unintentionally and inappropriately. So inappropriately in the sense that when the condition does not demand that you should be sleeping, and somebody says that I sleep off, is considered as excessive daytime sleepiness, a very, very subjective term. Now, what is important here is to go into the history, find out if recently something has happened that the sleepiness is more than what it was, or it has been right from, or exactly when did it start. Also, it is important that it should not be just for some days or some minutes or a very acute kind of a thing. It should be a sustained 3-month at least history. Again, this is a subjective terminology. You might find cases in very early pathophysiology who may be a 1-month history. And you must differentiate it from fatigue, because fatigue will not get resolved by sleep, but sleepiness will. So a subtle difference, lot of history taking can give you an idea. So the excessive daytime sleepiness actually results from two of the things, which can be a reduced nighttime sleep duration or a normal nighttime sleep duration. So if it is a reduced nighttime sleep duration, we have to think of some other pathophysiology. And if it's normal nighttime sleep duration, it can be either disorders which disrupt sleep or disorders with increased sleepiness otherwise. So most important thing here would be what is the time that the person is sleeping at night. Now, most of the time, the person will tell you, the patient will tell you that I sleep at 10, get up at 6. But when you ask for history, the person was lying in the bed at 10, looking at the mobile till 12, trying to sleep till 1, and got up at 6. So the estimation of sleep time comes from a history which the patient will give you once you are looking for it. And that's what it's important. Of course, there are objective parameters of polysomnography, home testing apnea, home sleep apnea testing, and actigraphy. But unless you find it out, you will never ask for it. And you don't ask for it, you will not hit the target. There are subjective parameters where you can ask for sleep diary. And as per the American Academy of Sleep Medicine, a sleep diary of at least 2 weeks gives us an idea. So you have to motivate the patient to write the diary for 2 weeks. I can assure you that if I didn't know the importance of 2 weeks and I gave a diary, I would have also written just the day before I was to meet the doctor, just scribble something and come back. But that will not clinch the diagnosis. And as we go ahead, we'll just see how. So this is a recent book which is in press, which actually we wrote, we have authored it too, and we wrote it specifically to reach out to all clinicians, because mostly we don't make sense of sleep medicine, whereas it is so crucial for a diagnosis. So I'm sure it will be released soon. And why I wanted to say that was because I touched this topic in detail there too. So is it only the duration of sleep which matters? A detailed sleep interview will give us other problems which may be there. Why is this coming, this hidden thing coming? I mean, no, my slide, I can see the entire thing, but here it's not showing. Okay, so you need to ascertain the comorbidities, and we are the diabetes capital here. So sometimes we don't even go into the history of comorbidities or the symptoms which may be hinting to comorbidities which are not identified himself by the patient. Then identify any other coexisting sleep problems. So first thing that we need to look at is the opportunity to sleep. Very, very commonly missed in adolescents. As I gave you an example where the person might say that I'm sleeping fine, and the parents would be convinced that the lights are off at 10 o'clock and he gets up at 6 o'clock, but he's actually only sleeping for 3 to 4 hours because there's a peer pressure of him to be on the social website or something, and he's waking up at night and making sure that he's in sync with the class. So opportunity to sleep is going to differentiate us, give us a clue whether it is an insufficient sleep syndrome, which the adolescents face, or it is insomnia. So if he's giving himself opportunity to sleep and he's not sleeping, is insomnia. Whereas if he's not giving opportunity to sleep, it becomes insufficient sleep syndrome, often resulting in excessive daytime sleepiness. And the sleep quality needs to be looked at. The sleep maintenance, he may be sleeping the right amount, but he may be waking up, frequent arousals. And most commonly things which might affect excessive, which may cause, is sleep apnea, shift work disorders, circadian rhythm disorders, narcolepsy, and so on and so forth as we go ahead. So, how do I go down now? Yeah. Yeah, thank you. So this is a table from my book, and why I want to talk about this is that the patient is only complaining of excessive daytime sleepiness when he comes to you. But you see the left side, reduced nighttime sleep duration, where it is mostly the cause is bad sleep hygiene, which can be so many things as severe exercise just before. I have seen some fitness freaks who would be doing severe exercise after they come back from office. just because they want to lose weight, they want to cure their obstructive sleep apnea. Nothing wrong in it. But if they are already sleep sensitive, they will have a problem in sleeping after that severe exercise. So just go into the history, and all you need to do is shift severe exercise early in the morning, prepone the sleep hour, sleep time just before 10 o'clock, so that everything matches. Then sleep deprivation, not giving enough opportunity to sleep, external factors, uncomfortable room, social commitments, and so on, and illness like chronic joint pains, cardiovascular, GERD, LPR, neurological and endocrinal disorders, which sometimes we miss. Then we have disorders which disrupt sleep, which is obstructive sleep apnea, central sleep apnea, periodic limb movement disorders, parasomnias, epilepsies, nocturnal frontal lobe epilepsy during sleep, GERD, endocrinal, respiratory, substance abuse, cardiovascular. And then we have some disorders with increased sleepiness. One of the most talked about it, narcolepsy, and other neurological like stroke, cardiovascular, and so on. So for obstructive sleep apnea, we know that there is already a change from sleep to wake, that the neural drive itself changes once a person is awake and when he goes off to sleep. So let's say if this is the wake where the genioglossus is keeping the airway, the upper airway patent, and the intercostals and diaphragm are working. During non-REM, this drive reduces, and on top of it, we have REM in which it further reduces. And finally, the fat, the neck circumference, and intra-abdominal fat, which will compensate it further. So why it is important? If you have a patient who doesn't have a craniofacial abnormality, doing a UPP will not help. I mean, we keep on hearing that the results are bad. It's not the results which are bad. It's the patient you have selected for the operation as bad. You may be doing an excellent procedure. The procedure may not be bad. So this is where there is so much of neural involvement here, where in fact one of the therapies now which has come up in US is a genioglossus stimulator for treatment of OSA. So we need to be holistic in identifying where the factors or what are the risk factors. So the diagnostic criteria of OSA is A and B, and this is also something which we often miss. So if you see A, presence of one or more of the following is enough. So if you see, it's a huge list: excessive sleepiness, non-restorative sleep, fatigue, insomnia symptoms, waking with breath holding, gasping, choking, bed partner or observer reports, habitual snoring, breathing interruptions or both, patient diagnosed with hypertension, mood disorder, cognitive dysfunction, coronary artery disease, stroke, congestive heart failure, or type 2 diabetes. So even if type 2 diabetes alone is present, any one of them is present, and on polysomnography he has 5 or more AHI, he categorizes into OSA. And this is the International Classification of Sleep Disorders, ICSD-3. So it is easy to say that one out of this with this is enough to give the diagnosis. Or if for any other reason you do a polysomnography or for a history that is of snoring or something related to OSA, and you find 15 or more, gives you the diagnosis. Now, is EDS possible in patients of OSA without arousals post-apnea? Yes. The person may give you no history of arousals, may give you no history of sleep breaks at night. He says, I sleep like a log. Of course, microarousals, sometimes the person doesn't come to know. But he says, I'm not going to the washroom, I'm sleeping comfortably. But you still might have excessive daytime sleepiness as the only symptom which may hint towards OSA, because if the arousals are not required, even if arousals are not required for termination of all obstructive events, the sleep fragmentation which is happening is enough to cause the excessive daytime sleepiness. And no history of sleep breaks may thus be reported, but polysomnography will provide the evidence because you will find the sleep fragmentation to happen. Again, the criteria is ICSD-3. What about OSA in children? They may not complain of excessive daytime sleepiness. In fact, all they will complain of is developmental, behavioral. Sometimes this come with excessive activity, hyperactivity, and you might miss it, though there may be an evident craniofacial abnormality or maybe a subtle craniofacial abnormality or other factors. Now, on the other hand, central sleep apnea, as the word describes, that there is no obstruction here, but apnea is causing the problem, and it will lead to arousal, it will lead to sleep fragmentation. And sometimes these patients may only complain of hypersomnia or insomnia. And the clinching diagnosis can be, if you do a wake time PaCO2, you might find that these people might have low PaCO2 during wakefulness. This is something which has been found out. It may not be clinching in all cases, but if you find excessive daytime sleepiness, you can put him to polysomnography and find out if there is any other cause. Circadian rhythm sleep-wake disorders, a word about them, because most of our patients nowadays are doing transmeridian travels, shift works. For ourselves too, we are on shift works, and that's why it's important to identify whether this excessive daytime sleepiness is because of a circadian rhythm disorder, which may be a change or a misalignment between the endogenous timing and sleep-wake schedule. Insomnia symptoms or excessive sleepiness, significant impairment in functions, and one of them is a delayed sleep-wake phase disorder. Why I brought it out is because a lot of ENT patients are this adolescent age group where they come with adenoids, and you see that these patients are also complaining of excessive daytime sleepiness. It's a big history of not doing very well in school, poor academic performance, and they might be having this devil sitting there too, which is a delayed sleep-wake phase syndrome. The thing is that the timing at which they sleep is quite delayed, and when they would like to get up is quite delayed. Just because they have school the next day, they are waking up earlier, and that is why they are deprived. So go for this history, try to find it out if it has been for more than 3 months. In fact, in post-COVID, many students will come to you saying of these features, because all this while they were just switching the attendance, marking the attendance online and going off to sleep. And now when they have to actually go to the school, they realize that they're having this kind of a deprivation. So evening chronotypes, genetic factors, social factors, exposure to light are some of the risk factors, and which worsens if they do other things which might deprive, like shift work, jet lag. Points to remember: differentiate from a normal sleep pattern. Go back, whether this person always did this or is it a recent development. Look for the duration. 3 months is crucial. It's not 1 or 2 days. And distinguish it from other disorders like insomnia, which we just discussed. The sleep initiation and maintenance are improved once you give them time to sleep. So on a Sunday, this person will be waking up at 1 o'clock in the afternoon. And that should clinch the diagnosis, that if allowed ad libitum, this person is sleeping longer, whereas otherwise he says, I'm going to school every day. But in the school, his productivity is dipping down because he can't concentrate, he's sleeping during the daytime. Shift work, excessive sleepiness related errors and accidents would be seen associated with mood problems, increased fatigue, and impaired sleep quality. Jet lag syndrome, if more than 2 time zones in the recent past, look for this. And it said that approximately 9 to 11 days, depending on whether you are on the East Coast or the West Coast, you're traveling to US, which side, takes for the jet lag. But if it still remains after that, you need to worry. And that is the criteria as per the ICST classification, that there should be a complaint across at least when the person has traveled for more than 2 time zones. Associated impairment should be there, like gastrointestinal disturbance within 1 to 2 days of travel. And this disturbance should not be explained by any other thing like recent onset of medications, substances abuse, alcohol, etc. Narcolepsy, we have heard about this, and the catch point here is cataplexy, which may be evidently present. In some cases, it may be absent, but you will have REM episodes in the morning, very rapid onset. And if you do a test called multiple sleep latency test, it clinches the diagnosis. Parasomnias. Now, why it is important is, I would not like to go much into detail of everything, but why I want to tell you is, if your patient says that I'm not a problem, I don't have a problem with my timing of sleep, that means there is some problem in the quality. And that is where you need to investigate. Is it the apnea? Is it movements of the, is he having some movement disorder? Is it some non-REM behavior disorder like sleep talking, sleepwalking? Is it a REM behavior disorder like dream enactment? Is it epilepsy? Is it some associated disorders which is causing him not to have a good quality of sleep? And that should clinch the diagnosis, or that should help you in the evaluation when you are evaluating the patient. So as I just said, disorders of arousal, REM behavior, restless leg syndrome, and the restless leg syndrome is very, very commonly seen in India. Ladies, where they tried everything, even on BiPAP, they kept on saying, no, I'm still not good, not good. And you find out that there's a restless leg syndrome which was sitting there. All that is required is iron supplementation. The first line of treatment. So simple to do, but mostly not done because we don't even think about it. Periodic limb movement disorder, again, I think what one must remember is if the patient is giving you a history or the mother says that he moves in the bed, just remember to tell your sleep study people this history so that they can put an extra leg electrode on the during the test, or they can do a leg actigraphy. That's why this history is very important. Insufficient sleep syndrome, we just covered, where the adolescents have a problem. So I'm not going to go through this again. This is again ICST 3, where they have said that it should be taken in detail, differentiated from chronic insomnia, where adequate opportunity to sleep is there, and in insufficient it is not there. So the bottom line is that sleep disorders may be solely a sleep problem or may be associated or aggravated with other conditions. So do rule out other causes. GRD and LPR sometimes, in fact, I've highlighted this, that sometimes the symptoms are only excessive daytime sleepiness. The person doesn't have complaints of heartburn, etc., etc., but may only say excessive daytime sleepiness because of the arousal that the person will have after a reflux event at night. So we must look for that. And sometimes in psychiatric disorders, you might find hypersomnolescence, and that may be very, very disturbing because the drugs cause hypersomnolescence, the patient is not feeling well, he's not performing well. And again, that is the place where you should also look for other disorders like we just named, whether they may be coexisting. So we come back to that same diagram. Remember this with excessive daytime sleepiness. Just identify first, is it the sleep duration which is affected, or the sleep duration is fine? If it's the sleep duration is fine, then the problem starts, because now we need to identify what is causing the problem in the quality, or is it some other disorders where it may be, causing this excessive daytime sleepiness because of the breaks which the person is not able to make up. So this I just wanted to highlight in the end, that you can have wake and sleep, and most of the problems happen when the shift happens. So from wake to sleep, either non-REM to REM, REM to wake. And just a little idea, like I had a patient who said that the mother used to say that the patient talks irrelevantly. And this is like around 10 years back. And this patient was being looked after. They were an elite group, so were very, very aware. They went to many neurologists, many people in a small town, and they were told that it may be an epilepsy, it may be a normal non-REM sleep disorder. But one thing which she kept on telling was that the patient talks in the morning, sometimes in the morning, sometimes in the first part of the night, and that generally will not be a non-REM disorder, because non-REM sleep talking happens in the first third of the night. If you remember the sleep, that chart, the first 1/3 of the night is non-REM intensive, and your REM patterns start to increase as you go later into the night. So this requires an extensive investigation, because it just might be a nocturnal frontal lobe seizure, which may be manifesting as a talking episode, or a movement which movement is not noticed. Talking is something which the mother could pick up. So just keep a little bit of physiology in the background when the person is talking about sleep problems. So monitoring can be by staging, and accordingly, if you are suspecting cardiovascular, if you're suspecting a PLM or anything, please make sure that your systems and the sensors are in place. Take home message is look for important symptoms, take appropriate history, complete relevant questionnaires, take the case as a patient as a whole, and if you don't want to take this sleep interview, just ask the patient to fill this diary. I've written this specially for them because I saw them suffering so much. They will be able to identify what's the problem. And they can come to you exactly saying, Doctor, I think I have the PLM type of history. So we can refer to this. Thank you so much.
Thank you, Karuna. I have one question. Tell me the smartwatches which are available, like Apple smartwatch and Fitbit and all those things. Are they reliable? Because I didn't find anything reliability about it.
I think that's the best, that's a very, very good question that I would say. Now, if you would have asked me this question around 7-8 years back, I would have said, don't rely on Fitbit. But Apple and Fitbit has really invested now, and they have come up with good algorithms. For a patient, I would still say no. But for general public, where you're not expecting a problem, it may not be a bad tracker. But when you suspect a problem, the problem with Fitbit and Apple watches is that they err. If it's good, they'll make it very good. If it's bad, they'll make it very bad. That's the little problem. And I think they will, I'm sure they'll fix it. But if a person is normal, it's fine, but I would not recommend for patient. That's all.
For example, for walking and all, it is fine, showing how many calories you have burned, how many kilometers you have walked. But night sleep, for example, I wear. Since last 10 days, I have not slept, as per a Fitbit. But I have slept at least 6 to 7 hours.
Because your heart rate must be high. Or
no, my heart rate is, BPM is below 90.
So the heart rate variability they make. They have different algorithms.
What I feel that you keep turning here
Shifting,
and there,
yeah.
shifting, that will show that it is not, there is a break, and it will not count as continuous 2 hours sleep.
Yeah.
For recording.
Yeah.
This is what I thought.
I'm sure. Because, sir, even for Fitbit, like, why Fitbit? Even for a actigraphy at times, actigraphy is a known instrument for screening. If a person is insomniac, a person will just lie like this and you will not find insomnia in that actigraphy record. So similarly, if you're tossing and turning too much while in your sleep, which may be because of whatever reason, your Fitbit will keep on telling you that you're not sleeping, though you were probably in N1, not very deep sleep, N2, but your quality may be bad, but you have had your quantity. So if a person is having a problem, not recommended.
And but what the diary, sleep diary?
Yes. So, ma'am, sleep
Is it available?
Yes, definitely. There are many free versions which are available. One of them, which is commonly used, is an American Academy of Sleep Medicine diary, which is 2-week diary, commonly used. You can also, if you want, ma'am, I can share my diary. I just want it more elaborately written by the person, so I use that. Whereas in ASM diary, it is just yes, no, when, and all that. So there are many versions available. But the bottom line is, it should not be a recall. Person will do it on the weekend saying, Acha, Monday ko when did I sleep? No, you have to convince the patient 2 times a day, immediately on getting up and just before sleeping. At least he should feel.
He can send a photograph, daily record.
Yes, I do that.
Daily record.
So he can't escape it. So when patients cannot write, we appoint somebody in the family.
We'll discuss that when she comes, because we are running late for quiz. It's already 6:10.
Thank you.
I would like to call the chairperson to please felicitate the speaker, Dr. Manish Munjal. Dr. Ashok Purohit. Dr. Karuna Datta. I would like to call Dr. Ramalingam to please felicitate the chairpersons. Dr. Bhavna Bhan. Dr. Bhavna Bhan. And Dr. Ritika.
Now we'll have a little bit rescheduling. Ma'am, do you mind? We have one group. We'll just come over here. Ma'am, इधर आइए.
So to end it up, we'll have the postgraduate quiz, and I promise everyone that I've been issued a lot of chocolates, so there'll be a lot of chocolates to be distributed as well. May have the audio-visual gentleman kindly switch on my laptop to this. And we have 3 teams, and I have someone to help me do the scoring. So we have team A, B, and team C sitting in the front rows.
A this side. Team A. Team A. Which is team A? Ma'am C. Come this side. And team B. And team C. Anyway, it doesn't matter. Wherever you say.
ये अभी लगा के गए थे वो लगा के गए वो हीट ट्रीटमेंट देखो नहीं ये चलेगा This is the last event of the day. So, can I have the score up? What's your first name, please? Jamil. Double E-L. Double E-L. Okay. So, Jamil is going to help me in this quiz. I know there are a few people, there are more chocolates, but let's see, you have to still answer to get it. So, it will not come for free. And we just want to have some fun. It's not very serious, and it's not, the answers will also be there, of course. So don't take it too hard, but then there is a set of prizes and certificates to be won. So this is team A. I just request you to kindly take your mics in your hand and introduce yourself quickly. Just take the mic. एक और mic है? तो mic को transfer कर देंगे. Oh, corner mic. Yeah, so team A, can you just introduce yourself? You can just keep sitting and just tell yourself. Yeah.
Good evening, everyone. My name is Dr. Abhinav from Maulana Azad Medical College.
And you're in which year? You're
third year, final year student.
Okay, fair enough.
Hello, I am Dr. Ditiksha Patel from Maulana Azad Medical College, third year resident.
Dr. Anju Fageria from Deen Dayal Upadhyay Hospital, third year.
Hello everyone, this is Dr. Vinny Nayak from Deen Dayal Upadhyay Hospital, third year.
Good evening everyone, I am Major Shubhankar Tiwari from Base Hospital, final year resident.
Good evening, I am Sajal Lieutenant Commander Bishwajit Das from Base Hospital, Delhi Kent, final year resident.
So you all know your teams, you are A, B, C. So there are going to be 6 rounds and 30 seconds for questions, so you'll keep it fast. Scoring, you'll get +10 for a direct question. If it passes and goes to the next, it's +5. So Jamil, kindly note. And if it's out of turn or it's a prompt, so audience, if you want to defeat some team, you start prompting them. Okay? So I would request you not to do that. And that will be a -5 for them, whether you like it or not. Answer sahi ho ya galat ho. So that is the way, unfortunately, the team works. And there will be audience questions, and if it is not passed on, From C it will go to A, and you understand that circle now. There will be audience questions as well, if when the need arises. And I know I have sat down and made the questions here. Whether you like it or not, I am right. Okay, so no arguments on that. I'll be right. You have to just take it, lump it, and even if you feel no, ye kya kar diya isne? Okay, so that's the way it works. Okay, so these are the rounds which you're going to have. So are we all ready? Ready? Okay, okay. And you can remember decide who to this thing. Timer, are you ready? Okay, great. So we'll go with the first round, and that is anatomy. And the first question will go to team A. So here it goes. Yeah. No, I'm just asking the timer if he's okay. The team timer is the critical one. Achha, how will you sound at 37 seconds over? Okay, any bell? Any bell or no, something you will make some racket? Make a clap or whatever. Yeah, so he'll say time. Okay? Yeah, he'll say time up. Time up. Yeah. So this is a cue. Okay. So the first question for team A starts here. Which of these spaces is not associated with the larynx?
Space of Gillette.
Okay, space of Gillette. Full marks, and must say they started off with a fantastic note. And what is space of Gillette?
There are two retropharyngeal spaces of Gillette, which are divided by the paramedian raphe.
So fantastic. So first, full 10 marks to them. And so where are these other ones? Audience, which is space of Boyle? Audience, or anyone? Okay, which is Tucker? What is Rinkies? Fair enough. So first of all, let me start off with the chocolate to gentlemen here. So, well done. I think we all deserve a bit of chocolate. Okay, next, are you ready for your question? So the direct question to team B is, here it goes. Identify this structure. There are 4 of me in each larynx. They get tired as they age. They work less as they age. And they have a potential to be multipotent. What is this organ? What is this structure? Timer, you have to. Okay, timer, incorrect. Okay. How about you? For 5 marks, you have a chance to give a correct answer. So 15 seconds for a pass question. You want to try? No. Okay. Anyone in the audience? They said wrong answer. Okay. Anyone else? Which place has got stem cells in the larynx? Which has got a cell which can divide and form into multiple shapes. So this is the macular flower, and there are 4 of them, and these are fibroblasts which are accumulated here, and they function very well in infancy, and as they grow up, they sort of atrophy, and they are known as now as the potential stem cells of the vocal cord. And what is the last clue? They are multipotent. Okay. Team C, this is a direct question for you. What and where is the sound organ of birds? We all have larynxes. The birds must be having them. But then where and exactly what is the sound organ of birds called? Gizzard. Female. No, not here. No, not here. Not here. Out of turn, yes, negative marking. Yeah. The negative marking is just you're not asking what to guess. So they said negative, no, negative marking that. The negative marking is if you answer now out of turn. Or there is a prompting? Pass. I have to eat a lot of chocolates, I think. Okay, audience. Okay. Picture से. What is it? Very nice. Wonderful. Anything else you want to add about it? So the answer is syrinx. So the answer is syrinx, and it's, it's a very interesting thing. And how it works it is just about the carina, as you rightly said. There is a larynx in birds, by the way, but that's not where the bird sings from. So songbirds can have two tones at the same time, because you see there are two of these larynxes equivalent at the carinal level. They're known as syrinxes, and when they sing, they can have dual tones simultaneously. So that's syrinx for you. Okay. Next question is for the audience. Simple question. For anyone can answer. You're also part of the audience now. Identify the structure. I have been referred to as the pomegranate. I symbolize a sin, and some people think I'm a disorder. You can just guess. Yeah. Adam's apple. So Adam's apple in certain cultures is referred to as a pomegranate. Certain places it is referred to as apple. And actually, it's supposed to be a sin. The Adam's apple, eating the apple. And some people think it's a disorder. And what is the reduction of the surgery of Adam's apple called? Is there a surgery to reduce this? It is. Okay. So this is the Adam's apple, the laryngeal prominence. Okay. Now what we'll do is we just have the score. After first round, we gave 10, 0. Okay. There's a lot of catching up to do. Don't worry. Okay. So round 2 is about history. Now, if you know it, you know it. You are free to guess. There is no negative marking for guessing. Chocolate for what? Adam's apple. Very simple. So catch. Good. Well got. So 10, 0 is the score so far, first round. So we're going to the second round, and the second round is about history. And there will be a person you have to identify. So there are two parts of more or less each question. Identify the person and his or her contribution, or the question will be written there. Okay? Should we start? Okay, ready? Team ready? Timer ready? Sorry? No, ma'am. We let the teams answer first. We let the teams answer first, ma'am. Okay, next team. No idea.
Sir, is Dr. Bose responsible for making most electronics?
Well tried. Well tried. Anyone in the audience? Dr. Sachin? Any guesses? Okay. Wonderful. And now Dr. Why? Dr. Patel, who he is what? Anyone? He is the guy who founded who discovered the CO2 laser. Because he is from Pune. He is from Pune, and in Bell Labs, he is the guy, Dr. Chandra Kumar Narayan Bhai Patel. He developed the CO2 laser at the AT&T Bell Labs in 1988. Very, very famous, this thing. And this picture has been there in many of the Voicecons. Okay, next team is, are you ready? Okay, now the direct question to team B. No, so कुछ हो रहा है. There are two cables there. Okay. Okay, the direct question for you, here it goes. हिस्ट्री तो पढ़ना छोड़ दिया सर आजकल व्हाट्सएप और these are textbook pictures, laryngology textbook pictures. No idea? So next team C. No idea. Anyone in the audience? Yeah. Because of okay. So you must have heard of McGill, and McGill is famous for multiple things in anesthesia and ENT both. The airway, the forceps, the McGill's forceps. You must have heard of McGill's forceps? Yes. You've heard of, and what is there in laryngology of McGill? The straight direct laryngoscope, the straight blade is from McGill. Okay. So McGill laryngoscope number 2. Okay. Team C, are you ready? Ready with your question? Identify this person. I think they are trying to resemble people in this conference hall. And his contribution.
I guess you need to give some clues.
Yeah, clues, okay. Clue. But it will be unfair if I just one team. Okay, it's a difficult one. Doesn't matter. This is in Europe.
The Evan Bear.
Next team. Anyone else?
Moral vacancy.
Yes. See, it's not that difficult. For people who have read their books. Yeah. Great. Wonderful answer. Wonderful answer. And he, incidentally, is the founding editor of Journal of Laryngology and Voice, which was known as Laryngology and Rhinology initially, and later on became Laryngology and Otology, and then it's so this is okay. Now one question for the audience: identify this gentleman and his contribution. Slightly older version of his. Now this gentleman is, I can give a hint to everyone, is known for a particular kind of optics. Yeah. So this is definitely, what did he do? Yeah.
Regional endoscope.
Yeah.
That lens system which is there.
Yes. So that you are absolutely right. Yeah. So he was the founder of, and what would he, another thing he was famous for? Developing something. And why did he do all this? Was it for medicine? Any guesses? So I'll give you a hint. He developed the zoom lens as well. So why did he develop the zoom lens? No, to watch cricket. Okay, so to watch cricket. So the starting point was he did this to watch cricket. So we are at the end of second round, and what would be the scores, please? Score.
Team 10, another team 0.
Come on, yeah, you have to pick up. And what is the audience score? Audience would be 40, I guess.
All remaining audience.
Yeah, all remaining audience. We got wonderful answers from the audience. Okay, we got a bit of a clinical sort of situation. Again, these will be syndromes or something which you would have heard of somewhere in the books. Okay, so we start off again with the same order. Okay, here we go. What is Bryce sign? Identify the condition associated with it.
No, don't look at the
Sir, it is present.
Google.
Sir, it is present in laryngocele.
Okay.
Whenever there is a swelling due to external laryngocele and we press it, there is a hissing sound.
Okay. Anyone has a better answer? Absolutely right. We give 10 marks to them. Good. Well done. So this is usually in these external and mixed laryngoceles, and it's essentially when you press from outside, there is a hissing sound. Okay. Next team, are you ready with your question? Okay. What is Chevalier-Jackson sign?
Sir, it's in the PA plus the connection. Secretions are there.
Okay. Okay. It's that be so. What is it associated with?
There could be malignancy, early malignancy, that can lead to.
Okay. Anything else? It was specifically described for. Anyone can improve this answer?
There will be an associated dislocatility of the upper ecophageal stricture, sir.
Any other specific condition this was associated with? No, this was not for malignancy, but I'll give 5 marks to team B for identifying the sign correctly. And big hand to them, very well identified. And this was for diverticular, Zenker's. This was a Zenker's, and this essentially was a sign where they saw pooling of saliva in the stasis observed on mirror laryngoscopy in cases of Zenker's. What is rising tide sign? Anyone? This is not part of the marks. So rising tide sign is a similar sign where they see that the pooling is increasing in this thing. Generally, it's done in the post-operative part of Zenker's to see if it's causing a stricture. Okay, the next question is for whom? Is for team B or C? C now. Okay, direct question to you. Good. Congratulations on opening your score. Well answered. What is Gerhardt's syndrome? Identify the condition associated with it. This is all laryngology, by the way. Don't start thinking of anything else. Pass. Okay, next. There's no hint in this. Okay, team B. Anyone in the audience? Okay, I'll tell you the association behind it. This is not for marks now, okay? Not for chocolate either. It was described when the time syphilis was common. Okay. So what condition in which a person can speak well but has dysphonia or but has stridor, and this was usually a neurodegenerative disorder following syphilis, and you had bilateral vocal cord abductor paralysis, and now even bilateral vocal cord paralysis because of any neural lesion is referred to as Gerhardt's. The original condition it was described was syphilis. Okay. So now we have one question for the audience. Where in ENT do we encounter the Z line? Who said that? Yes. So where exactly? And what does it signify? Good. So this is not good for your Barrett's line, but then I think this was mentioned today by someone in the talk. Yeah, it was, but it was already there. So okay. So what are the scores now, please? Please.
Team A 20, Team B 5, and Team C 0.
Come on, Team C, you have to pick up. Okay, and well done, Team A. You're doing well. Okay, now we go to the next round, and this is on some anesthesia because we share a common area. So it may not be that difficult, but then you need to answer quite quickly. So the first question goes like this. We are midway through now. Identify the equipment and its usage. No prompting, no prompting. Yeah, T-way is of it.
Jet ventilation system.
Can you just expand on that?
Sir.
Anyone has a better answer? A better answer? No, not the audience. We come to the audience. Okay. We'll give 5 marks to them. The answer is right. It's a type of a jet ventilation. What does it refer to as? Sanders. Okay. Sanders jet ventilation for rigid bronchoscopy. I thought it should be a simple question, but very well, at least they identified the thing. And basically, this is a manual. If you see this is a manual switch which they press intermittently. And now you have automated systems, but this is the initial systems they used to have the person anesthetist doing this. Okay. For direct question for Team B. Identify the equipment and its usage.
Loudly, loudly, please. Time up. Next.
Intuition. Want to improve that? HF. Anyone in the audience can give you the correct answer. Direct answer. Say again.
Nasal candle oxygen.
Oh.
Measure up to 40 liters per.
Fair enough. I'll not really give it, but then yeah, you're all going around that same area. If you see a particular word here, humidification. Now any hint? This is Thrive. You heard of Thrive? Transnasal humidified rapid insufflation ventilatory exchange. Okay, we've been having talks on Thrive, and this is how you have this humidifier here. You can see the humidifier now. Humidifier heating system, and it's going up and it's going and being delivered through the mouth. Why is it used? Very nice. So it's a way of increasing the apnea time in a laryngeal situation. Surgery. Okay, fair enough. Which team question was this? This was B's. अभी किसका है? अभी C का है. Okay. So ready? Identify this device and its usage.
It's a laser safe endotracheal tube, sir.
It's a
laser safe endotracheal tube, sir. Used for in laser surgery, sir.
Okay. Next team.
So it is used for monitoring of recurrent laryngeal nerve. It's a nerve monitor endotracheal tube, and it goes and sits near the vocal.
So 5 marks to them. Correct answer. Loud hand for you guys. Okay. Well answered. Okay. So this is a electrode which you can see, which is being wrapped around, and it goes around the bulb, and this is where it touches the vocal cord. This is the bulb below, and this is essentially for monitoring left and right separately both vocal cords to measure to see if there is any problem with the recurrent laryngeal nerve intraoperatively. Okay. So well answered. Okay. Next question is for whom? Oh, this round is over. Okay. This is for the audience. Identify the equipment that is used. Simple question. Who made this? Who made this? Who discovered this? No, it's not Google. The answer is right. LMA. Simple question, but who made this? So this is one doctor who still is alive, Dr. R.P. Brain, and this is the actual model which he made. He actually did a lot of studies where he devised multiple sizes, and he cut an endotracheal tube and an oropharyngeal mask which comes on the nose, just the nose one, and he mixed the two and he made this device. And this gentleman is still alive, and this is the thing. So what is the score after 4 rounds? Can I just have a quick?
Green is 30 point, green 5, green 0.
So 30, 5, 0. Come on, buck up. Okay. So well done, teammate. Now let's go to the next round. I think this should be number 5 round. Okay, let's see. Some gadgetry. We all found out a lot of gadgetry. So you see how everyone, you know the men from the boys from the price of the toys. So identify this device and its usage.
So it's I can describe it. So it's used for medialization, and we can even insufflate and customize the degree of medialization that we can have.
Anyone can improve his answer. So there's so many. I've showed you 5, 6 types of implants already. This is not one of those. Anyone in the audience? No. So kindly give this team 5 marks. Beautifully answered, well answered, and good. So this is known as A-Prevent. This is VOIS. Okay, vocal implant system. And how it works is that you put this operatively, you put this implant on the vocal cartilage, and then there is a sort of window. This is a port where you inject saline. This can be done immediately, intraoperatively, or even post-operatively. You can even do it later on. You can say, oh, if it's less, you can later on even inject the system. And this is how it's injected from this particular port. And it comes in standard 3-4 sizes. And there's a silicone balloon inside of a shape. It will just assume that shape. And of course, I also haven't seen this device, but this is a recent device which has come in the last 5 odd years. And right now, the trade name is A-Prevent Vocal Implant System. And well answered. Very good. So this was a question for them. So 5 marks, please give it to them. Okay. Had you given the name, you would have got the full marks. Well done. Okay. So next team B, are you ready? So you have to identify this device specifically and what are its usage. You might get 1 mark for it. It's the retractor, yes, it's steel also, but you have to be a bit more specific. Next team, team C.
Sir, it's used in image guided surgery.
Okay.
So it is FK retractor used in transfer robotic surgery.
And anything else?
Sir,
what does FK stand for?
Sir,
so first, please give them 5 marks and a clap. Okay, good. This should have been answered. So this is an FK retractor system. And what does FK stand for? This will be for the chocolate. So this is the way, even I can't pronounce it. So this is a retraction system which is used in robotic surgeries. And these are the FK retractor set. And I think he mentioned it during his talk as well, Dr. Devas. I think he mentioned about the retractor. And this essentially is a frame, and you have various types of these retractors, including these number 4 are cheek retractors from the side. They come in. So now whose direct question is there? C. Okay, team C. Then the direct question for you is this one.
Made of helium oxygen, sir.
So I want the composition. Heliox is helium and oxygen. Okay. 1 mark.
This is made of 90% oxygen, 5% helium, sir.
I'm sure people, the seniors won't know. PGs, we should know the composition. And was it used in laryngology? Why are we talking about it? Time up. Next. Team B. Why is it used in laryngology? Okay. Okay, I see a hand going up in the audience.
For increasing the apnea time.
Increasing the apnea time. Sir, Dr. Manish.
Combustibility is less.
Okay, no. Anyone else?
Airway obstruction.
Who said that? Yeah. What is the role in airway obstruction?
This is the.
No, he's coming there. His hands are going there. he's spinning with his hands. So what happens is since the characteristics of fluid motions of heliox is very different, it doesn't cause stridor. The flow becomes more laminar, and there is less turbulence in the airway, and it is used for treating in cases of pediatric stridor as one of the modalities. So I'll quickly go that. So it reduces. This is the composition. Okay, you should have been around this. It reduces the turbulence of airflow, results in laminar airflow, lower airway pressure, and even in cases of obstructive lesions, it has been used. Heliox has been used to get time. Okay, we are through with this round. Okay. Next question is for the audience. Identify this investigation. What is it? Sorry? Yes. I have to give one to the micro.
Somebody said from that side also.
High definition. Yeah. So, what is it exactly? Manometer. Yeah. So, can you interpret this? What is there where?
So this is a very static gauge you can see between the upper and the lower.
Where is the upper? Where is the upper and where is the lower? Now I am asking for trouble. So you're absolutely right. This is where the wave is passing through, and somewhere here right now, this is the lower esophageal sphincter, and this is a high resolution esophageal parameter. So,
And that's the reflux.
okay.
And it actually requires a colored manner.
Yeah, that you see only on a dynamic thing. So now, what is the score? We'll come to the score.
Score is 40, 25.
So big hand for team. Very well done. They've been answering very well, and they've picked out some questions which are being passed through to them, and even on their own, they've been doing very well. Fantastic. So this is the last round. This is on procedures. Okay. So each of them will be, you have to identify the procedure or the name which I will be mentioning and why it is used. And okay. So let's go with you first. What is Coleman's technique and where is it used in laryngology? Okay, I'll give a hint for it's probably in this the course of this today's lecture it was shown by someone. Epiglottic filtering. She was listening to you. Anything? It's got something to do with injection laryngoplasty. Anyone? Now this is the open hint. Yes. The answer is fat harvestation. The technique of fat harvestation, centrifugation, and injection is known by Coleman's technique. He is a plastic surgeon, and this has been used all over the thing, and it's been, I think, shown in the injection laryngoplasty thing. मिल गया Google पे? मिल गया. Google पे है ना? ठीक है. I mean cross check. Come on. So it is also like ये तो खत्म हो गया था. So this is also known as lipostructure. They call it lipostructure, but that of course is probably a brand name. But what we basically know is that harvesting tissue, making it into small particles, centrifuging it, and then re-injecting is known as Coleman's technique. So now the next is team B. B, direct question. Okay. Okay, the team B, direct question for you. What is and where is this particular method used? Koharat method. This is not a very new method. It's been there for a while, and very recently some modifications have been described. Any hint for everyone? Okay. Maybe that's not a good hint. It's used in a post-laryngectomy situation.
It's a strategy for patients who are having dysphagia, sir.
Come on, you have to be creative. You can have exercise on creativity.
Method of swallowing, the technique.
So it's not. So we all have heard of tracheoesophageal punctures, and we have heard of Provox placements and all. So there are two ways. One of them is you put anterograde. There is one which you put retrograde from the mouth. So that is known as Fukuhara's technique, and there have been certain modifications of it. And the one in which you put a fiber optic and you go from the mouth is known as Fukuhara's technique of tracheostomy. The next direct question is for team C, I guess. Okay. Oh. Identify the maneuver and exercise being done in the picture below and its role. This is a bit of a tough one. It has something to do with solving. I'll give a hint. So we don't have.
So it's the tilt
in
which the tongue is tilted towards the stronger side, such that the bolus is passed towards the
next team. Which muscle? What do you do with this maneuver?
So we ask the patient to press the tongue
and then
increase the tone and then relax it and again increase it.
Well tried.
In Sterling rehabilitation.
Yeah, that I'm telling you. So.
And then the tongue between the cheek maneuver when you bite, tongue between the teeth, sorry.
And? No. It's the next one to Mendelssohn. There are two of these techniques. Who said that? Yeah. One. This is a Masato maneuver. And essentially what they do is they hold the tongue and then just ask them to swallow it. And this is important to increase the muscle tone of the tongue as well as, and it's done repeatedly. It was a bit of a tough one, but then well answered. Okay, now what's next? Okay, whoa, now we have just two more questions which are left for the audience now. So this was a tiebreaker I had kept. Okay, what is the full form of SLAD R procedure and its usage? No, we don't know again. Tiebreaker. SLAD R and its. Okay, team C. More try. You must have heard of these procedures. They are in the textbooks. R stands for reinnervation. Now. Superior laryngeal. Anyone else? Very good. So this is selective laryngeal reduction, de-innervation, reinnervation. Is what is it used for? Yeah. Good. Well answered. Oh, good. So, just one last question. This should be a light one for the audience. So, which position is this? Okay. And what is this based on? Fair enough. So this is a simple one. I just ordered. These are three axes. You have to line the three axes, and you have to do that. Well done. Sorry. So thank you all for your participation and involvement. Can I have the final scores? Though I think I will know the scores. So there should not be a. Big hand for team A. They really answered some very interesting questions, and I was really happy that you answered about that incredible plastic implant. Very nice. So, what do we do next? We have to just request the organizing chairperson himself to come and congratulate these teams, bless the youngsters, and give them some prizes.
You know, they didn't want to participate. I pulled them. I said, you have to come. And they have won the prize. What do you think?
They are from Martina.
Yes, congratulations. And you'll get a tattoo. You are coming tomorrow.
So now we know your name, no? That's why we write it down. Second prize, please come. I think you see, well, good. No one loses actually. It's just a question of chance, and it's just a question of getting the right thing in your head immediately. And keep it up, all teams. Thank you very much.
Thank you, ladies and gentlemen. It has been a wonderful day today. Rather, till 7 o'clock, we are all stuck here. But Rakesh, I think he made our day by posing difficult questions which I didn't know. Many of them, almost 98% I didn't know. And these youngsters, they could answer. So they are studying, we are graying. That is the problem. Anyway, thank you very much and hope to see you tomorrow morning with full strength. We'll have we have 2 orations also, and then we'll have hands-on dissection. So all the best and sorry for the delay and enjoy your weekend evening. So tomorrow again we meet on Sunday morning. Thank you very much.
So we have a consolation prize for Dr. Ramalingam.
Oh, that's great. So I think I'll give it to my organizing secretary. Oh, thank you. I think organizing people, they require ये और दो दे दे यार स्कोरर तो ये ले लिया ना मैंने दे दिया मैंने दिया तो फिर मेरे को दो और नया पकड़ थैंक यू वेरी मच आज बाकी तुम्हारे लिए हाँ amazing questions really Rakesh as usual you have made the conference a great success. This is the last innings and you scored 6er. Thank you.
We need to go back to school.
Recording stopped.